Good morning, everyone. Welcome to the first edition of the uh, Royal London Paediatric Update course for GPs. Really nice to see all of you. And I can see many more of you are joining us. So we're just going to do some introductory talk. I'm going to go through the proceedings for the day. We have a few speakers who will say a few words, and then we also have a couple of our delegates who will talk, and by 9:30 we should be going. So let's start with the presentation. I would start with a big thank you to all my presenter colleagues who've really worked hard, and without them this course was not possible. But at the same time, that's 8 GP moderators: Dr. Philip Bennett Richard, Dr. Robert Davidson, Dr. Gupte, Dr. Dattani, Dr. Dave Shaw, Dr. Ali, Dr. Myers, and Dr. Ling, who have really taken their time out of their busy schedule and helped us out. A big thank you to all of you, because you've given us the chance to register on the first ever event, and I promise you this might not be the first, but many more to come. A big thank you to all my GP friends, colleagues, and GP administrators. The number of phone calls I've done to them, hassled them to promote the course. A big thank you to all of them. The course will not run without Jeremy, who's sitting with me. He actually is running the show. I'm just talking here. A totally IT illiterate person. Rajiv, who did the website, and Ikramul. And last but not the least, a big thank you to the two pillars of the course, Shruti Ganatra and Dan Gibney. Without both of them, I don't think we would have gone anywhere. So big thank you. A quick introduction. So we'll have Dr. Murthy and Dr. Armstrong, my clinical directors, who will speak, followed by Dr. Philip Bennett Richard, our boss from Tower and Hamlet, who will say a few words. And then we have Shruti and Dan, who will talk about pediatrics from a GP trainee's viewpoint. And we had a small surprise. We have 5 of our delegates who will say a few words as to why they chose this course and why they decided to attend. A real quick one, the course format. I've sent the email, the details about the format, but each session is 45 minutes. In each session, you have 3 talks, and the order of the day is, we'll start with a poll for most of the talks, a live poll for 30 seconds. After that, there will be a pre-recorded video of the talk. The reason for the pre-recorded is so that all the presenters who are there can interact with all of you when you ask them Q's and A's through the Q's and A's format on Zoom. So please use the Q's and A's format on Zoom. And once the recorded video is played, the moderators will screen the questions on the Q's and A's and ask a couple of questions. Some housekeeping rules. IT is not perfect. We've got a lot of backups. So if there is a bit of a lag, please bear with us. We've been testing the IT speed throughout the last week. So we should be fine. And apart from that, we do not expect any other problems through the day. A quick one about Zoom webinar for the delegates. We have polls, fun questions. Please participate. That's a way of us communicating with you, because as delegates, we can't see you and we can't hear you. Please use the chat function judiciously, just for logistic issues. The Q's and A's, as we've said, the moderators will go through along with the presenters. They'll screen the questions. The presenters might be able to actually answer quite a lot of questions on the Q's and A's. If you like a particular question on the Q's and A's, please upvote it, and the moderators will pick them up. And the questions which are screened through will be used at the end of the talk. First talk is by Dr. Naik, as per schedule. Second talk by Dr. Minson on nephrology. We have a break. We have a very close friend of mine who will do some wellness session. He's going to do breathing exercises. So please join in. We've got Dr. Nokoro, who's going to talk on respiratory, and followed by Dr. Aston. I think so. His is one of the most entertaining talks. You'll enjoy it before lunch on allergy. Lunch will be between 12:45 to 1:40. So please remember it's 1:40, because we need slightly longer time for the next talk with a quiz. And that talk is on the 6-week baby check and heart murmur by my dear friend, Dr. Singh. We then have the neurology talk by Dr. Bali, followed by another break of 15 minutes where we'll do some exercises for the neck and the hands, some nice relaxing exercises to sort of get away the stress for the whole day. Then you'll hear myself talking for a few minutes on common presentations, followed by Dr. Anna Riddle, who is going to do her 3 talks and will also do a 15-minute COVID update. We finished the day with myself and Dr. Philip Bennett Richard closing the webinar, followed by some other information about feedback and certificates. So I would request Dr. Giles and Dr. Murthy to say a few words.
You okay if I go first, Akshay?
Yeah.
So welcome everyone. As Akshay said, my name is Giles Armstrong. I'm the Clinical Director at the Royal London Hospital for the services covering integrated paediatrics, which covers our acute and community services. And a special welcome to those Tower Hamlets GPs I know have dialed into this, although I know people have dialed in from all around the country, and I'm sure you'll find the sessions useful and helpful. It's really just to stress that from our perspective, our interface with primary care is essential to the work we do as paediatricians. We couldn't do the job we do without the knowledge that we've got a huge number of highly trained professionals in the community who actually manage the vast majority of cases, and it's only the very small tip of the iceberg that comes to us. Hopefully these sessions will allow you to have a slightly finer grasp of which ones benefit most from a secondary or a tertiary paediatric care. Unfortunately, I can't join you for most of the day, but I will be dialing in during the day to see how things get on, and I wish you all the very best.
Thank you, Giles.
Thanks, Akshay. I'm Murthy, one of the clinical director for specialist pediatrics, and welcome all. And I should say a huge thank you to the whole team who's put this together. And I still remember me speaking to Akshay, part of his appraisal a few months ago, or beginning of end of last year, to say that we need something like this to be put in as things change in specialist pediatrics and the secondary pediatric care. It is important that the primary practices are also aware of these issues. And I think this is the first start, and I'm really grateful for Akshay and his team to put together through this whole period of time, which actually is quite a difficult times, where all of you have worked really hard, and thank you for all of your efforts in keeping patients out of the secondary care, which I think is a huge effort, which we have seen a lot of benefit from that, because we in pediatrics have really supported adult services as much. So thank you all for all the time and effort you put in through this crisis. Hopefully, as we move forward, we could be using more of these sessions in training, teaching, and supporting this. And this is essentially a start. And I have to say thank you to Akshay, because although we had a long discussion in his appraisal, to convert this into a real, true session is impressive. And thank you all, and hope you have a good day. I will be joining in most of the days, but we'll pop in as it goes. Thank you, and good luck, and enjoy the day.
Thank you, Murthy. Over to you, Phil.
Yes, welcome everyone. This is a very exciting and ambitious project. I think when many of us, when Akshay first mentioned it to us, thought it was going to be very difficult to pull off. So bear with us if there are any glitches. It's taken a lot of effort on everyone's part to put it together. And of course, thanks to you all for attending today. We were thinking that we would be in the Royal London Hospital in the basement in the beautiful lecture theatre and suite there, but unfortunately we can't. So we were still very keen to put this on and make sure that, as previous speakers have mentioned, that the strong relationship between primary and secondary care in Tower Hamlets and beyond in paediatrics is maintained and flourishes. I hope you find the presentations today interesting. We've all, as GP moderators, had the chance to view the presentations and tweak them a little bit so that it's, we hope, has a primary care focus. But if there are any questions as we go along, please put them in the questions and answers, and we'll be moderating that as we go along so that we can make it as interactive as possible. It's a really long day. Make sure you have some food, water, whatever you have next to you to keep you well hydrated during the day, and we hope you have a great experience. Thanks.
Thanks, Phil, for everything. And over to you, Dan and Shruti, my pillars.
Should I start, Dan?
Yeah.
So thanks very much, Dr. Jane. Good morning, everyone. And once again, a very, very warm welcome to you all to our very first paediatric updates for GPs in primary care course. I wanted to start by giving a super quick background on my journey here. I actually initially trained as a GP at the Barnet BTS, and I know we've got many trainees and even a few of the program directors joining us today. I CCT'd in 2014 and have since continued to locum as a GP. Alongside my locuming, as many of my friends often tell me, like a crazy person, I returned to the dark side of hospital medicine, to what's felt like absolutely endless night shifts. And I joined the paediatric training program in North Central London. I've just completed my training. Having been through both general practice training and paediatric training programs, I feel I'm in a really extremely privileged position to understand the complexities and challenges that both primary and secondary care face. I'm sure each and every one of you in the audience will be able to relate to dealing with the very huge volumes of patients seen day in, day out in primary care, battling to undress, assess, diagnose and manage not only the child, but their often very anxious parents in only 10 minutes. So trust me when I say that general practice done well is no mean feat. We're all aware that children make up to 25% of your workload, and it's great to see that they're being prioritised in the NHS long-term plan. Yet, paediatric placements are still not part or mandatory of general practice training. Integration, collaboration are terms that are really favoured nowadays, but actually, what do they really mean? This, for me, is where it all begins. I'm really passionate about building these foundations from the grassroots with experts and families, and those experts are you. As you can probably tell, I'm really excited about today's course. It covers some really challenging but very interesting paediatric presentations to general practice. And at the end, I think you'll all feel really empowered with up-to-date, evidence-based, really practical solutions, which will help you manage these children and their conditions by yourselves in a 10-minute appointment in primary care with absolute confidence. I hope you all have a fantastic day. I'll hand over to Dan.
So thanks, Shruti. So good morning, everybody. I'm Dan Gibney. I'm one of the GP ST2s in Tower Hamlets. So I did my paediatrics post at the start of ST1 in the Royal London with Akshay and some of the other presenters that are here today. Had a really good experience there. Although I definitely don't miss the infamous 1207 bleep, which I'm sure many of our attendees will recall very well. So there's a real variety as to how much exposure we get in GP training, as Shruti said. And this is really variable across training schemes. We're really lucky in Tower Hamlets that we can that we have a really good rotation in the Royal London. But it's great to be able to bring this course to everyone who hasn't had a useful experience in paediatrics. So I'm sure people in Tower Hamlets appreciate that we've got quite an interesting population there. It's quite a large population under the age of 18 with a really high birth rate, a lot of deprivation, but also quite a lot of pathology. So yeah, and depending on the demographics of your population, as Shruti said, up to about a third of consultations in primary care can be with children. So hopefully this course today will be able to help us clarify and gain more confidence in the management of the common presentations which we see day to day.
Thanks a lot, Dan and Shruti. Well, it's time to get our 5 delegates who have kindly volunteered to talk. So I'm going to unmute them. We've got Dr. Amy Kanabar, Dr. Sheho, Nikki, Nicola, and Sagina. And I won't mind whoever wants to talk first. We could start with Amy.
Hi, yeah, I'm Amy Canavan. I'm a GP in Southeast London. I finished my VTS training in 2014, and part of my reason for coming on this course was looking at the agenda. It had quite a breadth of different topics, seemed really comprehensive, and I felt, 5 years or 6 years post doing a paediatric post, it looked like a really good course to do. I was particularly looking forward to the 6 to 8 week check refresher, because I think a lot of courses don't really offer that, and it just seems like a great opportunity to kind of consolidate learning in all these different areas, and it's also been really great that this can be provided virtually, having not been able to attend in person at this time. So thanks for organising it virtually for us.
Do we have Shay? Shay, do you want to talk?
Hi, my name is Jay. I'm one of the GP trainees in Tower Hamlets. I did my GP placement with Danny and Akshay a year or two ago. Really looking forward to this course, because although my GP placement with paediatrics was only a year ago, unfortunately, I probably have forgotten quite a lot of the things I have learnt. And to have this refresher now is such a good point before I start my GP ST3, going into general practice proper. So really looking forward to it, in particular the allergy element of today, because there is a lot of allergy, particularly in the younger population in Tower Hamlets I've seen. Really looking forward to having those difficult conversations, but with the knowledge from today's course. Thank you.
Thank you, Shay. Do we have Nikki? Nikki?
Hi, I'm Nicola. I'm welcome to sunny Guernsey, but it's quite sunny today. Been looking forward to this. So it makes a change. I've been doing COVID clinics for 4 months, so we're just getting back to normality. We're 75 days COVID free now, which is a really great place to be. And it's been a very long time since I did any paediatrics. And I'm looking forward to just a good general update. And it's nice to actually have a study day as well. So looking forward to all of it. Lovely.
Thanks a lot, Nikki, and thanks for joining.
You're welcome. Thought I'd show you some nice view this morning.
Excellent. Do we have Sagina? Let's get in Sagina.
Hi, good morning, everyone. My name is Regina, and right now I'm doing my ST2 in North Middlesex University Hospital. I'm working along with Dr. Chintan Singh. He's such an inspirational pediatrician, as we all know, and he's a great teacher as well. So he told me about this course, and the minute he said, I was super excited because it covers a breadth of topics. And pediatrics is a nemesis of many GPs, as I have done 6 months in GP land before. And as Dr. Shruti said, it's 25% of the population, and what the mind does not know, the eye does not see. And I just want to get that little fear element out of my knowledge gaps that I have. And looking through your schedule, it looks like pretty much you've covered every aspect that a GP trainee needs to know. It's a beautiful curriculum, and I'm so excited to listen to all the great lectures from all you great people out there. I'm very grateful for all the hard work you have put into this course. And I think it's a super boost before I go into my ST3 into GP land. And what do I expect from this course? I'm quite looking forward to the allergy testing bit, interpreting the results, some prescription guidance on formula feeds like amino acid and extensive hydrolyzed formula. I could never get my head around that. I also love to hear about the 6-week baby checks, the murmurs made easy, and talk about the PIMS, TS, safeguarding, and all the common presentations. Obviously, any knowledge is welcome for me. And thank you so much for this opportunity. And as I said, as a GP, a strong history. We entirely rely on 10-minute appointments, and it's so hard to make diagnosis. A thorough clinical examination is so important. And if whatever you guys are going to teach me, it's going to really pay back, and I'm going to make all those appropriate referrals to you guys. So I'm looking forward to it. All the best, and thank you for the chance to speak.
Thanks a lot, Sagina.
Thank you.
Do we have Nikki, who was the first one to register on the course? Nikki?
Hi, Dr. Jane. Can you hear me?
Yes, Nikki.
Hello. I'm so sorry about the lack of camera. I haven't managed to make this Mac work, so apologies.
No problems.
But good morning, everyone. So I'm Nikki. I'm a GPST2, currently working at a practice in Tower Hamlets. I spent some of my ST1 year last year working with these guys in PEDS at the Royal London. I found it an enjoyable but really challenging 4 months. I didn't have any experience in peds before starting. And while I felt a lot more confident by the end in sort of managing acutely unwell kids, I'm finding that being in general practice has its own challenges. So I'm really looking forward to today, just to help me feel a bit more confident in knowing what's okay to manage in primary care and when it's time to refer on to my secondary care colleagues. And I really don't want to be that person that refers every little thing in. So yeah, just getting a bit better at knowing when it is okay to refer would be wonderful. And that's about it.
Well, Nikki, thanks a lot. And thanks for taking the time out, all the delegates. And what we'll do is now we'll straight go into the first talk. And we start with another quick poll on constipation. And this will be followed by the pre-recorded video by Dr. Naik, who will be giving the talk.
Good morning. I'm Sandhya Naik, Consultant Paediatric Gastroenterologist at the Royal London Hospital. I'm here to give some updates and optimise referral pathways for some common conditions such as gastroesophageal reflux and constipation, as well as less prevalent ones, including inflammatory bowel disease and celiac disease. I always have the Bristol stool chart open during my consults for constipation. Parents and children often have difficulties describing their stools, and yet an accurate description is so useful to help optimise treatment. And as such, I highly recommend that the Bristol stool chart is close to hand during any consult for constipation. Constipation is very common. It is a significant burden to primary care and makes up to 50% of paediatric referrals to hospital. The majority of children do wean off medication. But what is crucial at the beginning is to take a detailed history as to what do the parents mean by constipation. Do they mean that the child is simply passing hard stools, which may be pellets, or a large stool that blocks the toilet? Do they mean that the child is straining and it only goes every few days, but ultimately passes a soft stool? Do they mean the child is refusing to pass stool by stool withholding? Some children will actually present with constipation, but described as diarrhea by the parents, and this is because of overflow, where a hard mass is blocking and small liquid stool is bypassing. Parents will often describe other symptoms, occasionally abdominal pain, that this is more common when it's been present for a long time, and offensive flatulence. Now, most flatulence is offensive, but some parents will clearly describe that there's been a change and it is even more offensive than usual. Rectal bleeding is not a common presentation, but can be associated with constipation if there's an anal fissure or an anal tear. Here I've broken it down into age groups. Constipation is actually unusual in the age less than 6 months, and often it's because it's rather mislabeled or misdiagnosed. Detailed history is required, and it is more common in formula-fed infants, but often related to lack of water or fluid. Doctors do worry about allergy in this age group, but in fact, cow's milk allergy in this age group presents with blood in the stools at the onset of around 6 to 8 weeks. In the older child, the onset is associated with introduction of weaning or finger foods at the age of 1, and therefore a dietary history is key, where it is obvious there is a lack of fruit, fibre and fluid. Children at this age will often strain or stool hold, and again, if one is concerned about allergy, there should be other symptoms such as a rash or upper respiratory tract infections, recurrent otitis media. So how do we go about diagnosing constipation? Well, there is a very good, nice guidance which is attached here, but it does rely on detailed history an examination. There are very few red flags. The important one is to examine the back and the lower limbs to ensure no abnormal neurology. And also to remember to ask about meconium, because failure to pass meconium may be an indication of something like Hirschsprung's. The amber flags may or may not be helpful. Constipation is common in adults, and so a family history may not always be suggestive. One needs to consider allergy, but again taking a respiratory and a derm history. Abdominal pain and vomiting can present if the child is quite significantly fecal loaded and is often a late presentation. Of course, be mindful of bilious vomiting, which would suggest something different. Here I've broken down the treatments according to age. In the younger babies, it usually is a question of increasing water. Constipation rarely happens in breastfeeding babies, but often is due to inadequate intake, and a breastfeeding counsellor may be required. Multiple feed changes should be avoided. Occasionally, lactulose is of use, but we should avoid stimulants in those under 6 months. In contrast to the older baby and toddler, a dietary history to ensure adequate fruit, fluid and fibre, but often a macrogol will be required, and consideration earlier of the use of a stimulant. Lactulose is often ineffective in this age group, but toilet training is very useful. Lifestyle changes can't be overemphasized. Dietary modifications can make a big difference. Toilet training simply involves at least 10 minutes 3 times a day, whether or not the child passes a stool. It's a good form of exercise and training. The increase of screen time has led to increased immobility, and therefore encouraging exercise and restricting screen time can also be useful advice. When it comes to treatment, do consider whether or not the child would benefit from disimpaction before starting the maintenance treatment. If the colon is significantly loaded, it doesn't matter how much maintenance we use, it will simply make the soiling worse, for example, and disimpaction is needed first. After 2 or 3 months of the use of a macrogol, if there's no improvement, consider using a stimulant in an adjunct. Also, we need to manage parents' expectations and explain that we need to step up and step down medication. And the stepping down is often a lot slower than people realise, but leads to better long-term ability to actually wean off medication. Surgical intervention is extremely rare, but I will touch upon this later. So what is the referral criteria for chronic constipation in children? It's actually quite straightforward. Obviously, if there are red flags, such as abnormal neurology. However, the other criteria is simply refractory to a combination of macrogol and stimulant. But do ensure there's compliance. Parents will often stop medication because in their minds it didn't work quickly enough or wasn't really helpful. So what do we do once they're referred to hospital? If they're already on a combination of a macrogol and a stimulant, they're likely to need a transit marker study. Obviously, if they're only on a macrogol, we would add in a stimulant and then review. A marker study is simply a capsule containing plastic shapes that is swallowed by the child and an X-ray taken 5 days later. But the capsule can be broken open, and so therefore even younger children can have one, and the little pellets or shapes can simply be mixed with yogurt or food. It's important to stop laxatives during those 5 days. Here is an example of 2 types of results that we commonly see. The picture on the left hand of your screen shows the markers are distributed throughout the colon and the rectum. This is indicative of slow colonic transit and is likely to require quite high doses of both macrogol and stimulant. On the right hand side, however, it simply shows all the pellets are in the rectum, and therefore here a stimulant in high doses is required, or topical treatment such as the introduction of enemas would be effective. No further investigations after a marker study are required in the majority of patients referred to hospital, but there is a tiny proportion that really are refractory, and in those cases we're quite lucky at the Royal London that we have an anophysiology service that can also do endoanal ultrasound. These children may benefit from the use of something like Peristine, which is seen on the right hand side of your screen. Peristine involves inflating a balloon into the rectum and blowing it up until the patient gets sensation, and then is essentially a rectal washout system. Although it sounds a little brutal, we have some patients whose lives have been transformed by the use of this. I mentioned that surgery was really rare for constipation, and apart from the odd manual evacuation, nowadays surgeons are involved in operating to give the patient an ACE, an anti-grade continence enema conduit. Usually this is the appendix brought up, and patients then instill something like bisocodal or clean prep, and then sit in the toilet after 15 minutes. And essentially, it's a forward flush. Again, we have patients who, although this is quite an interventional treatment, have really improved, and some have actually weaned off their ACE, off medication, particularly by the teenage years. So, to summarise childhood constipation, it is common. We need to manage parents' expectations and ensure that dietary and behavioural modifications are implemented. We should use macrogols, but also consider the earlier use of stimulants. And we need to be a little patient when it comes to weaning off medication. And if you're unsure whether or not to refer, I would advise simply phoning up first, because then we can optimise whilst the patient is waiting for their hospital appointment.
Thank you, Dr. Naik, for the lovely opening talk. So I open the floor, Dr. Naik and Nick, for a couple of questions, and then we move to the next talk.
Sure. They came in. Thanks, everyone, very much for sending in your questions. They were a bit quick, but there's a few that have a similar trend, so I hopefully will be able to ask them. So firstly, the question was about the fluid in the young babies, and I said, 100 mils per kilo. And what I meant was that includes their milk. So if they're sort of getting 50 to 80 mils per kilo, you can give extra water. Yes, it should be cool boiled water. And even if they are on 100 per kilo roughly, just give them an extra roughly 10 mils per kilo. That would be a good one. Someone's a bit nervous about disimpaction regime. I just would say refer to the NICE guidance and say, look, this is standard practice. It's well validated. Question about which is the first stimulant. And I was delighted with the poll, by the way. Macrogol is the first line. But I would say that I usually start with Senna. And if there isn't an improvement with Senna, then picosulfate. But a little tip, all these stimulants, Senna and picosulfate, and even sometimes docosate, will give a bit of abdominal cramps. And the main thing is to warn the family and say that it's worse in the first few days and then it settles down. And then that way they won't be hesitant to use it. And it really is often the combination of the two. And the reason being for that is, yes, macrogol is mainly fluid pushing through and partly stimulant, but particularly in this toddler group, they still withhold so strongly. You really do need that little extra push. I'm trying to think if I haven't covered anything.
Is there any question, Nick, you want to ask?
Yeah, I think the other things I think that came up are, the red flags, so previously unknown or diagnosed weakness in the legs, locomotor delay, those kind of things. Questions about how do we differentiate between an impact or a maintenance? Well, I always say, well, diagnosis combination of the presence of overflow, soiling, and fecal mass palpable when we examine children is quite common to know if they need disimpaction versus the maintenance. And then the question about how long should we continue treatment for, and I normally say for at least 6 weeks after regular bowel habit is established, and that can really take up to 6 months. I don't know what you think, Sandhya.
Yeah, I mean, for the ones that come to me, obviously, I usually say, well, how long has the problem been going on for? And if you're still constipated, it's probably going to be as long. So if you've got a 6-month history of constipation, probably going to be another 6 months till we can get you really back. Somebody says glycerol suppositories in the little ones. I hate glycerol chips. It's a personal issue of mine. I think that if a little neonate is not managing on either a bit of lactulose, extra fluid, you might need to ask for second opinion, because we really shouldn't be using chips regularly. I don't condone the practice. Some parents, put a little bit of KY gel on a cotton bud and all sorts. I wouldn't recommend those. The earliest I use Movicol is about 6 months. That's partly because there's lack of evidence in under 6 months and also licensing. It isn't that it's impossible to use in a young baby, but again, in primary care, I think you should avoid using Movicol less than 6 months, unless you've just picked up the phone and chatted to somebody and said, what do you think?
Any more questions, Nick?
I think we've covered most of them. We'll try and answer the remaining few on the chat, but I think most of them are quite similar.
Thank you. So let's crack on and let's go on to the next poll on reflux, and then we'll do the video on reflux. Thank you, guys.
I'm now going to talk about another common presentation to primary care, gastroesophageal reflux. It is really important to differentiate gastroesophageal reflux from gastroesophageal reflux disease. It is the latter that warrants investigation and treatment usually. Gastroesophageal reflux is normal physiology, whereby a small amount of gastric contents goes into the lower esophagus. It is more common in babies, but gets better by the age of 1. When it presents with vomiting, we need to ensure we haven't missed other causes, such as a UTI or sepsis. When there is concerning associated symptoms, we need to consider gastroesophageal reflux disease. These include refractory epigastric pain, Sandifer syndrome, weight loss, coffee ground vomit, melena, hematemesis. When it comes to gastroesophageal reflux disease, there are some clear red flags, which once again rely on detailed history and examination. I've broken it down into age groups because in the younger infant, less than 6 months, we need to consider whether projectile vomiting is indeed projectile and is indicative of pyloric stenosis. We need to ensure that it's not bilious vomiting, indicating an obstruction. And though unusual, reflux disease can cause apneas. Faltering growth can be a challenge because we need serial weight measurements, and currently, with less face-to-face interactions, this is even more challenging. So we need to ensure that at every opportunity babies are weighed, when they attend for immunisations, when they see the health visitor, when they seek breastfeeding counselling. Only through serial measurements can we determine whether or not there is genuine faltering growth. In the older child, there are some other symptoms which are of concern. Refractory epigastric pain, which they can describe to you. development of a hoarse voice because of acid damage to the larynx, dysphagia because of a stricture, selective eating patterns because of ongoing acid reflux, coffee ground vomiting, hematemesis and melena due to reflux disease occurs in the older patient, not in those under the age of 6 months. Here I've listed a few of the amber flags, and they're amber because they may or may not be useful. The most challenging one is that of irritability. Parents will describe an inconsolable child, and there is often a knee-jerk reaction to throw antacids and anti-reflux medication at these babies, whereas in fact they may just suffer from a disordered sleep pattern, or they may have colic or trapped wind. I remember many years ago, a consultant colleague of mine when I was a junior actually ran a crying baby clinic. She gave out lots of reassurance and listened to the parents, but she did not dish out anti-reflux medication like sweeties. There are some amber flags we need to be aware of, and the NICE guidance which is attached here describes nicely how to sift through the symptoms. Cough is so common in babies, and viruses are so common, but it's only occasional that a recurrent cough is caused by reflux. That is the same for pneumonias, because babies are vaccinated and pneumonia is uncommon. Aspiration pneumonia can only occur if the gastric contents go all the way up the esophagus and it spill over into the lungs. And therefore, in someone such as a neurodisabled child, yes, it can be due to reflux, and recurrent chest infections in these patients should include optimizing their reflux medication. But in healthy babies, aspiration pneumonia is pretty unusual. One needs to bear in mind about the history of atopy, and the amber flags are merely a guidance. So what do we do when it comes to treatment for gastroesophageal reflux? Well, again, differentiating between reflux and reflux disease is probably key. Often, it'll be a thriving child who's just frequently vomiting, and reassurance to the parents is all that is required. It is worth exploring the pattern of feeding, because sometimes simply by reducing the volume and increasing the frequency of feeds can make a significant difference in the quality of life for the parent and the baby. Reassurance that a thriving baby whose vomits will get better by the time they're older, often when they introduce solids. The NICE guidance does discuss thickeners and alginates. And for those who may have, for example, amber flags or borderline flags, they are probably worth trying. Changing feed to, for example, over-the-counter formulas that stay down longer are also beneficial. However, it isn't recommended to frequently change to hydrolyzed or partly hydrolyzed expensive feeds if it's simply reflux, not reflux disease. The other thing of note is that parents often move, and you may inherit a patient who is on quite a lot of anti-reflux medication for reflux and not reflux disease. So do consider de-escalating treatment as well as escalating treatment. In the older child, it is much easier because reflux disease warrants a trial of a PPI. What about the referral criteria for gastroesophageal reflux? Well, it's gastroesophageal reflux disease. Faltering growth? Absolutely. The red flags that I've alluded to. It's easier said than done, but please try and avoid referrals simply for parental anxiety. In the older child, refractory to PPI is an indication for referral. And obviously, refractory to all the interventions that you may have already tried is a valid referral. So what happens when you refer to the hospital? Well, depending on the signs and symptoms, the gold standard for diagnosis is pH impedance. And this detects both acid and non-acid reflux. This is highly important, particularly in the under 6 months, because their diet is entirely milk-based and will neutralize any acid-type reflux. But the impedance side will show positive correlation with symptoms and signs. The pH impedance involves a nasogastric tube with several portholes, the distal one just above the lower esophageal sphincter. And parents are advised to press appropriate buttons in relation to symptoms and to meals, and we can then correlate and determine whether or not there is indeed reflux, acid or non-acid, causing the signs and symptoms that the patient presents with. So what other investigations would we consider in the hospital? A contrast study is sometimes done, particularly if we're concerned regarding stricturing, but quite often I will do one simply to prove normal anatomy and to ensure, in the rarest of occasions, that we haven't missed a malrotation. I do not use a contrast to look for reflux, even if it is reported as such. An endoscopy with biopsies will determine whether or not there is reflux esophagitis. And sometimes, for practicalities, we will combine both procedures, although in the ideal world, one would do a pH impedance first, act on the results, and if refractory to treatment, then consider an endoscopy. There's an age group where they would not tolerate pH impedance, and that is the toddler group. And I personally will sometimes have to empirically treat these children and undertake an impedance or an endoscopy later. We are now moving to the small, tiny group of severe gastroesophageal reflux disease. And what do we do for these children? Well, here we do change formulas. Often a partly hydrolyzed feed is required. Often nasogastric tube feeding is required. And sometimes moving from bolus feeds to continuous feeds makes a huge difference. Sometimes moving from gastric feeds to jejunal feeds is what is required. One often wants to know what the indications is for fundoplication. It really is for ongoing stricturing disease despite optimal treatment, or for the presence of Barrett's esophagus, which, although highly unusual, is not unheard of in the paediatric population. Many neurodisabled children have been referred for fundoplication in the past, but more and more evidence is emerging that actually using blended diets and optimizing their treatment medically is better. These children actually do worse with fundoplications and have ongoing issues with retching and bloatedness, and therefore significant consideration must be done before considering fundoplication in these children. So in summary, gastroesophageal reflux is common, gastroesophageal reflux disease is not. Reassurance, particularly for those who have reflux but not disease, is really important and effective. There are clear red flags, and the NICE guidance takes you through these very well. And prior to referral, please don't hesitate to consider phoning for advice first.
Thank you, Dr. Naik, for the lovely talk. Time for a few questions with Dr. Naik and Nick. We got about 3-4 minutes.
Okay, I'll start because there's been again a couple that have come through. The question about continuing a PPI while you wait for a referral, absolutely in the older child, because you're effectively showing whether or not they respond. And by the time they see us, we may have the answer, because then we can say, well, you've responded to the PPI, we don't need to further investigate, or actually there's no response, we might need to look at slightly wider issues. the stay down formulas, the ones I mentioned over the counter, they're actually labeled as anti-reflux, as in AR. On a live webinar, I really shouldn't use brand names, but all the common milk formulas have an AR type product. The ones that I was referring to is the ones that need prescriptions. So what I didn't want was a child who's thriving, is a bit irritable, and then gets changed onto a prescribed partly hydrolyzed or hydrolyzed feed. A really excellent question was the 8-week check. Somebody's a bit colicky, a bit constipated, and possibly reflux. And one of the main issues there is actually it's likely the constipation is making things worse. And so I would actually go back to the previous talks and address the constipation and see how then the signs of colic and reflux type issues respond or not. And you often do find that by releasing lower down, there is a significant improvement. I was asked about silent reflux. This is thrown out so much. In my experience, the ones who have silent reflux are actually the ones who become unwell. So unexplained recurrent chest infections, as in they've got silent reflux and they're aspirating, or they've got such significant silent reflux, they've got food aversion, or they've got such significant silent reflux that they're not gaining weight because the child's just not feeding as they would normally would. So in primary care at the beginning, when it's new kind of onset of reflux, I suspect you're not going to be seeing the silent refluxes. And again, it just goes back to detailed history, really. How long would I give a PPI for? I think is one of the questions. And I usually say 8 weeks, 6 to 8 weeks, and then see the response. And, you know, nowadays, because of COVID, you don't have to see them. You can phone them up and say 6 weeks, 8 weeks, how are things going? Has the PPI worked? And in those who have, in the older child, however, I would say that they often will have their 8-week course, they get better, but then the symptoms break through, and I have no, I have no problem in continuing long-term in the older child. In fact, you can even do it in the younger babies. The only thing you might need to warn them about is breast bud development with long-term PPI.
Nick, any questions from you?
I think the only thing I would really add is that, you know, it affects 40% of infants, and it can really resolve in 90% by the age of 1. And actually, we should be reassured by that and often not jump to medical treatment as well, as Sandy was saying. So I think we've answered all the other questions, though.
Thank you. We are on time, so let's move on to the next talk.
I'm now going to take you through the final part of my talk, which is briefly to discuss inflammatory bowel disease and celiac disease as 2 important causes of chronic diarrhea. Celiac disease is a lot more common than many people realise. Its prevalence is 1 in 100. It can be diagnosed at any age and can go undiagnosed for many years. I remember my adult colleagues laughing, having diagnosed a 78-year-old for the first time with celiac disease. The most common presentation is abdominal distension and diarrhea. Usually, this used to occur at 6 months of age when weaning started, but nowadays, many families use ready-made jars and pouches, which are often gluten-free, and so symptoms don't start until they're 1 year old and starting finger foods with actual wheat products. Constipation really isn't a common presentation of celiac disease, but short stature is. And before assuming it's constitutional or familial, one needs to ensure that we've done antibodies for celiac disease. If symptoms have been going on for a long time, there may be signs of fat-soluble vitamin deficiency, such as rashes or rickets. There is often a family history of autoimmune disease, and also first-degree relatives. But currently, the recommendation is to only screen family members who are symptomatic. Now, this is different to, for example, Italy. The diagnosis of celiac disease has transformed over the years. Historically, all children required an endoscopic biopsy. But now, the latest guidelines attached here clearly indicate that in symptomatic children, they have antibody test, as in tissue transglutaminase, greater than 10 times the upper limit of normal on 2 occasions, together with positive anti-endomysial antibody. Biopsy is not warranted, and neither is expensive HLA genotyping. This means that primary care can do the first set of bloods, ensure the patient stays on a gluten-containing diet, and at first appointment, we can repeat the bloods and then do a diagnosis. For my colleagues in District General Hospital, where already a second test has been done, I will simply put in writing that I agree they have celiac disease and allow local follow-up, because the guidance still says formal diagnosis is by specialist. For some proactive GPs, if you wish to do blood test at time 0 and then at 3 months and merely telephone to confirm the diagnosis, that is just as acceptable. Primary care is usually involved in the prescribable products, and again this has changed in England. Due to cost savings, it is now recommended to only prescribe bread and flour. Other countries such as Scotland and Wales will still prescribe gluten-free snacks. It is estimated that about 50% of CCGs are strict and 50% are a little lax, and it is totally within your remit to determine what you wish to prescribe. You may be asked, is the gluten-free diet for life? And the answer is yes. Non-compliance with a gluten-free diet over time is associated with a risk of small bowel lymphoma. In particular, this is challenging for teenagers who may have been diagnosed when they were so young they don't remember, or even more so if they were diagnosed simply due to short stature with no GI symptoms. But again, we discuss the risks of lymphoma and reiterate it is for life. Some parents will also be a little confused and think it is the same as a wheat allergy and want EpiPens. This is an autoimmune mediated condition, but is totally different to type 1 IgE mediated wheat allergy, which does require an EpiPen, and is different to the non-IgE mediated symptoms of wheat allergy, where often later on, after a period of a couple of years, gluten can be safely reintroduced. I'm now going to move on to inflammatory bowel disease, which comprises the conditions Crohn's, ulcerative colitis, and IBD-U, otherwise known as inflammatory bowel disease undefined, which essentially means it has overlap symptoms of both Crohn's and ulcerative colitis. Referral criteria for inflammatory bowel disease is relatively straightforward with a detailed history. Chronic abdominal pain and weight loss. Chronic diarrhea, but please do ensure that stool cultures are negative. I have had several patients with Shigella and Campylobacter incorrectly referred for inflammatory bowel disease and a lot of parental anxiety. Growth failure and delayed puberty, refractory iron deficiency are also common symptoms. Milder symptoms with a positive family history should also be an indication for referral. I'd like to now discuss the role of fecal calprotectin in children, and in particular with respect to paediatric inflammatory bowel disease. It was originally designed, as you know, for bowel cancer screening, and therefore the absolute values differ when applied to paediatrics, and it is only validated in those over the age of 2, and I simply just wouldn't do one under the age of 2. A level of less than 50, I agree, is no pathology. But remember, the fecal calprotectin is simply an adjunct to a detailed history, examination and baseline bloods. So, for example, if the fecal calprotectin is between 50 and 150, but there's no real history of inflammatory bowel disease, consider what else it could be. Has the child been taking regular Brufen? Does it have simple gastroenteritis? In which case I would simply repeat it after a few weeks. A level greater than 150 is likely to indicate pathology, but again, the history will help suggest whether or not it is indeed inflammatory bowel disease. Common mistakes are positive fecal calprotectin when the history is that of epigastric pain and the child has Helicobacter pylori. A simple stool antigen would have helped. A level greater than 250, however, is highly indicative that their child will have paediatric inflammatory bowel disease, and a referral to be seen in our specialised IBD clinic is warranted. So the gold standard for diagnosing paediatric inflammatory bowel disease is a combination of an upper and lower endoscopy and an MRI. Here one can see the deep ulceration on the left-hand upper slide, indicative of Crohn's, and the more continuous pattern on the right-hand side, indicative of ulcerative colitis. The MRI highlights the terminal ileal disease seen in Crohn's. In some patients, however, we will also proceed to a video capsule endoscopy. And here again, one can see the inflammation detected in the mid-small bowel. Because inflammatory bowel disease is essentially managed in the tertiary centres, I won't dwell too long on it, but simply have attached these very useful guidelines which we follow for those who are interested. And so to conclude, ladies and gentlemen, gastrointestinal symptoms commonly present to primary care. Early and effective management of gastroesophageal reflux and constipation can improve the child's care, improve patient and parent satisfaction, and actually reduce the number of hospital referrals. Chronic diarrhea does occur in children. Celiac disease is more common than one would realise, and although inflammatory bowel disease is not common, delay in diagnosis can cause potential harm, for example, the development of stricturing. And I wish to emphasise that the fecal calprotectin is a useful adjunct, but should not be considered as an assessment tool alone. And finally, I'd just like to say a huge thank you to Dr. Jane for organising this webinar, and to Dr. Davison for giving me very positive and useful critique on my slides, and to all the webinar participants. Thanks very much. Have a good day.
Well, thank you, Dr. Naik. Superb as usual. Let's crack on with a couple of questions. We got 2 to 3 minutes.
I think the fecal calprotectin in children is a topic of debate. And just to re-emphasise, it is validated in over the age of 2. Low values are not related to IBD. There's very good evidence that it's got to be above 250. I believe there may be an issue in Tower Hamlets about ordering calprotectin, and I've just given Dr. Philip Bennett-Richards our contact at the Royal London, because the biochemist has clearly said she's happy to do fecal calprotectin in children. And just for those interested, I know in primary care you do a lot of fit testing recently, and we've actually just undertaken an audit comparing fit in children, and that is hopefully going to come out soon and will also help you guys in primary care. Going back to the previous talk, there was a question of, can you give water to young babies? And I pressed the live button accidentally. So just to say, yes, you can. I mean, I wouldn't give it to a 1-day-old, but in the one who's a couple of months old and constipated and definitely not getting enough fluid, cool boiled water is fine. It's not harmful.
Nick, any questions from your side?
I think the only things that came up are about ordering the tests in certain labs, and certainly in North Central London, primary care have access to all of these tests, so there shouldn't be any issues there. But it doesn't seem there's too many more questions from the IBD talks. I think you've answered them all, which is great.
And we're also spot on time, so I think it's an excellent start, guys. Nick, thanks ever so much for moderating, making it a bit easier for me. Akshay, back over to you.
Thank you, Nick and Dr. Naik. Thank you, everyone. So we can crack on with the next talk. So let's go live with a poll on creatinine and launching the poll now.
My name is Dr. Susie Minson. I am a consultant in general paediatrics at the Royal London, and I have a special interest in paediatric nephrology. So we're going to have 3 talks this morning about different elements of paediatric renal problems. So the first of these is about raised creatinine in childhood, and we chose this talk because it's a topic that we get quite a lot of calls and referrals about. Often what to do with an unexpectedly abnormal result of a raised creatinine and how to manage that in children. So first of all, we'll talk about what really counts as a raised creatinine and why and when does it matter. How to calculate the EGFR in children, which can be super helpful. Think about what the causes of renal failure are in children, how to approach that, and what the real red flags are and when these children need referral and how sort of urgently that needs to happen. Okay, so the first thing I think to say is that chronic renal failure in children is relatively uncommon in the UK, but it's also true that children in the UK very rarely have routine bloods taken. So often the first time you see an abnormal result on their creatinine is the first time that they've ever actually had that measured. So it's often quite difficult to know from a single result really where we are and what's going on. So it's important to know that the normal range of healthy creatinine will vary both between different labs a little bit, but also varies dependent on the child's size, their height and their muscle mass, as well as their health. So for any given reading, there's a bit of untangling as to whether this is actually a result which is physiologically normal and healthy for that individual child, or whether this result actually represents underlying renal pathology that needs further thought and investigation. So one of the reasons why this is really key is because we know that the identification of renal pathology and chronic renal disease in children is really important in terms of optimizing their health and managing their kidney disease and really aiming to preserve their renal function as long as possible. We know that for adults in the UK who have chronic renal failure and are needing kind of renal replacement therapy in middle adult life, their renal pathology often did begin in childhood, and we know that optimizing children's renal health in childhood is really important in delaying end-stage renal failure as long as possible. Okay, so what is a normal creatinine? So as we've said, creatinine rises normally throughout childhood as children grow and as they develop further muscle mass. Reaching a normal adult creatinine is only usually something that happens once children have passed through puberty, and as with adults will continue to vary at different times of life depending on a number of factors. Usually there's quite a significant rise in the creatinine around the time of puberty just because there's a growth spurt at this age, but also because in young people the muscle mass develops quite rapidly at that age. So you often see a physiological rise around the time of puberty, which may flag on some lab systems as pathological just because of the rate of rise. It's also important to know that because little children generally have a very low muscle mass, and that's normal, their creatinine often varies slightly more than in an adult population just because the hydration status relatively contributes more to their overall creatinine. Okay, so as we've said, because creatinine varies with height, when you see a result that may appear as abnormal on the system, it's quite hard to know whether that result is truly abnormal for that child, especially if they're quite short or tall for their age. So most lab systems, including the one that we use at the Royal London, gives you a normal creatinine based on the child's age. So the age is banded. So in our lab, children between the ages of 6 and 10 have the same normal range for their creatinine. But of course we know that that's a generalisation, because a tall child who's 10 and nearly 11 who has only a modestly raised creatinine may actually have a creatinine that's normal for their physiological size. And conversely, a small 6-year-old whose creatinine is only a little bit high on the lab result may actually have quite significant underlying renal pathology for that result. So the GFR is a way of calculating a more accurate idea of whether this is abnormal or not that takes into account the child's height. So there's a formula you can use, I've put it here. There's also lots of online calculators, and I often use nephron.com, that's compatible with the UK units. And when you calculate the eGFR, a result that's greater than 90 is normal. So in a child who's had a result that appears abnormal on the system, but once you've incorporated their height and recalculated, if the GFR actually is greater than 90, that is very unlikely to be significant renal pathology. That child essentially has normal renal function for their size. Of course, the eGFR doesn't include any factors like the muscle mass or the health of the child. So you have to sort of factor those things in a little bit yourself in your interpretation, but it's a very good correction for height. Okay, so when we think about renal failure in children and we interpret the creatinine, we have to remember that creatinine is only part of the picture. So partly because there is not very much muscle mass, plasma creatinine only starts to rise once there's quite significant loss of renal function. But most children who have renal pathology will have other features to suggest that something is not right, as well as a raised creatinine. Most children will have other features such as hypertension, proteinuria, hematuria, poor growth, and so interpreting the creatinine in a wider context is really important. It's also, as we've said, important to know that creatinine often jumps significantly at puberty. So sometimes a child who's got 2 readings, maybe not separated that far apart in time, but showing a significant jump, if that's coincided with puberty, may also be normal. So what is a good way to approach a raised creatinine in a child? So I think one thing that's important to say is, as we said right at the beginning, children don't tend to have their bloods measured kind of routinely. So often the usernines were done because the child was perhaps not very well or having a blood test for some other symptom. So it's important to ask in the history how they were when the bloods were done. If they were done as in the context of an intercurrent illness, it may well be that actually they hadn't been drinking very much and their hydration wasn't great. It's also important to ask about a history of urinary tract infections, any hint of renal pathology in the past, whether they had normal antenatal imaging or not is really important. In the UK, our antenatal sonography is very accurate and does pick up a large majority of congenital kidney disease, but not all the children, certainly in our local population, had their antenatal care in the UK, and so it is important to ask about whether they've actually had the imaging that would have allowed us to exclude this, whether there's any significant family history of renal pathology, and whether the child's having any urinary symptoms, so whether they've ever had any hematuria or whether they've got sort of dysuria or hesitancy, anything like that. And then on examination, blood pressure is really important. An assessment of height, weight and muscle mass is useful in interpreting the creatinine, whether they're pubertal or not. Again, we've said that that can influence it. What their urine dip shows, just because the presence of proteinuria or hematuria would also significantly raise the question of renal pathology. And then, as we've said, an eGFR is a really helpful way of understanding how that creatinine relates to the child's height. Okay, so which children need referral and further management and which ones are okay? So we know that a sort of well child with a raised creatinine, but normal eGFR, blood pressure and urine dip doesn't require further investigation. But a child who's got a modestly raised creatinine or was a history of being a little bit dehydrated when they had their bloods done, does need to have that test repeated when they're well. A child with a persistently raised creatinine should also have further investigation, even if it's not that highly raised, but if the GFR is less than 90, we should be working out what's going on with those children. As we said earlier, if a child also has other symptoms such as hypertension, proteinuria or hematuria, that makes renal pathology much more likely. And so again, even just a modestly raised creatinine in the context of additional features suggesting renal disease should also be referred. The children who need the most urgent referral are those who have a significantly raised creatinine, so not just kind of 5 or 10% above the expected, but where it's, 1.5 times the normal value, or certainly if the creatinine is rising on repeated blood tests, even when the child has been encouraged to drink well, needs more urgent referral, because those are the children where they may well need an intervention to protect their renal health. So when children are being referred for concerns about renal health, it's really helpful if they can have a renal ultrasound requested if they haven't had one before. It's also useful to do a more full renal panel of blood tests. If those hasn't been requested, we usually do the tests here, including a bicarbonate and PTH, and a measurement of their blood pressure. So in summary, we've said that the finding of a borderline raised creatinine is a common finding, and for many children this may turn out to be physiologically normal. It's normal for creatinine to rise as the child grows and as they increase their muscle mass. But it's important to know that a significantly raised creatinine, a creatinine that is rising between measurements, or a raised creatinine that's associated with other abnormal findings are much more likely to have underlying pathology, and those are the children that need the most urgent referral.
Thanks a lot, Susie. So let's go live, Susie and Shay. Let's have a couple of questions from the Q&As.
Great, Fabs. Thank you so much, Susie, for your talk. We've got a couple of questions coming in. One of the things was about when you would recommend repeating the creatinine. So when we're asked to sort of repeat it, what sort of time frame should we be doing it, mindful of the fact we don't want to sort of frequently bleed children unnecessarily?
Yeah, thank you. So absolutely. So we did say it was important to repeat the creatinine, and I think the first thing to say is how urgently that needs to be done primarily depends on how healthy the child is, whether they have any other clinical signs of renal disease, and also just how high the creatinine was. So in a child who's clinically unwell with signs of renal disease, or a child whose creatinine is very high, so sort of 150% of normal or very elevated, that would of course need to be done urgently, within a matter of days. In a child who's essentially well and only has a modestly raised creatinine, I agree, I think it's good to leave it for a period so that we're not repeating bloods more often than is necessary. So I think certainly if the bloods are done in the context of an intercurrent illness, it should be when the child has recovered and is back to their normal intake in terms of how much they're drinking. So ideally kind of 2 to 3 weeks at a minimum, I think is reasonable.
That's fab. And one of the other questions that came about was, you mentioned about age sort of adjusted creatinine. Is there any adjustment for ethnicity or muscle mass as well? Is that taken into consideration?
Yeah, those are really important things to consider. The normal ranges that are used in our hospital, and also the ones recommended by the RCPCH, don't adjust for ethnicity. And in my experience, it's much more about adjusting for the individual child. So the normal ranges are just by age. And then, as we discussed, you can use the GFR to include an adjustment for the individual child's height. But interpreting that result really, I think, needs to be in the context of the individual child in terms of their muscle mass and their activity levels, but also their pubertal status. So I suppose the kind of typical one is the sort of, a boy who might be referred, but he's actually post-pubertal, very tall, and particularly ones that are very into sports such as rugby often have a physiologically very elevated creatinine compared to the normal range that's probably actually okay. But yeah, there isn't a kind of generic adjustment for ethnicity.
Definitely, that's a really good point you make, actually, Susie, as well. We come across quite a lot of that in general practice. I mean, given the limitations as GPs as well, you mentioned about blood pressure check, and we've got a question here from Jen, who mentioned, would you consider blood pressure check in children essential in general practice? The difficulty sometimes of our GP colleagues is that sometimes we don't have the right cuffs of children for various sizes, and Jen was wondering whether we would refer in any case for that.
I mean, I think it is challenging to get a blood pressure often in children, and especially in the youngest children. And then also sometimes it's difficult if you don't have feel that you've got exactly the right kit, that you can get a sort of falsely elevated result, which then kind of sometimes just makes things harder to interpret. I think in the case of a child who's just got a modestly raised creatinine that you're going to repeat anyway, and who otherwise looks well, doesn't have clinical symptoms of overload, it's reasonable to perhaps leave a blood pressure if you can't do it until you've at least had a chance to repeat the creatinine. I think in a child with a very elevated creatinine, or a child who has any other clinical signs of overload, it is an important test. And I suppose if it couldn't be done in GP, then that would be an indication for sort of referral to secondary care more urgently.
I think we've got one last question. Mark asks, should GPs be doing the ultrasound on all the special bloods, or should we refer to you guys first of all? Would that sort of help you out, or what sort of things would you suggest?
I mean, I think that either is fine. I suppose the thing is that if we see a child, if they've been done, then it's always brilliant, because you're seeing that family with those initial investigations and allows you to kind of incorporate that into the first appointment and the discussion. And sometimes if everything's reassuring, means that that family then don't need to come back and it can all be sorted out in a single appointment. Equally, if those things are difficult to do, or that, but they haven't been done, then that's sort of very much our first step and we can easily facilitate that. So I think either way works.
Excellent. Thank you both. And time to go for the next poll live.
Okay, so the next thing we're going to talk about is urinary tract infection in childhood, which is another really common clinical scenario in children. So we'll talk a little bit about the background of urinary tract infections and why they are something that we worry about, particularly in very young children. Think about the way that they clinically present and how to diagnose them. What are the particular red flags or worrying features in a child or young adult presenting with UTI? And then we'll have a bit of a think about the further workup that's necessary for some of these children. And I'll just talk a little bit about antibiotic prophylaxis at the end and how we think about that. Okay, so urinary tract infection is fairly common in children, and by the age of 11, 3% of girls and 1% of boys will have had at least one episode of urinary tract infection. And the reason why it's so important is firstly because the clinical presentation of a urinary tract infection may be that child's first presentation of a renal tract abnormality, which will need further management and monitoring throughout their life. It's also important because the growing kidney is much more vulnerable to damage than an adult kidney. And so infections that happen to children in early childhood are sometimes the start of renal damage that can lead to really quite significant renal failure, sometimes even end-stage renal failure in adult life, and often in kind of relatively middle adult life as well. So it's really our job as people seeing little children to make sure that we do everything we can to protect their kidneys, because urinary tract infections relatively rarely lead to end-stage renal failure in children, but do sometimes impact on renal health through adult life. Okay, so the clinical presentation is sort of quite varied and partly depends on the severity of infection, but also to some degree on the age of the child. So similar to we see in adults, often it's a very much a lower tract infection presenting with frequency, dysuria, and sometimes incontinence. And really how clearly this presents depends on whether the child is verbal or not, and also very much whether they're toilet trained. So in a non-toilet trained, often non-verbal child in nappies, they may just have episodes of crying or being miserable and appearing uncomfortable, but it doesn't always become apparent to the caregivers that this is associated with the child passing urine. It may just seem intermittent. In a child who's relatively recently toilet trained or hasn't quite got the hang of it, it often presents as a sort of recurrence of incontinence. As children become more unwell, you often get more what's referred to as upper tract signs, where they're more systemically unwell with fever, often loin pain, and rigors are often a feature of these infections, and sometimes vomiting as well is a prominent feature in children. The most unwell children have a much more of a sepsis picture, and sometimes people will talk about urosepsis, but actually these children are kind of clinically very difficult to distinguish from any other form of sepsis, and it should always be a consideration in the acutely unwell child. Okay, so as we know, the best way to diagnose this in the clinical setting is on a dipstick, and it needs to be a clean catch urine, and usually nitrates and leukocytes are strongly sort of specific and sensitive for a urinary tract infection. But it is important to remember that in very small infants, usually under 3 months, but particularly those in the first few weeks of life, don't always make nitrites. So the absence of nitrites in those in that age group isn't particularly reassuring, and any small infant with significant leukocytes should always raise the concern about a urinary infection. Obviously, it's much more challenging in a non-toilet trained child to get the sample, and you do need quite sort of motivated parents to try and get that, but it is really important to try and get a urine sample. We'll talk about that in a minute. I mean, sometimes in a secondary care setting in small children, we'll need to do either an in and out catheter or sometimes a suprapubic aspiration with a needle just to get that sample prior to giving any antibiotics. It's really important that, as well as dipping the urine, that urine does get sent for culture. That's because knowing what the organism is and whether the child's actually had a proven urinary tract infection or not is really key in guiding the further investigations that they need. So we sometimes encounter a situation where a child's had a dip positive urine and been started on treatment that has achieved full clinical resolution, but then it's quite difficult to know where we are. Did that child definitely have a urine infection, and what was it? So even if that's quite difficult to achieve in potentially like an out of hours scenario, that urine can be saved and sent off the next day, and I would really emphasize the importance of doing that in children. Okay, so now we'll just talk about the things that might make us more concerned in the history and examination, that this is not just a simple UTI, but something where there's a bit more going on. So in a child who's had lots of urinary tract infections, or where there seems to be a bit of a recurrent issue or an infection isn't clearing, that needs a bit more investigation. Also a child where they're describing poor urinary flow, so if the urine doesn't come out in a good stream, also suggests potentially underlying pathology. That can be quite a difficult thing to pull out in a child who's not toilet trained, but certainly children who are toilet trained, it's usually something that the parents can give you a bit of clarity on. And then in a child with significant constipation or an abdominal mass, it would make you concerned about intra-abdominal pathology that's limiting urine drainage, or in any child with a sort of hint of a spinal lesion, there's a concern about whether they have got a really normal bladder. And then children with other signs of underlying kidney disease, so children that aren't growing well or are failing to thrive, or if there's any element of hypertension. Okay, so in terms of the acute treatment, most children can be treated with oral antibiotics, and it's a relatively simple thing to treat. It's really important that when children are on antibiotic treatment, you encourage them to have a good fluid intake and to go to the toilet regularly. Some children can get a little bit frightened about going to the toilet in the context of a UTI if there's been significant dysuria, but actually regular voiding does help them to clear the infection, and sometimes it can be helpful to suggest to parents popping them in the bath to void if dysuria is a significant feature. For some children, they need IV treatment. So the children who we would generally always recommend having IV treatment for are those that are under 3 months, just because urinary tract infection in that age group is the sort of highest risk for long-term damage, and also just because oral absorption is less reliable in those very little children. The other things that would give me a low threshold for thinking about at least initiating IV treatment would be the ones that are sort of on the more unwell end of the clinical spectrum, so children with rigors or very significant loin pain, children who aren't really tolerating oral antibiotics, especially if they have a strong element of nausea and vomiting. And then any child where there's known renal disease in the background, just because those children need so much sort of protection to hang on to the renal function that they have, that any hint of a UTI should be treated very aggressively just to preserve as much of their renal function as we can. Okay, so one of the key sort of elements of a urinary tract infection is not just, of course, the acute treatment that we've talked about, but how those children need further workup and investigation, really to look at whether they've got underlying pathology. So most children who have a single UTI with an uncomplicated recovery are at low risk of having something abnormal underlying this and are at low risk of renal damage. So we can be quite reassuring to the majority of children. And we target our further workup to those children and young people who have the highest risk of underlying pathology. And essentially the children with the highest risk are the littlest children and those who have got an atypical organism, or children who are having very frequent UTIs. So when we talk about atypical or typical organisms, we tend to talk about whether they've got an E. coli or a coliform UTI, or whether they've grown something a bit more unusual. So the most common atypical organisms that we see in children are Klebsiellas, Proteases, sometimes Pseudomonas. And really this is why it's so important that the urine was sent off at the beginning, because any of these infections may well resolve with oral antibiotics, but without knowing, which one they grew, it's very difficult to guide how aggressively we need to investigate children. So the three tests that we really do to look at children's kidneys in more detail are firstly an ultrasound, which is really good for looking at the structure of the kidneys and the size. Are they well grown? Do they have cysts? And it's a non-invasive test that we do, for children that we're concerned about. The next test, which are a bit more specialist, is firstly a DMSA, which is a radioisotope scan that looks at uptake of a tracer throughout the kidneys and shows if the child has function of both kidneys that's uniform throughout the kidney, which is normal, or whether they've got areas of non-functioning kidney suggesting that's been scarred or that there's damage. And then the final test that we sometimes request is called an MCUG, which stands for micturating cystourethrogram. And this is a dynamic test that looks at how the urine flows through the system, particularly looking at whether there's any areas of obstruction or whether there's any areas where the urine is going back up towards the kidneys and refluxing. So the investigations and how we use these are set out in the NICE guidance, which I've included for you, but essentially the youngest children, so those under 3 months, need sort of everything. As children get older, so between 3 and 6 months, we tend to only do the MCUG and the DMSA if they've had recurrent infections or an atypical organism. And then once they're over 6 months, it's much less likely, if this is their first UTI, that they're going to have, significant underlying pathology. So those children would all get an ultrasound, but then just a DMSA if they've got recurrent infections. And once children are over 3 years, we can be much more reassuring, because if they've never had urinary tract infections before that, it's very unlikely that they're going to have significant problems. And for those children, we only tend to investigate them if they're having frequent recurrent urinary infections. So I'll just say a final word now on antibiotic prophylaxis. And really the aim of this is to protect children's kidneys while they're in the process of having their investigations done, or while they're awaiting definitive treatment, which is usually surgical. And these are usually started on the basis of either abnormal antenatal imaging suggestive of abnormalities, or by the child having a postnatal infection that is awaiting workup. We usually use trimethoprim or nitrofurantoin. And one thing that's just very important in the littlest children is that because the doses are weight dependent, in those first few months when children are in a really rapid phase of growth, they do need quite frequent adjustments of their dose for their weight, and that's something which is important to keep an eye on. So in summary, we've said that urinary tract infection in childhood is common and important in that it may be the presentation of a renal tract anomaly, or it may indicate that infection in the growing kidney could lead to long-term damage. So it's something that we need to be alert to. And it's also important to say that the investigations required will depend on the age of the child and the type of infection that they've had. Okay.
Thank you, Susie. That was an amazing talk, and you have clarified the UTI quite nicely. Over to yourself and Chief for some more discussion on this, please. Thank you.
Great, thanks so much, Susie. I think UTIs, we could agree, in primary care are very common, and it was good to sort of demystify it in your talk. I think from a practical point of view, and we've got some questions on this, what would you suggest if we're not able to get a clean catch, especially in young children, or any practical tips we can tell parents? Because it's very easy for them to sort of give a bottle and go away and get it, and it's another thing trying to collect it. What would you suggest? Any practical tips for us in primary care?
I mean, absolutely, I agree. And I think we totally see this in secondary care as well, that in the non-toilet trained child, getting a kind of clean catch urine is certainly not straightforward. I mean, I suppose I've always found it really helpful to explain to parents why it's so important in terms of understanding the sensitivities and the organism and how that does influence what they may or may not need in the future. So kind of clear explanation of what we're trying to achieve. And then I suppose being patient, sitting with the nappy off and making sure they've had plenty to drink really helps. And also emphasizing to the parents that we don't need a massive sample. It can just be like, even if they only catch a little bit, that's still super useful and is usually sufficient to get the information we need.
And I guess further to that, for our colleagues working in maybe out of hours or urgent care or in A&E, if we're getting the urine culture on a Friday night or a Saturday morning, how good is it to just repeat it, or keep it, or what sort of things would you suggest if we do?
No, absolutely, and I think it is a real problem, those kind of out of hours samples where the dip is kind of easily achieved, but then you don't have that sort of microbiological sample for the results. So I think it varies. I mean, certainly in the out of hours facility that we have at our hospital, we can ask the families just to bring round a urine to drop in A&E, which then gets sent off, and that works really well. So that might be possible for some people. I think obviously if it's away from the hospital, it's a bit more tricky. The urine can be stored in the fridge for a couple of days, is usually fine. And you can also repeat it, but the thing is you don't want to delay starting antibiotics in these, especially in young children, which is usually the ones that aren't toilet trained. So the younger children, I wouldn't recommend holding off antibiotics, for more than sort of 12 hours, certainly, to get that sample.
Great. And I think another question that came up was so the definition of, I guess, recurrent UTIs. What is it? How many? And when do we sort of refer? How many episodes before a referral for that?
Yeah, and that's also a kind of common question. So I think it is difficult because that's not clearly defined in the kind of NICE guidance. So it does vary a little bit. One thing that's really important is to try to clarify whether the child is truly having repeated episodes of urine infection, because sometimes what's actually happening is that it's just a single infection that hasn't cleared, or they didn't complete the course of antibiotics. So two positive urines very close together sometimes indicates just one prolonged infection. It's also relatively common to see children that are having repeated episodes of sort of urinary symptoms with frequency and dysuria, possibly with some positivity on the dip of leukocytes, but without actually growing a bug. And those children often have more of a sort of vulvovaginitis or balanitis type of picture, where they do have irritation, but it's not actually true urinary infection. But I think certainly in a child where they've had 3 repeated positive urine cultures, that would count as recurrent and should be prompt further investigation.
Thank you, Susie. Those were quite practical tips for us. The next stop is quite interesting. It's on hematuria and proteinuria, but let's first start with a poll just to excite some thoughts, and then we will go to the talk. Thank you.
So the last of the talks is going to be about hematuria and proteinuria, which are again common findings in children, which sometimes lead to a bit of uncertainty about how to approach them. So we'll talk about the causes, we'll talk about what the red flags are and which children need to be seen most urgently, and how we approach it. So hematuria may well be a presentation of underlying pathology, and it can be the thing that families come with, or it can be an incidental finding. And really, how we approach this in terms of the investigations and the differential diagnosis depends very much on whether it was macroscopic or microscopic. So macroscopic hematuria is fairly dramatic, and that's normally the thing that families come with, either in the urine, in the toilet, or sometimes in the nappy in little children. So it's important to think about whether this is actually really blood. Sometimes it's actually urate crystals in a small infant, which are the little orangey crystals that you see, which are normal in the first few days of life. Beetroot also can cause the urine to be red, and sometimes it's the first time the child's really eaten beetroot in any quantity. And of course medications, most notably rifampicin. Trauma is an important differential, and I think that can be perineal or abdominal, and it's also important to consider sexual abuse in this group, just because that's a diagnosis that we really don't want to miss. A global bleeding tendency, such as leukemia or ITP, is important, and these children often will have bleeding at other sites as well, typically the oral mucosa or nose. It can be part of a UTI or urethritis, and nephroblastoma or Wilms tumour is also an important differential in children. As is intrinsic kidney disease, such as a nephritis or nephropathy, and renal stones are another important differential, although relatively rare in childhood. So microscopic hematuria is, generally speaking, a chance finding on a urine dipped for another reason. Again, it can be seen in a urinary tract infection, but it's unlikely to be there on its own. So isolated hematuria without leukocytes or nitrites shouldn't be chalked up to UTI. It's important to consider nephritis in this group, which is a broad group of conditions that involve inflammation of the renal parenchyma. The most common ones in children are henoch-Schönlein purpura or post-strep glomerulonephritis, although there are many others. Allport syndrome or polycystic kidney disease could also be causes, as can local irritation such as vulvovaginitis or urethritis. Because the urine dipsticks are really super sensitive, a very small amount of blood is needed to make it positive or trace or 1+. So even a bit of irritation is enough for these to show up on dipstick. It can also be idiopathic, and there is a sort of subgroup of children who, and through adulthood, who will have persistent low-grade hematuria without any other evidence of renal pathology, and they tend to just need monitoring. And then, of course, there is significant overlap with microscopic. So, with microscopic hematuria, once the macroscopic hematuria clears, it is normal for the dipstick to remain positive at low level for up to kind of a couple of weeks, just because, as we've said, they're super sensitive. So even once it's reduced enough that you can't see it with the eye, it may still be picked up on dipstick. So key points in the history and examination of these children is to think about if there's bleeding at other sites, history of trauma, had the child been unwell, what food and medication have they had, and is the hematuria painful? On examination, we're looking for signs of trauma, excluding any significant abdominal mass is really important, as is having a good look at the skin for any evidence of rashes or petechiae. Blood pressure should be measured, and the child should be checked for signs of fluid overload, and of course it should be interpreted in the context of the other findings on the urine dip. So further workup, so thinking about which of these children need to be seen urgently and which children could perhaps be monitored and then referred to general paediatrics if required. So essentially any child where there's suspicion of leukemia, ITP or nephroblastoma should be seen urgently, as of course should any child with any concern of child sexual abuse. If there's significant hypertension or signs of fluid overload, those children also need urgent assessment and any concern of stones. If a child's had a first ever sudden onset of macroscopic hematuria, we normally see them the same day, just mainly to exclude any renal tumour or stones, and usually we scan those children generally within 24 hours. Children who are having kind of repeated episodes or persistent microscopic hematuria in the absence of signs of pathology do still need monitoring, but they are less urgently in need of being seen. So if there's microscopic hematuria and the child doesn't have any other worrying features, it's reasonable to monitor that over a period of a few weeks. If it's persistent, it should still be seen by paediatrics. If it resolves completely and the child is well, we don't generally need to see those children. At the time of referral, it's really helpful if they can have an ultrasound requested as well as a full renal panel of blood sent. We'll do that otherwise. So proteinuria, like hematuria, is really important because it could be the sign of underlying pathology. It may also be normal. So we'll talk about what's normal, what requires further investigation, and how to approach it. So as I've said, it may be normal, and a small amount of proteinuria is part of a normal sort of orthostatic response. So this tends to be children who've had quite an active day, run around, maybe done some sport, and then at the end of the day will have trace or 1+ of proteinuria. The same thing can occur in fever, and we know that often children only really get their urine dipped when they're unwell, so sometimes you will see this. can also be seen in urinary tract infections. But as with hematuria, it's generally not the only thing in a UTI. So if the child has significant hematuria in the context of also having nitrites, leukocytes and dysuria, I think that's very likely to be UTI. If they don't have nitrites or leukocytes, I don't think proteinuria can be put down to infection. Nephrotic syndrome is an important differential in children with significant proteinuria, and we'll come back to that. And it can also be a sign of renal pathology. And the mechanism here really is that in children with underlying renal pathology, you tend to get a bit of hyperfiltration at the kidney level, and the increased pressure the kidneys are under tends to lead to this renal leukoprotein. And you often see that very early in renal disease before the creatinine has really started to rise significantly. So heavy proteinuria, which is 3 to 4 plus on dipstick, is much less likely to be sort of normal. That's not something that you can really say is just due to fever or running around a lot. That's more likely to represent either a urinary tract infection or significant renal pathology. So nephrotic syndrome is a childhood condition that's a triad of heavy proteinuria, edema and hypoalbuminemia. Usually in children, the most obvious feature is really significant periorbital edema. But the children can get edema anywhere. They can get ascites or pleural effusions, and also often become quite hypertensive. It has a good prognosis overall, but is associated with significant morbidity and some evidence of mortality. And the first presentation of these children should always be admitted and usually managed as an inpatient. So key things in the history examination for proteinuria are whether there's any dysuria, fever, if the child's got a family history of proteinuria or significant renal pathology, if they've had any hematuria, whether they've got any signs of fluid overload and are hypertensive, what the rest of the urine dip shows, and whether there's any edema, ascites or rashes. So as we said, the children who have a possible nephrotic syndrome should all be sort of urgently referred, as we said, they normally get admitted. If they've got features of a UTI on dip or clinically, then that should be treated. If it's less than 3 plus, the child is well with no other worrying features, then the urine dip can just be repeated, usually 3 times over a couple of weeks, aiming to dip the first morning urine, just because that's a good way of seeing if it's going to clear overnight. If it's febrile, it should just be repeated, in a few weeks' time when they're well, and it should ideally be the first morning urine. If there's a lack of certainty over how many pluses it is, or whether it's trace or 2 plus, and sometimes it can be a bit tricky, you can always send a urine protein creatinine ratio, which just gives you a more formalised measure of the proteinuria in relation to how dilute the urine is, and that can be quite helpful in understanding if it's significant proteinuria or not. So children who have persistent proteinuria, even if it's just 1 or 2 plus, should all be referred to general paediatrics outpatients, just because a significant portion of children who have ongoing proteinuria will have underlying renal pathology, and proteinuria may well be the first sign. It's really important to manage these children because actually reducing their proteinuria and monitoring them helps to improve their long-term outcome. So in summary, hematuria and proteinuria are things that crop up relatively commonly in children, and both of these may be normal or may resolve spontaneously, but may also be a feature of significant acute or chronic underlying pathology that needs managing. Thank you.
Thanks a lot, Susie. I'm back. So we've got time for a couple of minutes of Q's and A's. Off you go.
Thank you so much, Susie, for your talk. We've got a couple of questions on the dips and significance of it. So I guess what degree of hematuria on urine dip would be classed as significant? What should we be looking at? Trace value? Should we be sending off MSU first? Or what sort of significance would you say?
Yeah, I mean, I think like we said in the talk, those dipsticks are super sensitive. So it is only the tiniest amount of blood that's needed to make it go trace. So I think if it's just trace in a child with nothing else in their urine dip, who's essentially well, that's relatively unlikely to be pathology if they don't have anything else. And often in those children, it's much more likely it's just a little bit of local irritation. I think if once you're getting into 1 or 2 plus, that is more significant, especially if it's there on repeated dipstick. So if there is an alternative explanation like a urinary tract infection or vulvovaginitis or balanitis, and the child is on repeated testing having 1 plus, then I think that would be cause for further investigation.
Thanks. And we've got a question from Brian. He wanted to clarify one episode of sort of frank hematuria for an urgent referral, but questioned whether it's multiple occasions. I presume this is for microscopic hematuria for a general referral. Would that be sort of what you would suggest?
Yeah, I mean, I think the reason why sort of frank hematuria, macroscopic hematuria, needs relatively urgent referral is just because especially in the sort of younger children, that can be the presentation of a nephroblastoma or Wilms tumor, and often those patients, it's not uncommon for the hematuria to be the only symptom that they have. So a child with a new onset of macroscopic hematuria, particularly if there isn't, I mean, obviously if they have symptoms of a UTI and they've got other things on the DIP, they've got dysuria, they've got frequency, then initially I would treat for a urinary tract infection. But a sort of onset of painless macroscopic hematuria in a young child, we would aim to do an ultrasound within sort of 24 to 48 hours for those children, just to exclude significant intra-abdominal pathology. I think where they've got repeated episodes of microscopic hematuria but nothing else, that does need referral, but less urgently. There's another sort of group of children that we sometimes encounter where actually in the history it does turn out that they have had repeated episodes of possible hematuria, or perhaps the more kind of cola-coloured urine that's associated with renal pathology. And those ones are, if it's gone on over some time, of course, that's less likely to suddenly be a renal tumour. And again, those children perhaps could be referred somewhat less urgently. But I think a very dramatic new onset of macroscopic hematuria is the sort of thing we should be seeing kind of more as a sort of same day or within a couple of days.
Fantastic, thanks, Susie. And in your talk, I picked up, you mentioned about family history, which is quite interesting because that's something that I probably have not really asked. Is there a family history of sort of hematuria, and should we be asking that in children who present with sort of recurrent hematurias as well?
Yeah, I mean, absolutely. So it's relatively uncommon, but both macroscopic and microscopic hematuria can be familial. So either through Alport syndrome, which is sometimes inherited, or through sort of the less common, a wide range of conditions that can cause familial microscopic hematuria. I mean, they all are generally have quite a good prognosis, but in a child who's been identified as having recurrent episodes or recurrent findings of microscopic hematuria, we do normally ask the parents to get their urine dipped, just because if everybody in the family has it and is well, it makes it much more likely that this is going to have a good prognosis and a benign course. And sometimes those families can have genetic investigation to confirm that.
Thank you, Susie and Sheeling. This brilliant, lovely. We have, after this talk, a 10-minute break, and I would want all of you to join this. This is a wellness session. Ritesh Bhai, he's one of a close friend. He teaches breathing exercises in yoga. A very charitable person. He does this every morning for 150, 200 people. So I'm going to hand over to Ritesh Bhai while you enjoy your coffee, but please join the session if you can. It will be really nice. Over to you, Ritesh Bhai. Just putting you on now.
Thank you, Akshay, and welcome everybody, and pleasure to join you. So I'm going to do about 10 minutes of basically breathing exercises, and it's kind of gentle introduction. Some of you may have done these exercises before or are aware of them, and they're kind of beneficial and also helps you with a general kind of calmness and relaxation techniques. Okay, so we do this in the mornings, 15 minutes every day, then it's followed by some exercises. But for this one, so I'm going to just say these are breathing exercises that you do through the nostrils. All of the exercises will be done through the nostrils. Okay, so you can sit on the floor in a cross-leg position or on a chair with the back straight. Relax those shoulders. Okay. Relax the shoulders and just rest the hands lightly on your knees in what they call Gyan Mudra. Okay, so index finger and thumb touching tip like this, and just rest it lightly on your knees. Obviously, you can't see my knees. I'm sitting on a stool, but just rest it lightly and keep the back straight. So what I will do is the 3 pranayams that we are going to go through. I'll explain those pranayams initially, and then we'll do about a few minutes of each one together at the end. So when you're sitting in a comfortable position, the first pranayam is called Bhastrika. Bhastrika pranayam is basically simple breathing. Breathing in through the nostril, out through the nostril. 2.5 seconds to breathe in, 2.5 seconds to breathe out. Okay, and as you breathe in, you just imagine, you keep your eyes closed, imagine that you're taking all that positive energy and vibrations around you, and the whole body is being energized. Okay, if you're doing this in a quiet place by yourself in the mornings, have some gentle, soft music playing, just resting lightly, and this is your own time, getting your mind calm, getting your body set for the rest of the day. So Bhastrika Pranayam, simple breathing in and out. This one, the benefits of this is actually helps you to improve the lungs, okay, strengthens the lungs. It helps with allergies, if you're suffering from any of those, if you have some respiratory diseases, then it helps with that, or thyroid problems, okay. But the biggest benefit is obviously calming your mind. If you feel stress, this is an ideal pranayam to do. Okay, so next one is going to be Kapalbhati, as they call it. It's breathing out through the nostrils, okay? But this is throwing the breath out, gently throwing that breath out through the nostril. If you've never done this before, the simplest way is take your left hand, place it on your stomach, okay? Just feel that where your belly button is, just place your thumb there, just hold it there. And then the right hand, hold it under your nostril. And all we do is just blow the breath out through the nostril. Gentle blowing out through the nostril. You can feel that air rushing out through the nostril, hitting your palm. And as you throw that breath out, you can feel the stomach contracting. Okay, so simple exercise, Kapalbhati. But what that does is when the stomach is contracting, it helps to exercise the internal organs. Pressing down on your stomach, your liver, your pancreas, your kidneys, all of those, okay? So the benefits of Kapalbhati, one of the key benefits is obviously gives you a nice facial glow, okay? So skin feels luminous, okay? Helps with respiratory problems. It's also beneficial for your heart, your lungs, your brain, because you're kind of getting oxygen in, and it's good for your digestive system, okay? And also strengthens the immune system. And the final pranayam is called Anulam Vilom, and sometimes known as alternative nostril breathing. So you keep your left hand in Gyan Mudra resting on your knees, okay? Take the right hand and the right thumb, you close the right nostril, okay? You breathe in for 2.5 seconds through the left nostril. You close the left nostril with middle 2 fingers and breathe out through the right. 2.5 seconds. You breathe in through the right. Close the right nostril, out through the left. Okay, so you keep on doing that, in through one side, closing that nostril, out through the other side. That's Anulam Vilom, as they call it. Anulam Vilom, the benefits of that, okay, and it helps with, helps with developing a positive attitude, okay, helps with clearing kind of blockages in your arteries. I know for experience from individuals that I'm aware of who've had some heart blockages that doing this exercise 15-20 minutes a day really helps them with that, and has helped with that. It helps with lowering your cholesterol levels. If you have suffering from eye or ear problems and orders of the nervous system, helps with those, okay. So these are kind of the 3 main pranayams that we do. Typically in a day, you do 5 minutes of Bhastrika, 15 minutes of Kapalbhati, 15 minutes of Anulam Vilom. So let us practice this together. So we're going to start with Bhastrika pranayam. I suggest you close your eyes, just rest your hands lightly on your knees in Gyan Mudra, and just breathe in and out through the nostrils. 2.5 seconds to breathe in, 2.5 seconds to breathe out. We'll do that for about a minute, okay? So carrying on, breathe in, breathe out. Keep on doing that, breathing in and out. As you breathe in, you're filling up the lungs to the maximum capacity. As you breathe out, you're getting rid of all of the toxins from your body. Okay? 1 minute, breathing in and out. As you breathe in, just feel that energy around you and the whole body is being energized by it. Okay, and relax. Okay, you can open the eyes. So we're going to go on to Kapalbhati. So we do a couple of minutes of Kapalbhati, or a minute and a half. So place the left hand on your stomach, right hand under your nostrils, and just blow the air out through the nostrils. Don't have to blow it out hard, just gently blowing it out. Feel that air hitting the palm of your hand. Don't worry about breathing in, because you're creating a vacuum in your lungs, air will automatically flow in. If you do this for about 15 minutes altogether, then you'll feel really lightheaded at the end of that, okay? But as you're blowing that breath out, you just imagine you're getting rid of all of those toxins, any kind of negative thoughts, negative ailments, all being thrown out with each breath that you blow out, okay? So just relax. We're going to move on to Anulom Vilom now. It's very, very fast paced for this 10 minutes, okay? So Anulom Vilom, just press the left hand in Gyan Mudra. Take the right thumb, close your right nostril, breathe in through the left. 2.5 seconds, close the left nostril, out through the right. In through the right, out through the left. In through the left, out through the right. In through the right, out through the left. In through the left, out through the right. In through the right, out through the left. In through the left, out through the right. In through the right and out through the left. Okay, and relax. Okay, so open your eyes. Normally we do this in a very kind of slow pace, medium pace, but this is obviously a quick experience of all of the kind of pranayams that you can do. Try experiencing this in your own time, 15 minutes in a quiet place. Just close the eyes, have some music playing, and just do 5 minutes of Bhastrika, 5 minutes of Kapalbhati, and 5 minutes of Anulom Vilom, and see the difference. Okay, thank you.
Ritesh bhai, really, really thank you. You've relaxed me. I woke up at 3 o'clock in the morning, so I'm feeling much better. So thanks a lot. I'll see you at 3:50.
Thank you. All right, take care. Enjoy the day.
So the next talk, we're going to go to respiratory, and Chintan's going to host.
Thank you, Akshay. Really, after such a nice breathing exercise, I think it is time to start our respiratory session. We'll start with a quick poll.
Hi, I'm Chin Okoro. I'm a respiratory paediatrician here at the Royal London, and I'm going to give you a bit of a talk through cough, wheeze, spit, and when things don't quite fit. I'm going to talk about wheeze and the fact that not all wheeze is asthma. I'm going to talk a bit about bronchiolitis and croup and when you should be referring both acutely and chronically, and an approach that I like to the chronic cough. So, what is wheeze? Well, to my mind, it's an expiratory whistling sound caused by turbulent rapid flow in the small airways, audible with a stethoscope, and only really rarely from outside the chest. You'll get parents telling you that they can hear their child wheezing from the other room, from outside their bedroom, and that should ring alarm bells. Find out, be clear with them what you mean. Mimic the sound. Do a for a wheeze or a for a stridor, and be clear which one they mean. Check whether they mean stertor from nasal congestion, whether they mean stridor, rattles, or rattly breathing. Ask them if they have a mobile phone recording and get them to play it, send it in at the time. Always important to look at contemporaneous medical records. Many children that come to my clinic with a diagnosis of wheeze, when I go back through the records, I find that no one's actually recorded wheeze, that they've described stridor, that they've described shortness of breath, they've described parental reported wheezing, but actually the children have a diagnosis of asthma and therefore people have assumed, and that sends you down a very inaccurate diagnostic pathway. This is key. You really need to know what it is you're talking about. So having established that not all wheeze is asthma, sometimes it's stridor, that's that inspiratory sound we spoke about. You need to then think about where that might be coming from. And it can basically come from the supraglottic area, as in these images, in the context of laryngomalacia, where you see this collapsing area on the right. Or perhaps from the glossic or subglottic areas, where you might have a laryngeal web, as you see here, between the vocal cords, a hemangioma, or a vocal cord palsy. Or there may be edema of the vocal cords due to reflux or anaphylaxis, or there may be a functional dysmotility of the cords, as we see in vocal cord dysfunction, which we see is often in panic or anxiety in children. And sometimes you'll see it following prolonged or difficult intubation, particularly in the neonatal period, or from irritation from reflux. And then it may be tracheal or thoracic. And the things we're thinking about there are intrinsic compression from intrinsic narrowing from tracheobronchomalacia, allergy or tracheitis, or extrinsic from lymph nodes or a vascular anomaly, as you can see here. When it is wheeze, it's important to consider the causes. Bronchoconstriction is the classic thing we think about in wheeze with asthma or multiple trigger wheeze or episodic viral wheeze. But you can also get wheeze with bronchial edema and secretions, as we see in infection, acute or chronic, cardiac edema, where you get cuffing of the small airways, or chronic aspiration. And also chronic small airways disease with interstitial lung disease, or the ex-preterm baby with chronic lung disease of prematurity. So how do we dig down deeper into this? Well, we take a focused history looking at the early life, whether there was maternal spoking, preterm birth, a family history of wheeze, whether there's neonatal rhinitis or respiratory distress, which might point you towards a specific diagnosis, or whether they had a clear newborn screen, which excluded cystic fibrosis or reduced the liability to that. You want to know about their gastrointestinal history, whether they have signs of reflux or aspiration, whether they fail to thrive or malabsorb, whether they get other infections, either those that might have precipitated this cause of wheeze and cough, or those that indicate immune deficiency, or, for example, the otitis media that we see in primary ciliary dyskinesia. Moving on, you might look at whether they're atopic, whether there is a tendency for them to get worse when they visit a family member's house with a cat, for example, whether there are specific risk or trigger factors, such as food or air allergens, whether there is a seasonality, whether they're exposed to tobacco smoke, whether it's worse when they drink, or when they get viruses, or when they're emotional or upset. Is it worse at night, as you might see with upper airway cough syndrome or gastroesophageal reflux, or an exercise? It's important to look and see even then whether it's when they run or when they bike or trampoline, because the child with severe reflux may be more likely to get wheeze on running than on riding a bicycle due to the lack of perturbation in riding a bicycle. And then it's worth looking at other features such as hypermobility, as evidenced by growing pains, flat feet, intolerance of exercise, and clinical examination, which might point towards the reflux tendency that we sometimes see in this group, or cough, distractibility, anxiety, or other psychosocial concerns which might make you think that this was actually a habit cough. Then you decide, do they have a high or a low probability of asthma? And then you take your next step. Now, there are multiple schemas around available to guide the management of asthma, and you'll be aware of all of them, I'm sure. But I like this. It's one that I put together myself. Once you've decided that they have a reasonable suspicion of asthma, decide based on those symptoms, episodic cough and wheeze, nocturnal symptoms, exercise symptoms, viral symptoms, salbutamol treatment response, whether there's a variation in lung function, whether that's peak flow or FEV1, whether they have other A to P or family history. And then once you've got to that point, ask whether their symptoms are troublesome, by which I mean they're overusing salbutamol, they are impacting on activities of daily living, exercise, sleep, school attendance, whether they are causing them to have over medicalization with hospitalization, oral steroids, or reduced lung function. And if that's the case, I would start treatment with low-dose inhaled steroids such as clenil modulite via spacer. All children should use a spacer, only using a mouthpiece, only using a mask if they are under 5 or have learning difficulties. And then I would reassess with all the features that we used to assess in the first place after 3 months. And if they're better, I would reduce or stop their treatment, and then reassess them again sometime later on. If they're not better, you may choose to escalate their treatment by adding montelukast or switching to a combined long-acting beta agonist with inhaled steroid. And if that doesn't help, then they may be a candidate for onward referral to secondary care. So we've talked about what we do when we think it is asthma. What if we think it isn't? Well, you can break this down into the acute and the chronic setting. The child with rapid onset features, perhaps with stridor, rash or facial swelling, may be with allergen exposure, but perhaps without, maybe with urticaria, maybe with edema, has to be considered to have anaphylaxis and given an adrenaline auto-injector if at all any doubt exists. There's a strong history of doctors not giving adrenaline when they should do, and we need to change this. A more subacute history may, in the presence of a younger but mobile child with sudden onset and maybe a choking history and monophonic wheeze, may indicate an inhaled foreign body. And the steps to take there are rapid assessment with chest X-ray, possibly C-spine X-ray, and ENT referral as a matter of urgency. The consequences of delaying can be catastrophic, particularly in the situation of a button battery or perhaps an inhaled peanut. A more common presentation is that of croup, where there's a clear 1 to 2 day viral history, or perhaps much shorter, with stridor, barking cough, and perhaps drooling. And the response, as I'll talk about later, is calm, oxygen, steroids, and consideration of ENT or anesthesia. And then, of course, we see wheeze and bronchiolitis. And you know what these children look like. And treatment is overwhelmingly supportive management. So what about when we think it's not asthma, but it's a more chronic history? Well, these to me are quite obvious, but it's worth going through them. The child with a wet cough, possible clubbing, chronic chest crepitations and progressive or persistent symptoms, perhaps with specific features such as dextrocardia or steatorrhea or recurrent infections, may well have bronchiectasis and at the least has persistent bacterial bronchitis and will warrant chest imaging, airway microbiology, and perhaps specific investigations targeted at the concern in question. The child with a wet or dry cough, with nocturnal or exercise symptoms, or perhaps postprandial symptoms, with chest pain or epigastric pain, perhaps a long history of regurgitation or vomiting, which may have resolved after the neonatal period, perhaps with hypermobility or a history of tracheoesophageal fistula repair, or with poor or limited drinking, is quite likely to have chronic aspiration. The specific diagnosis will vary depending on the pattern of symptoms described, and the investigations will depend upon the history as well. So they may require an upper GI contrast or an impedance study, perhaps a milk scan, or perhaps simply a trial of anti-reflux therapy in the first instance. Similarly, the child with chronic aspiration from an unsafe swallow may have a wet cough, perhaps abnormal neurology, may have more symptoms with fluids than with liquids, with fluids than with solids, and may have poor oral intake, and would benefit from a speech and language therapist review with consideration of video fluoroscopy, perhaps an ENT or neurology review, and is often treated with thickened feeds or tube feeding. So when we're looking at the differentials in childhood asthma, the key pointers are inconsistent history or clinical features, a lack of atopy, no history of actual wheeze, clear features of other diagnosis such as clubbing or steatosuria, failure to respond as expected to treatment, recurrent exacerbations despite good compliance, and a high symptom score in the context of normal pathophysiological testing. When you see these sorts of features, you need to be thinking that something else might be going on. If in doubt, shout.
Thank you, Chin. Thanks a lot for this. Let's invite Dr. Gupte as a moderator for this talk. And Chin, if you could also, welcome Chin. I can see you live on the camera now.
Hi.
Dr. Gupte himself is an eminent general practitioner, and it would be nice if you could answer some of these questions coming on the Q&A section, please. Thanks.
Okay. Question, are you going to ask me the questions, or where are we?
Dr. Gupte, have you got any specific
Hi, Chin. Hi, everybody.
Yeah.
I could only see one question in the Q&A section, which Akshay has kindly answered. Am I missing something here?
So I can see two. I can see, is there, I'm going to take out my teeth, apologies. Oh, because I can't speak. That's how professional I am. There was a question early on about the initial poll around the number of puffs of salbutamol for a 7-year-old child. First, it's not a poll question that I posited, but the number of puffs of salbutamol depends on what you're trying to treat. In the acute exacerbation, while we've historically done 5 for a younger child and 10 for an older child, we're moving to using 10 at the first line in an acute exacerbation first off, and using 2 if it's a child with a few symptoms but not having an exacerbation. Looking at the questions in the poll, I've got one looking at, is there a role for inhaled corticosteroids for children under 5 with recurrent viral induced wheeze? The answer is yes. And if you go back to the flow chart that I posted, which is based on the ERS consensus document from a few years ago now, what we're really looking at is the lack of a clear either pathophysiological distinction between preschool episodic viral wheeze and asthma. It's not obvious where those things differ. And what you look at is severity, whether it's frequency of symptoms or severity of symptoms. And if your child's symptoms are troublesome, first line is inhaled steroids. I did my higher degree on Montelukast in preschool wheeze, and you guys all know that it did not really show what we hoped it would show. So first line is preschool wheeze is inhaled steroids if it's troublesome. Another question here is there a move to prescribe more environmentally friendly inhalers, dry powder versus MDI, as long as patients are able to safely use these? And that's something that you're using in general practice. What I would say is that in pediatrics, we tend to still be focused on MDI and spacer, primarily due to the best evidence that we have around deposition and therefore efficacy and lack of side effects. I would argue that there isn't really an age where MDI and spacer isn't the best option for delivery. When we move to DPI, it's less about environmental friendliness and more about whether the child is actually going to use the device. And then if you do have concerns about environmental friendliness, you know that we've changed the propellant in these devices to being more environmentally friendly over recent years, and also that there is a scheme now, and I'll post the link later on when I remember it, for recycling of inhaler devices, which is readily available. Just going through, there's a lot of questions coming through. 3-year-old responds well to Clenil, recurs after stopping. Enough to diagnose asthma? Yeah, I would say that it is. Or at least troublesome viral wheeze that needs inhaled steroid treatment. Now, I know the label of asthma is important from a primary care point of view in terms of what is expected. From my point of view, I would say operationally, it's suitable to, it's reasonable to diagnose asthma in that context. Arianna, sorry?
Did you just take the one more and then we kind of move on to the one about the multi-triggered wheeze?
Yeah, so I think I've sort of semi-answered that. It almost doesn't matter. It's about severity, because everyone is triggered by viruses to an extent, and it's severity and troublesome. And if they are troublesome, even if it's always viral, inhaled steroids.
Okay.
Very briefly, wheezy post-COVID, we didn't see it.
Yeah, I just thought probably should we leave the post-COVID to the end of the discussion?
Sure.
Perhaps you could go on to the next talk and then.
Yes, thank you, Chin.
Okay.
Thanks, Dr. Gupte. Indeed, I like the table where you were talking about differential, so I will keep that PDF saved in my folder somewhere to look. So let's go to the next part of the talk. We will start with a poll first, and then we will go straight to the next talk.
Okay.
So what's bronchiolitis? I'm not going to bore you with this. You know what it is. It's a viral infection of the small airways, usually in the under ones, with a short, urty history, followed by shortness of breath, wheeze and crackles. Generally a low fever and possibly reduced feeding, lethargy, apnea. When we're assessing them, we want you to refer if they are hypoxic, if they're struggling to feed, if they are at a stage of the disease, and we know that it peaks at around day 3 to 5, whether you think that they're going to get worse, or whether there are associated features such as the parents being young or unable to cope. Perhaps the child is high risk due to cardiac or ex-preterm birth or neuromuscular disease. We've talked about this stuff already. What we don't want is for you to give them nebulization, antibiotics, steroids, or refer for chest x-ray or beta agonists. We won't give those things. We will give oxygen and supportive therapy via nasogastric tube feeding or IV fluids, and we'll give thought to differential diagnoses. If you're talking about referring in the long-term context to outpatients, the reasons you'd do this would be perhaps if there were recurrent, atypical or very severe episodes, perhaps requiring intensive care or not getting better in the normal time frame, which is within sort of 10 to 14 days. If they had focal findings or persistent cough or other signs suggesting another disease such as rhinitis, dysphagia, failure to thrive or steatorrhea. Looking at croup, again, you know what it is. It's this viral infection of the upper airway, a laryngotracheal bronchitis, usually caused by paraflu or 1 or 3, but also by other viruses. More common in preschoolers, more common in males, with a 3% annual prevalence, peaking in September to December. An upper respiratory tract infection is commonly prevalent, but not always there, and the cough is barking. They are stridulous, not wheezy. They may drool, they may have hoarseness or shortness of breath, and their shortness of breath can look quite scary. They may have fever, reduced feeding or lethargy, and they get worse at night or with emotion. Risk factors for this kind of presentation are prolonged or traumatic intubation, reflux, or following tracheoesophageal fistula repair. Assessing these children, the first thing, as Ian McConaughey tells us always at Mary's, maintain calm. Give oxygen in a non-threatening way if needed, and assess their severity. If they're mild, they'll have the barking cough. If they're moderate, you'll add to that resting stridor or shortness of breath. If they're severe, they may have abdominal paradox. And if they're life-threatening, you can add all of this to upper airway obstruction, which is getting worse, paradoxical breathing, intercostal recession, and fatigue. Who should you send to hospital acutely? Well, if children who are mild, you might just give them a dose of dexamethasone and guidance to safety net so they know when to attend. All others should be admitted. When they're admitted, you need to think about whether they have an alternative diagnosis, whether perhaps they have a high fever, or they appear toxic, or history of foreign body or allergen exposure, which might make you think about anaphylaxis or foreign body or tracheitis or epiglottitis. Whether you might admit them because they're feeding less than 50 to 75% of normal or anuric, or perhaps whether there are social factors that mean that they should be admitted. When they're admitted, we give them dexamethasone, perhaps budesonide if we think that they won't tolerate oral medications, and oxygen, again in a non-threatening fashion. We might give them adrenaline as a way of biding time until we have expert airway support available. If you're talking about sending to hospital to the outpatient department, think about children with recurrent severe atypical episodes. Perhaps those are older or younger than you would expect. Those with features of another diagnosis, such as extrinsic compression, anaphylaxis, reflux, or malacia, or those with a functional or anatomical vocal cord anomaly.
Thank you, Chin. I can see Dr. Gupta here as well.
So allergy testing in the context of wheeze should not be a first-line investigation unless there is a very clear history of an allergen triggering wheeze, in which case, yes, a referral is appropriate and testing is appropriate. If, however, there isn't that kind of situation, you'd go down the steps of treating and seeing if they respond, escalating and seeing if they respond, and if they don't respond, then referring on for allergy testing in that context when you're looking for exacerbating remediable factors.
And there was another one about using soluble prednisolone instead of dexamethasone.
So the guidance that I cited was actually from the NICE guidelines, and dexamethasone 0.15 mg per kg is the recommendation. It does say where that's not available or perhaps unsuitable, soluble prednisolone is an option. The trouble with that I have is that actually dexamethasone is generally far more palatable and better tolerated than soluble prednisolone. So I would go with dexamethasone in the first instance. The other thing that came up in our private discussions was around dexamethasone as per the guidance for mild cases. Why it says to use dexamethasone for mild cases that aren't being referred to hospital, we all know that we don't routinely do that. There is a case for using your discretion, judging the likelihood of the parents to recognize deterioration, your clinical acumen as regards how severe this child is. We all know that children cough and have a creepy cough and nothing happens. So it's not an absolute. Is Pred okay in community? I've answered that. Did I say that athletes get dysfunctional vocal cord? Not athletes per se. I was an athlete back about 100 years ago and I didn't. But people, teenagers particularly, and dysfunctional, and teenage girls in particular, unfortunately this is true, who tend to put themselves under the kind of pressure that enables them to be successful, either academically or in sport, tend to be more likely to get dysfunctional vocal cords. My son has a few intermittent stridor at night, which one start will calm down, didn't take him to A&E. Yeah, exactly. So I think I've answered that. I wouldn't. If the child's got better, they've got better. The peak time with dexamethasone tends to be in the middle of the night. I don't know whether that's anecdotal, but it feels like it's always 2 in the morning. If they're getting better, they're getting better. We've answered that about prednisolone. Don't keep pediatrics. Many practices don't routinely keep pediatric SATs probes. Should we keep those? Yes, you should. I mean, I don't think anyone has any doubt about that. That's a fundamental thing that you should have in a GP practice. For bronchiolitis, yeah, and for lots of other reasons as well, because it's one of the key markers as to whether the child needs to go to hospital. in moderate and above.
I think we can answer some of these questions later as well.
Yeah, sure.
But thanks a lot. Now, you do look like an athlete still, Chindo. Yeah, you do. And thank you, Kaustubh. Thanks a lot for this session. Let's go to the part of the third part of Chin's talk, which is chronic cough. But before that, let's have a poll.
The next talk is around chronic cough. When we talk about chronic cough, we need to know what's normal. And this nice study performed back, I think, in the 80s, measured cough frequency in a group of mid-childhood children, measuring ECG, activity, physical activity, heart rate, audio, and EMG. And they found this sort of pattern. That's to say, children cough on average around 11 epochs a day, rarely cough at night, and that most of them, when they have a respiratory tract infection, will cough for less than 3 weeks. It's worth looking at the frequency of upper respiratory tract infections. In preschoolers, it's around 6 to 10 per year. In the 10 to 14-year-old, it's more 2.5 to 5 times a year, and these coughs are generally self-limiting. So what's an abnormal cough? Well, a cough that occurs at night, that's frequent, recurrent, persistent. What do those things even mean? Duration-wise, well, we can look. There's no international consensus, but the BTS in 2008 suggests that less than 3 weeks is an acute cough. You know, the viral cold that we're so used to seeing. 3 to 8 weeks might be a prolonged or subacute cough, which might make you raise your eyebrows. And greater than 8 weeks would be a chronic cough. Although you can recognize that in Australia or the USA, that might be greater than 4 weeks. So what would I say? Less than 3 weeks, ride it out. Unless, of course, there are pointers to a specific diagnosis that you need to investigate. 3 to 8 weeks, ask questions. Is there a reason I should be paying attention? And if they're greater than 8 weeks, then definitely investigate. How to investigate them? Well, this is an approach to the acute cough, and it's pretty straightforward. If they've got an acute respiratory infection, is it upper or lower respiratory? And treat it accordingly. If they've got acute onset with inhaled foreign body, perhaps with choking, think about urgent rigid bronchoscopy. If there's signs of allergy, then think about allergic rhinitis and treat that. And if they have other signs of chronic illness, such as failing to thrive, clubbing, abnormal chest shape, general ill health, think about whether this is the first presentation of chronic disease. If it's a subacute cough, things are a little bit different. If there are specific pointers identified in the history and examination that make you think of a particular type of illness, such as a post-infectious cough, pertussis, for example, you might just observe and wait. You might do pertussis antibodies, but there's no real need to do so, and see whether they've resolved. If, however, there are specific pointers that make you think something might be going on, then you would go to a chest x-ray. You might look and see whether they had inhaled foreign body. You might look and see whether there was evidence of TB or an expanding or compressing thoracic lesion. You might look and see whether there are other features of a specific chronic lung disease which was just evolving, and investigate accordingly. So investigating the chronic cough, well, you look at history in the first instance. Antenatal history. Did mum smoke? Was there antenatal infection, chorioamnionitis, oligohydramnios, preterm birth? All these things are risk factors. Was the child intubated? Did they have tracheal surgery? Did they have persistent neonatal rhinitis in keeping with primary ciliary dyskinesia? What was their newborn screening result? Do they fail to thrive? Think about their preschool status. Did they have atopy or wheeze? And are you sure that it's wheeze? What's their exercise tolerance like? What's their sleep like? What's their exercise like? Think about the timing. Does it get better when they're on holidays? Is it worse when they're going to school? That might not just mean that a child is malingering, for want of a better term. It may be that there is a particular exposure at school which isn't present in the home. Is there family trauma? Is it worse with sport, with visiting families with members with pets? Was there a precipitating illness? Is it worse with swallowing? Has it got better as they've grown? Do they vomit, arch? Do they sweat when feeding, as you might see in cardiac disease? Is there anything in the family home that puts them at risk? Pets, smoke, damp, air pollution, family history. And then looking at specifics around particular illnesses. Do they have a wet cough or a dry cough? And that one is fundamental. Do they produce sputum? Most children won't. Do they grow atypical organisms? You won't find them unless you perform cough swabs or request sputum samples. And whether they responded to treatment such as antibiotics, steroids or bronchodilators. On examination, look and see whether they have clear signs of respiratory disease such as clubbing or poor growth, Harrison's sulcus, pectus carinatum, barrel chest, eczema or distress. Do they have superficial hemangiomas which might point to hemangioma within the lungs or the airways? Do they have retrotympanic effusions which might point towards allergy or primary ciliary dyskinesia? Are they rhinitic for the same reason? Are they hypermobile which might point towards reflux and aspiration? Do they have lymphadenopathy, organomegaly? What is their abdominal situs? Is the cough a classic cough? Is it wet? Is it dry? Is it honking, which suggests some airway malacia? Do the parents have mobile phone footage of it if they're not doing it in clinic today? Are they distractible? Does the cough seem not quite right to you? When you examine the child, are there focal signs? Is there wheeze? Is there a murmur? Is there stridor? Are there fine crept in a generalized fashion? Is there dextrocardia? Watch them eating, watch them drinking, watch them running. See what happens, what triggers their symptoms. And then breaking it down. The child with a dry cough, atopy, Harrison's sulcus, wheeze, and a family history with perhaps exercise or nocturnal symptoms probably has asthma. The child with rhinitis or throat clearing and hay fever may have upper airway cough syndrome, which is the postnasal drip you're so familiar with. The child with a wet cough or poor growth, steatorrhea, clubbing, other infections may have bronchiectasis from primary ciliary dyskinesia, from cystic fibrosis, from immunodeficiency. The child with clinical reflux, hypermobility, exercise or nocturnal symptoms, dysphagia or food aversion will have possibly chronic aspiration. The child with brassy or barking cough, history of tracheoesophageal fistula or lymphadenopathy may have some airway narrowing or obstruction due to malacia or lymphadenopathy. The child with no clinical signs apart from the cough, who is distractible when you send them into the room with the nurse or when the parents aren't listening, who's quiet at night and whose cough doesn't sound right, just needs looking at a little bit further. The child with a dry cough and clubbing, breathlessness, and perhaps restrictive spirometry and hypoxemia may have interstitial lung disease. And the child with progressive cough, perhaps responding to oral steroids, perhaps with night sweats, B symptoms, weight loss, may have lymphoproliferative disease or tuberculosis. This is a way that I would look at it. The cough is longer than 8 weeks. Exam, history, see what it tells you. Probably needs referral. If it's an acute illness, longer than 8 weeks, exam and history, consider chest x-ray and spirometry and cough swab if you can. If there are specific features that tell you that there's something going on, go and assess those particular features. The dry cough, as I've said, the rhinitis, all of this, these two charts actually describe what I've shown you in the previous page. If, however, they've got symptoms that point towards asthma, then trial them with asthma therapy and see how they respond. These two graphs probably put together my asthma and chronic cough guidelines together and are a useful way for you to consider when and who you should refer. Questions?
Thank you, Chin. Thanks a lot. Over to Kaustubh yourself for some question answer session, please.
Nothing has come through so far. It's been a great session, actually. Absolutely no question.
So there were a lot of questions in the Q&A, but I was typing very rapidly because of the rush. I see something here from Dr. Lennon. I sometimes see GPs giving antihistamines for salbutamol or salbutamol for acute prolonged coughs when parents are insisting for medication. Is there any evidence for this? That question's difficult. Can you hear me properly, by the way? Because
yes.
Yes. Okay. So that it depends. It really comes down to deciding what you think you're treating. If you think that a child has got a cough due to allergic irritation, which is a thing that we see, then a trial of antihistamine is reasonable. And you don't always have the rhinitis and the running eyes in that context. So seasonality might be enough to make you think that, or it happening when they visit the auntie with a cat. By the same token, that that allergic type cough may be responsive to salbutamol. The issue there regarding the salbutamol is when you're having to use that salbutamol several times a week. If you're using it 2 or 3 times a week, then you need to escalate. You need to either deal with the trigger, or you need to institute some preventative therapy. Next question: what would you advise for those with persistent cough thought to be rhinitis or postnasal drip with no improvement with antihistamine? Which, on cue, my nose starts to itch. So there's a question about the dosing of antihistamine and also the use of direct topical therapy with nasal steroids. I like Avamis. My colleague in allergy like Dimista, which is a combination. If they've got eye symptoms, then a Patanol eye drops, for example. And there's also a question around the dosing of antihistamine. You can go up, and I'm genuinely shocked when I walk into the allergy clinic and see them giving doses that are far in excess of what I would normally prescribe. Now, I know it is easier for us in secondary and tertiary care to prescribe beyond the guidelines than it is in primary care. But I would go up, I'd use nasal steroids, possibly nasal lavage, nasal douching with saline, and top dose antihistamine. And if I'm not winning with that, then I might speak to ENT or allergy.
With nasal steroids, there may be sometimes an issue with licensing and under 5. And what do you suggest we do in primary care? Should we still use them without any hesitation?
I would use them in, I mean, it's difficult telling you what to do in that context because I think we're under different levels of regulation in that regard. And I recognize that difficulty. But I would use them in short periods of time, almost as a trial of response. If the thing gets better, you know that that's the answer.
Yeah.
Right. And then if you want to continue it and you feel uncomfortable with prescribing long term, then you might want to discuss it with either respiratory or allergy or you know, ENT, depending on who is the most receptive in your area, about, I guess, backing you up in terms of prolonging that. Because it may be just at the end of the season, or it may be that there's a brief intervention, or it may be about getting rid of the cat. You know. Does that help?
Yes.
Oh,
Any other burning questions, Kaustubh, from your side?
I think Chin has answered pretty much everything, and the presentation was very comprehensive, and it was very, very useful, I think, for primary care management of these conditions. I think we're just about out of time, right? So,
indeed, it was a lovely presentation. I think we are on.
All right, thank you very much, everyone. I look forward to catching up with you when we get through the other side of this pandemic, whenever that will be. Take care.
Thanks for a lovely presentation.
Thanks a lot. Thank you.
All right. Bye-bye.
Thank you. So after this lovely presentation from Chin, let's move on to the topic of allergy. And for this session, the talks are presented by Dr. Anthony Ashton, who is a consultant pediatric allergy specialist at Royal London Hospital. And we have our moderator as Dr. Shaw, who is a very experienced general practitioner. Actually, he's my practitioner as well. So he's very good. So let's first start with a poll, and then we will move on to the talk.
Hello, my name is Dr. Aston. I'm one of the paediatric allergy consultants at the Royal London Hospital. I'm going to talk to you today about cow's milk protein allergy as opposed to lactose intolerance, allergy testing, focusing more on specific IgE as opposed to skin prick testing, and who needs an adrenaline autoinjector. We'll start off with some dairy issues. But why are we interested in the first place? Well, it's the most common allergy under the age of 16 as opposed to adults. But let's start at the definitions. So an intolerance is a digestion problem, not involving the immune system. And so lactose intolerance is an enzyme deficiency. So this can be divided into primary, which is the most common, can appear after the age of 3 years, but tends to be in adulthood as your lactase production falls off. Secondary, perhaps a bit more familiar, after a bout of gastroenteritis or surgery or small intestine is damaged. And the one that causes the confusion is the congenital one, which is rare, even in Finland where it's the most common. It's a gene defect that results in a complete absence of lactase in the child's gut. So when this child has lactose, they develop profuse diarrhea. Now, there are plenty of tests out there, but particularly in the infant age range, they're neither helpful nor practical. So we're left with the lactose-free formula. Now, if you put anybody on a lactose-free diet who is intolerant, they will respond within 1 week. And then when you reintroduce, their symptoms will come back again, and they'll tell you about it within 48 hours. Now, remember, there's no point putting breastfeeding mothers on a lactose-free diet, as it doesn't affect the amount of lactose in their breast milk. So with food allergy, it is an immune mechanism, and it specifically goes after the protein. So a reaction is either going to be IgE or non-IgE mediated. This means it's either antibody or cell mediated. An IgE mediated reaction is the result of IgE sticking to the outside of a mast cell that's in your tissues. When the antigen comes along, it causes cross-linking, which degranulates the mast cell. This produces the symptoms that you know and love. The allergic reaction can affect one body system or multiple, with varying degrees of severity, and you cannot predict any of this before exposure. Now, a non-IgE mediated reaction is a cell-mediated reaction, which means it's slow compared to IgE, and it doesn't produce the same pattern of symptoms. So what are we looking for? So yes, it can contribute to eczema or constipation or reflux. It can cause blood in the stool or contribute to failure to thrive, but these aren't too uncommon presentations in your clinic. So what's going to push you more into a non-IgE mediated school of thought? Well, it's actually the constellation of these symptoms, that these are all present in one patient, that's going to make you think maybe this is part of the diagnosis. Whatever the condition, the history is essential. Now, I appreciate that the people you're getting the history from might not be the best historians in the universe, and neither is the patient, but always, always, always check the weight, because you need to assess the growth. When you're taking your history, consider differentiating symptoms. So what do I mean by that? So let's say the parents tell you that every time the child has some milk, they get urticaria and start coughing. Well, that's going to push you in more towards an IgE mediated reaction. Whereas if they're telling you there's recurrent mucus in the stool with some blood, then you're thinking more non-IgE. And yes, you can get both. Also consider the timing of the symptoms. So if these reactions happens within a few minutes, it's more likely to be IgE, whereas if it's hours later, it's more likely to be non-IgE. And remember, for example, with milk, they're having this on a regular basis, so these reactions can be occurring almost all the time. Also remember to check previous interventions and investigations, as this will help you with your diagnosis. People love tables, so of course I have to have one. So just remember, lactose intolerance only affects the bowel. Both non-IgE and lactose intolerance, you need to do an exclusion trial and then reintroduction. And if you're trying to diagnose IgE, it's mainly on history. Of course, you can do allergy testing if you want. One thing to be very clear though, whether it's IgE mediated allergy or lactose intolerance, neither of these present with blood in the stool. That's only non-IgE. If you're planning on changing the milk, then you need to know all the different choices that are out there for you. So we do get a lot of questions about soya formula, and generally we don't recommend it under the age of 6 months because it contains phytoestrogen, which is a female plant hormone. Now, of course, you might point out the fact that a lot of the population now consumes soya on a regular basis, but unlike adults, babies have 90 to 100% of their intake as a milk, and we simply don't know what that amount of phytoestrogen is going to do to the developing body and brain. Also, as an alternative, it's not great because up to 50% of people with a non-IgE mediated cows milk protein allergy are also allergic to soya, and there's a smaller proportion of the IgE patients that also have a problem. Now, if you are prescribing a milk, you need to know the basics. Now, an extensively hydrolyzed formula is where the cow's milk protein has been chopped up into peptides, and it's tolerated by most of the children who are allergic. However, there are some who are very, very sensitive, where the body still recognizes the peptide as something it should be allergic to, and that's why we have amino acid-based formulas, where all the protein has been chopped up even further into amino acids. So if you are prescribing an extensively hydrolyzed formula, you're going to be doing it for somebody who's got a mild to moderate non-IgE or IgE-mediated allergy. Now, there is one caveat with this. Aptamil pepti contains lactose. Now, the reason for this is it's supposed to make it taste nicer, but none of the other formulas, whether it be amino acid or extensively hydrolyzed, have lactose in it. And so if there are continued problems, just remember that you haven't excluded lactose from the child's diet. Now, the amino acid-based formulas are generally for more severe disease or people who are reacting to microscopic amounts. And we tend to use it more in those children that we feel that the faltering growth is due to an allergy, because we don't want to muck around and we want to get them growing again as soon as possible. If you're looking for some guidelines regarding prescribing, the International Milk Allergy and Primary Care Guidelines are helpful, but you will also have local prescribing guidelines, as your CCG will have made a deal with one of the companies to get some of the formulas cheaper. If you look at the amount we're prescribing and consider, for example, Neocate is £38 a tin, these things can be incredibly expensive, particularly the amino acid-based formulas. Remember to always tell the parents, these things taste and smell disgusting. You and I wouldn't touch it with a barge pole, and the only reason babies can is their taste buds are immature. Also point out to the family that at least for the first couple of weeks, they can get some loose stool, which is perfectly normal as the gut adapts. There are a few things you can do with gradual introduction or adding things to help with the taste, but persevere as we don't have any other treatments. We do get a lot of questions about animal milks as well. They're often very similar to cow's milk. So for example, 92% the same in goat milk. And so we don't advise it as an alternative. And also remember that lactose-free products still have milk protein in them. So if you're milk allergic, you will still have a problem. What this is not is the answer to colic. This is part of the differential diagnosis. And so when you're trialing a change of milk, that's fine, but try and avoid this resulting in a massive exclusion for both mother and child. And remember, if you are trialing a milk, like any medication, if it doesn't work, you can stop it and reassess. From a timing point of view, remember that colic starts to decrease anyway from the age of 3 months, and reflux can improve with the introduction of solids. So there's a lot to do, but there is help. And this comes in the form of the International Milk Allergy and Primary Care Guidelines, which cover diagnosis, management, reintroduction, and referral, all in 2 A4 slides, but also have additional support tools for both health professionals and for parents. So in summary, lactose intolerance is rare in babies. A short exclusion trial can help you make a diagnosis. Non-IgE, longer exclusion trial, as allergy tests don't work. IgE, usually based on history to make the diagnosis, but you can do allergy tests. Be aware of your local prescribing guidelines because this will help you. And consider reintroduction for mild to moderate non-IgE and the Milk Allergy and Primary Care Guidelines will help you.
Thank you, Anthony. That was really a nice talk. I can see there are a few questions coming on the Q&A side, so would be nice if you could throw some light on them. I would also like to invite Dr. Dave Shaw to join as a panelist.
Okay, so I've tried to answer some of the questions that were put out on the Q&As. A lot of them about the lactose intolerance as a diagnosis for breastfed babies. Let's be very, very clear. Congenital lactose intolerance is very, very rare. So it is not my go-to point when I see someone with concerns regarding colic and things like that. Also remember that manipulating the mother's diet will not reduce the amount of lactose that is in the breast milk. Remember, the lactose is actually being broken down in the gut by the lactase enzyme, which is what people are deficient with, that causes lactose intolerance in the first place. Okay, so manipulating the mother's diet, not going to be helpful. Now, someone was asking, well, what else do we do? If it does actually turn out to be congenital lactose intolerance, I would have a discussion with your secondary care team before stopping breastfeeding, if possible. If it's such a significant problem that they're failure to thrive, you will be talking to the general pediatricians and the allergists as quickly as possible anyway, and they will be seen urgently and should be seen urgently.
Hi, Anthony. Can you hear me?
I can hear you.
Yeah. That was a very informative talk. And as you know, allergy is one of the up and coming thing. They say in the UK, we have trebled in prevalence in the past 30 years. About 50% of children have got some form of allergy or atopic condition. My question is, in patients with cow milk protein allergy on hydrolyzed formula, after what interval do you do a challenge? And is it the same for IgE and non-IgE type of allergy?
So there, in terms of the non-IgE, the International Milk Allergy and Primary Care Guidelines do provide you with some advice, but generally people tend to say about 6 months after you started the extensively hydrolyzed formula. For the IgE, that's more complicated because you need to do this as a challenge in hospital because it needs to be done under safe conditions. So to be honest, for those ones, you'll be referring to your local allergist to be able to do this safely. I wouldn't expect any primary care practitioner to undertake an IgE mediated food challenge at all because it's not safe to do so. But the non-IgE, there's lots of information in the guidelines from the International Milk Allergy and Primary Care to help support you in that.
Fantastic. I noticed you have answered lots of the questions from the audience regarding diet in adjusting diet in intolerance and lactose intolerance in the mother, which has no value because the breast milk contain it. A question again on cow's milk protein allergy. In patients, in an earlier question you answer, you said that children who are exclusively breastfed can get cow's milk protein allergy despite the mom avoiding milk in the diet. Would you recommend, if those children are symptomatic, would you recommend hydrolyzed formula, or is there a role for straight to amino acid formula?
So in answer to the poll, when we were talking about children with extensive failure to thrive, eczema and things like that, we actually would go straight to the amino acid based formula rather than kind of trial and extensively hydrolyze, because we want these children to start responding quickly. There is such a small amount of cow's milk protein in the breast milk, and even less if mother has taken it out of her diet, that we would actually recommend going straight to the amino acid based one, to be honest with you.
Fantastic. I think I think that's about it. We have answered lots of the questions.
One person has asked about what milk protein allergies. If you look in the additional information on the PDF I provided on your, it's not actually in a talk, it tells you about the association between cow's milk allergy and any kind of beef and something like that. It's actually more like 10%. And the other question is more about changing mother's diet. Yes, it does make a difference for cow's milk protein, because the protein is present and absorbed from the gut and then in the mother's breast milk, whereas the lactose, you're not allergic to the sugar. It is a problem with an enzyme deficiency in your gut.
Thank you.
Fantastic. Lovely.
Thank you, Dave. Thanks a lot. So let's move on to one more poll, which will be followed by the second part of Anthony's talk.
Okay, so we're going to talk about allergy testing now. But let's be clear, without any history, allergy testing alone is just a guessing game. Because what are we used to? We're used to having testing where we can look at a patient and go, this one's got renal impairment. And this other patient's also got renal impairment that's worse. So we can get some bearing on severity and compare between patients. We then have tests that are very specific. And so we like that specificity. But allergy tests don't have this. When you have a test that's positive, what exactly does it mean? And if it's even more positive, what does that mean? It's not as good as we would like it to be. Now, as you are well aware, there's both specific IgE testing and skin prick testing. Both of these have problems, but in terms of availability, in primary care, skin prick testing is a rarity, whereas specific IgE is far more common, so we're going to talk about that. But first, non-IgE reactions. Again, they are cell-mediated, which means skin prick testing and specific IgE testing will not detect them. The only validated test is the elimination diet and reintroduction. So what are we actually testing? I know you've heard about RAS tests in the past, and now we have specific IgE that can measure to a lower level. But what are we actually testing? So we're testing the specific IgE that's floating around unbound in the bloodstream. But hold on a second. The thing that causes the reaction is the mast cell with the IgE that's in the tissues. So aren't we measuring the wrong thing? So what can you actually send off? Well, you can send off a total IgE, but let's destroy this myth right now. A total IgE is not a screening test for allergies. You can manufacture IgE to any antigen. So you can make it to Staphylococcus aureus or filaggrin, one of your skin proteins, and it has no clinical relevance whatsoever. In a similar manner, you can manufacture IgG to food, and there is no immune reaction to these foods. So when you send a total IgE, it is like sending a jigsaw box with no picture on the front and shaking it. You have no idea what's inside, and you have no idea if it's got anything to do with allergies at all. To make things even more complicated, if you have high levels of IgE, which is very common in patients with eczema, you can get false positive specific IgE results. So what do I mean by this? So what should be happening is your specific IgE is like this message, very, very clear and straightforward. But then you have lots and lots of total IgE that non-specifically binds to the test, and you end up with lots of false positives and trying to work out exactly what the message really is. Also, if you have very low levels of total IgE, then you can have false negatives, which is why history is so important. The literature is a little bit vague, but basically anything below the level of 5 as a total IgE risks false negatives. A lot of people use IgE mixes. On the face of it, makes sense. You can have a nut mix or a food mix, and you test for lots of different allergens all at the same time with only one test. Sounds great. But what does it actually mean? Okay, so we've got patient 1 who's allergic to peanut. You send off your nut mix. You get your result. Okay, it's positive. Now you have patient 2, who's allergic to peanut, hazelnut, and cashew nut. You send off your nut mix, and you get the same result. So, what does this mean? It means that if you have a positive result, the person is sensitized to one or more of the foods in the mix, not all of them. So they are not allergic to all the foods within the mix, and you don't need to take every single food out of their diet. Theoretically, the specific IgE should work well. These are antibodies that bind to a specific allergen. If they are around in greater than 0.35, then historically this was a positive result. The new specific IgE test, as opposed to the RAS test, can test well below this, which is why you're getting different numbers, but we still use the historical value for a positive result. So what do these actually mean? It tells you how likely the person is to be allergic to that food. That's it, on its own, nothing else. It doesn't have any bearing on the severity of any reaction. It doesn't tell you how little food is going to set them off. It doesn't allow you to compare patients, and it doesn't even allow you to compare different foods in the same patient, because it's all different. So, if we have a level above 0.35, positive result, and we have no history, all I can say about any patient is that they are sensitized, i.e. there is the presence of specific IgE. It does not mean they're allergic, not without more information. However, if we have a raised specific IgE and a clear history of reaction to that food, then they have been diagnosed with an allergy. So, if you find raised specific IgE and there is no history of any acute reaction when they eat that food, that person is tolerant to it. Now, there's a lot of research into this, and we suspect there's an IgG4 subclass and a T regulatory cell that inhibits the allergic reaction. Problem is, there is no test for this, so it's interesting but not practically relevant. What is relevant is if you take the food out of the diet of someone who's tolerant, there is a risk they could lose that tolerance if you do a long-term exclusion, say 6 months, 12 months, that kind of thing. So there are risks involved with unnecessary exclusion, because what we're trying to do is improve the quality of life for these poor people who have food allergies. So if we have a patient who has never eaten peanut, and we have a specific IgE test, all this tells us is that he or she could be allergic because it's above 0.35. If we have another patient who also has never eaten peanut, but this one is a higher test, without any history or any more information, all I could say is that it's more likely that this person is allergic to peanut. We do get questions about age and testing, but basically you can do a specific IgE test on anybody above 6 weeks of age. But remember, doesn't matter what age, if the history is consistent with an IgE-mediated reaction, a negative test does not rule it out. Now, we do a bunch of tests, we get a bunch of results, lots of different numbers, all very confusing. I think we should make it easier and just say it's positive or negative. So, if you're investigating a history of an IgE-mediated reaction and the test is positive and the history is convincing for that food, then you assume they're allergic and you tell them to avoid that food. But if the person is still eating that food and there's no reaction, well, then they're tolerant, so they should keep it in the diet. If, however, they've never had it before, the problem with the test is it says they are likely to be allergic, which means they need to avoid it until they are seen by an allergist. Now, If you're investigating a potential IgE-mediated reaction and the test is negative, then if the history is convincing for that food, you still assume they're allergic and tell them to avoid it. If they're still eating the food and there is no reaction, then they carry on eating it. And if they've never had it before, the chances of them being acutely allergic are very low, and there's no need for them to avoid it. And so this is what you all came for, which is a table to allow you to work out how to interpret allergy tests. However, it still looks complicated to me, so I've made it a bit simpler. But remember, you have to correlate the results with the history, and a very high total IgE, say above 500, or very low total IgE, say below 5, will affect the accuracy of your results. So, allergy tests are very limited without an allergy-focused history. Total IgE is not a screening tool for allergies. Specific IgE tests do not relate to severity, how much will cause a reaction, or have anything to do with non-IgE mediated allergies. And the tests are there to provide evidence to support or potentially refute the history. And remember, the gold standard is a food challenge. So if this person is eating the food already, they cannot be allergic if there's no reaction happening.
Thank you, Dr. Austin. We've got some lovely questions which you have answered earlier. Just a few others. If a food is never eaten, would a RAS test or specific IgE test be helpful since there is no prior sensitization?
So this depends on what you're asking there. If you're saying, I want to do this test before feeding this child, then what the presence of sensitization will mean that there is a possibility that the child is allergic. But then you have to assess it in the context of, is there a very high total IgE, which means is this test potentially falsely positive, and we shouldn't necessarily exclude it. If, of course, the test is negative, then you can turn around and say, actually, the chance of them having a severe allergic reaction as a result of trying this food is, less than 0.01%. So I'm happy for you to try it at home.
Okay, fantastic. And this is from experience in my own practice. I've got children who are asthmatics and eczema. Parents would come to you and say, well, I'm not quite sure if there's a food that is contributing to their symptoms. However, they've been eating, and for instance, nut. You send them for the RAS test. It shows that they are not positive. However, they have been eating nuts. Would you then recommend that they withhold the nut with the intention that they may lose tolerance? Or would you say, carry on as you are?
So one of the questions came up on that as well. The thing about exclusion trials is they are a test so that they come across as you exclude for a certain period of time. So nice guidance is 4 to 6 weeks, and then you reintroduce. Now we know that a lot of people are very reluctant to reintroduce after they've tried this, but that is the standard that we are supposed to follow. Now, if they exclude for 4 to 6 weeks, we are not worried about them losing tolerance. We are worried about people losing tolerance if they've excluded for 6 months, 12 months, or several years. It does take time to lose this tolerance. So the exclusion trials are not risks in terms of losing any tolerance that's there. And that's why they are part of the NICE guidance when you're looking into these things. But what we would make it very, very clear is if you don't see any improvement, you put it back in.
Yeah, fantastic. Just confirm here, it says for allergic eczema, IgE testing is not helpful. Is that correct?
So that's a very big question, because of course I get a lot of people coming to my clinic about that. So the point about IgE testing in patients with eczema is it's all about interpretation. So if the person has a history of acute allergic reactions, it doesn't matter whether they got eczema or not, the testing is useful. If you're doing it because you're trying to find, is the food causing the eczema, the answer is no, as long as there is no history of any acute allergic reaction. Because what you're worried about in patients with eczema who don't have acute allergic reactions is non-IgE mediated allergy, which doesn't come up on the skin prick test and doesn't come up on the specific IgE test. It's very different.
Lovely. I think you have touched on this. There is one last one here. If the patient from Zeneb, if the patient has raised specific IgE, but no acute reaction, and so deemed tolerant, what's the risk of going on to have an acute reaction in the future?
So if they're already eating it,
yes,
then it is very unlikely. However, as one of the questions was already there about developing allergies later on, we do find that some people quite often after severe illnesses can break their tolerance, and things they were able to eat before, they suddenly can't. So we don't have any actual figures, but all we can say is if you can eat it, carry on eating it.
Brilliant. Lovely. Thank you.
Thank you, Anthony. That was an eye-opener talk. We have already done the poll on the auto-injector, so let's go straight to the presentation.
And finally, who gets an adrenaline pen? If the person is having an anaphylactic reaction, you give adrenaline. Don't do what a lot of families have done, which is give the antihistamines and wait and see, because they're scared of giving the adrenaline. There are plenty of guidelines out there throughout the world. They generally provide some definitions for anaphylaxis, all of which quite scary and life-threatening. Okay, so definitions are all well and good, but what am I going to do in terms of assessing someone if they have anaphylaxis? Now, you need as much information as possible, which is why you need to take an allergy-focused history, because let's say we look at these two photographs. Which child is having anaphylaxis? And I don't know. The child on the left has a swollen lip and some rash, but I have no idea whether they're wheezing or they're having stridor or their blood pressure is low. And whereas the child on the right, they might be in intensive care, but they might be there for another reason and they're just having an allergic rash due to a drug allergy. Whenever you're making a decision about an allergic reaction, you have to assess it for severity. Now, as with many things, there is a spectrum of severity from mild to severe, and we tend to call the severe ones anaphylaxis. But we've just had a series of guidelines that talk about life-threatening and things like that. They're not all life-threatening. This is why, actually, anaphylaxis has its own spectrum. So you've all heard of the term anaphylactic shock. Well, that's the severe end of the spectrum for anaphylaxis, presenting with hypotension and shock. And these are the symptoms we're looking out for to help us make a decision whether this person has anaphylaxis or not. Now, most of the time, you'll be assessing this retrospectively using your history, but these are the things you're looking out for to give you an indication, did this person have an anaphylactic episode in their allergic reaction, or was it less severe? There are plenty of algorithms out there, and even some that tell you when to prescribe adrenaline and when not to. They all look quite complicated though. There are plenty of national guidelines as well, with lots of caveats about when to prescribe and when not to prescribe. But practically speaking, you're going to provide an adrenaline auto-injector if somebody's had anaphylaxis before. If they had it once, they can have it again. So whenever you're taking a history, you're looking for any of these signs to give you an indication that this person had anaphylaxis. It's not due to the severity of a particular symptom, like if the lips swelled up a lot, that's not an indication of anaphylaxis. If the face swelled up, that's not an indication either. If the throat felt itchy, no. We're looking for other symptoms on this list. Another reason you'll give an adrenaline pen is if the person has had an allergic reaction of any severity and they have asthma. This is because almost every single person in the country who has died from a food allergic reaction had asthma, and even those who didn't had some form of respiratory problem while they were having their allergic reaction. So if your patient has asthma, they are far more likely to have a severe reaction, even if the asthma is mild. But the more severe or uncontrolled the asthma, the more likely, if they have an allergic reaction, that they're going to have a severe anaphylactic reaction. You're also going to prescribe it if they react to traces. So let's say, for example, I buttered my toast with peanut butter. I then cleaned it somewhat, and then I buttered my friend's toast with normal butter, and then he or she had a reaction, even if it was just a bit of lip swelling. So they reacted to microscopic amounts of the food. God knows what's going to happen if they eat a dollop of the stuff accidentally. So who actually gives an AAI? Well, if you've presented to A&E and been diagnosed with anaphylaxis, then the A&E department should give them an adrenaline auto-injector to go home with. They will then ask the primary care team to prescribe the rest. Now, if you are referring someone after an allergic reaction to an allergy service and you think that they have had an episode of anaphylaxis, then as part of safety netting, they should be prescribed an adrenaline auto-injector for safety reasons, to make sure that if they have another allergic reaction while waiting for their allergy appointment, they can treat it. So if you've prescribed an adrenaline auto-injector, you need to teach them how to use it. Now, yes, the instructions of how to use it are on the side of every device, but nobody actually reads it in an emergency. There are other resources out there, but nothing can compare with an actual demonstration in front of the family. Yes, there are videos produced by each company, which means that the family can look at them again once they get home. You can get trainer pens for your practice, or the family can get them so they can teach other family members. And don't forget about your pharmacist, because the dispensing pharmacist will have the opportunity and very likely the knowledge of how to show them how to use the adrenaline device. So it's always worth speaking to your local pharmacist to see if he or she will do that for you. Why is this so important? Well, because people are human and we make mistakes. So you may mislay your adrenaline when you're having your allergic reaction. And this is one of the reasons we tend to prescribe 2. And another reason is people do make mistakes in terms of how they use it. So if you can see, this little mark here is where the needle has gone into the finger. And the reason those 2 fingers are white compared to the other fingers is because the adrenaline has been injected into the fingers as opposed to the leg of the person having the allergic reaction. Why are we so concerned about calling an ambulance afterwards, though? We're just boosting your naturally occurring adrenaline. And adrenaline works very quickly if it's going to work. But remember, it does wear off, and the allergic reaction may be continuing to go on. So the reason we're actually telling people to call an ambulance is because the ambulance will have more doses of adrenaline if the patient needs it, not because the adrenaline being given is dangerous. So, why is this important? Well, to illustrate this, I'm going to use some research where they actually got someone who's allergic to bee stings and then stung them and then checked their observations afterwards. So, they're stung by the bee, their heart rate goes up, the blood pressure goes down, the adrenaline is administered, and then within a few minutes, things start improving almost back to normal. And this is what we hope most of our patients who have to use adrenaline experience. But this isn't the same with everybody. This is another patient in the same program. So after being stung by the bee, the blood pressure drops, the heart rate goes up, they're given a dose of adrenaline. There's a little bit of improvement in the heart rate, but blood pressure is still low, so they get another dose and another dose. And there's a bit of improvement, but still not enough. And there's another dose and another dose. And it carries on until eventually they have to put the person on an adrenaline infusion. Now, our problem is we can't tell the difference between these two patients. There's no blood test, there's no skin test that's going to give us any kind of indication what's going to happen if they have a severe allergic reaction and how many doses of adrenaline they're going to be given in order to respond. And that's a problem. And we tend to hear about it when it's plastered all over the news. Now, always remember that in addition to prescribing adrenaline, you also need to give them an allergy management plan. These are freely available at the British Society of Allergists and Clinical Immunologists, and they come in each form for the adrenaline. And they're free, they're PDF form, they're printable, and free text. So you can fill them in with the child's allergies and give it to the patient then and there and keep a record for yourself. In terms of taking adrenaline away, to be honest with you, just let us do it. So in summary, there are plenty of guidelines about when to prescribe adrenaline. Always consider about prescribing it if you think they've had anaphylaxis or at risk of having anaphylaxis. And if you have prescribed it, please train them how to use it. And don't forget, always give them an allergy management plan as well.
Right. Thank you, Aston. I think that was very informative and interesting. There is always this blurred area in general practice where we are not quite sure when to prescribe the adrenaline auto-injector, and simply because you have patients who have some form of reaction, not quite severe enough. However, you may send them off to secondary care, but in the interim, while you're awaiting that, the parents are demanding, I need to get that because I don't want it to be more serious. Now, given the fact that in the UK, we have quick access to hospital and healthcare, lots of times the severity of the condition is arrested early. What would be a little rule of thumb as to when do you say, fine, I have no hesitation in giving you an injector for now?
So this one's always a tough one, but although we have close access to treatment, we still have to stick with the national guidelines. So if the child has had an episode of anaphylaxis, then they automatically get an adrenaline pen. If there are risk factors that make you think that it could trigger the asthma exacerbation, then they have to get an adrenaline pen. If you're faced with the incredibly anxious patient or parent who says, I'm sorry, I must have an adrenaline pen, I'm very, very worried, and so on and so forth. Yeah, I mean, what you can do, yes, is prescribe it, and I will then talk to the families in clinic and I will explain, look, actually, it's not necessarily needed. You know, the indications for this are this, this, and this, and we can then work with the family to kind of take this crutch away from them. I appreciate, though, it's a very difficult situation for you, and while the guidelines are helpful to some degree, it doesn't help you manage the anxiety that allergies produce necessarily. The anaphylaxis campaign does provide you with a lot of useful information that you can give to the families and they can read up on, so that they can understand, you know, the actual very, very, very low chances that an anaphylactic reaction will actually A, send you into hospital, and B, you know, end up dying from it. You know, to be honest, you've got more chance of getting struck by lightning. But you know, this is a process. All they've been fed is what's in the media, And so it may be a question of you start and give them one, and then I continue the discussion and probably take it away. But it's what works for that particular case.
Fantastic, thank you. There's a question here from Mark. Would you give a beekeeper who's never been stung an EpiPen if they ask for one, given that they will probably get stung sooner or later?
No.
I mean, I suppose it's costly, and we have to be a bit cognizant of that. Okay, another question here. Would you consider antihistamine or steroids, as in prednisolone, as adjunct to treatment in the sense of prophylaxis, or patients going abroad, camping, where they would not access healthcare?
Okay, so definitely anybody who is traveling, we would definitely advise them to take some antihistamines and their adrenaline. If they are traveling somewhere where, actually accessing medical care may be several days away, then they need to be very careful. They need to, basically prepare as much as possible. If there are language barriers, they need to try and circumvent them as best they can. And so they need to really think about what they're going to do when they do travel. Unfortunately, there's not a lot of evidence based for the use of steroids. I know they're in the APLS guidelines, but we really don't recommend that they're that much use. And so I wouldn't prescribe them if someone's going traveling. What I would do is make sure they've got an up-to-date allergy management plan. And it's also worth knowing that there is a medical authorization form on the BSACI website that's free, and you can print it off and give it to the families so that they can actually get on the plane with the adrenaline pen. But the short summary to your question is, yes, take your stuff with you, because if you have an allergic reaction, you'll need it.
Fantastic. There's a question here from Osman Ali. Any comments on the expiry of pens and how long post-expiry can we safely use them?
Okay, so unlike food, which goes off and will make you sick if you eat it, the adrenaline pens just get weaker afterwards. Now, it's not a particularly hard and fast rule, but generally what we're saying is you've probably got about 3 months after they expire. But obviously we try and avoid that as much as possible. But yeah, around about 3 months. And then there's
lovely, and I think this one is straightforward. I think I can answer this from Emma. Should all patients with a history of anaphylaxis be referred to allergy clinic? I would say yes. Would you agree with that?
Yes, sadly so.
Yeah, okay, lovely. And the other one, if a child has facial swelling to food but no signs of anaphylaxis, they may not need EpiPen. But even if we still refer them to the clinic, I thought we touched on that a little bit. If you're, yeah, lovely.
I mean, it's kind of the flip side of Emma's one. Yes, you can refer to allergy clinic if it's not anaphylaxis as well. This child may have multiple food allergies, and so we need to get them checked out.
Okay, my last question then. In terms of continuing issuance of the pen, if somebody haven't had any real reaction for 10 years, but they keep renewing their pen ever so often, when would you say it's about time we probably don't continue giving this prescription?
So this is when you send them back to us. Unfortunately not. And unfortunately, testing is not going to solve them either. So no skin prick test or specific IgE. What you want to do is you want to go, okay, send them back to the allergy clinic. The allergy clinic will make an assessment and then we'll challenge. And then if they pass the challenge, they no longer need the adrenaline pen. Now, if the assessment when we do the testing is actually things have not changed and there's no point in actually taking them forward for a challenge because we feel they'll automatically react, then we will just advise you actually it needs to continue for the time being. So it's basically send them to us.
Brilliant. Do we have time for more impromptu questions, or are we?
I think it's time for lunch. everybody would be waiting.
Okay, thank you.
Thank you so much for an informative talk, and that was an interesting discussion. But I would also want to know, when would this crisis of this auto-injector end? Because it just seems like the pandemic, it's just not ending. I hope it ends soon.
You and me both. You and me both. Don't know.
So let's break up. Let's break for lunch. We've got 50 minutes for lunch. We will be back online here at sharp 1:40. And let's see you then. And the host at that time will be Shruti. Thanks a lot.
Hi, good afternoon, everyone. Well, I really sincerely hope you enjoyed the morning session, had a good lunch, and all set to go for the afternoon talks. A good lineup of talks. Your host for the afternoon is going to be Dr. Shruti Ganatra, and the first talk is going to be by my close dear friend, Dr. Chintan Singh, on 6-week baby check and heart murmurs. So off you go, guys.
Thanks very much, Dr. Jain. Let's take it away with the next talk. Just a quick heads up to everyone. I'm going to give you just a few seconds to grab yourselves a pen and piece of paper, because the next session is super interactive. So we're going to start off, instead of a poll, with giving you a chance to grab yourselves that equipment for the very exciting session on 6-week check by Dr. Chintan Singh.
Hello, good afternoon, everyone. I hope you're having a good day, and I hope you all have had some lunch. My name is Chintan Singh. I am a pediatrician and a neonatologist. I work at North Middlesex Hospital. I have a special interest in cardiology. The reason why I'm here today is to talk to you about two specific things, and they are 6 weeks check in a baby and what not to miss. And the second topic that I'll be talking about would be heart murmurs in children and how to make some sense out of it. Now, the 6-week check of a baby includes examination of heart and heart murmurs, but I would cover that part of my topic in the heart murmur part of my presentation. So let's start with the 6 weeks check. Now, this is the content of my presentation. But essentially I'll be talking to you about the clinical stuff, as well as we are going to have an interesting quiz in between. I would also touch on missed cases communication, and as well as give you some resources and links where you could get further information and training. So what is 6 weeks check? 6 weeks check is essentially NIPE, which means neonatal and infant physical examination. Now, every baby should have NIPE done 2 times. The first time is within the first 72 hours of life, and this is a primary responsibility of the place where a baby is born. The second NIPE should happen within 6 to 8 weeks of life, and that is what is done in surgeries, and that's where you all will be involved. So there are 4 specific examinations which are mandated in NIPE, and they are eyes, heart, testis, and hips. My personal practice would be to review the red book where the first NIPE has already been done, have a discussion with parents and a history from parents, and then do a detailed head-to-toe examination, because many a times there are minor issues which are present, and some of them may have been identified during the first NIPE, but they may continue to need some form of follow-up or some management. I have intentionally left the documentation part because I think every surgery has their own systems, and they all document in slightly different way. But as long as it is systematic and as long as it is reproducible for you all to do regular audits and checks just for quality assurance, that should be fine. So from here on, we will be touching individually on these 4 specific areas that need examination, so that we do not leave any chance of missing any abnormality. So first, let us focus on the eyes. Now, the focus of examination of an eye is basically to find out if there is any opacity within the media, whether it may be cornea or lens. Congenital cataracts have an incidence of 2 to 3 per thousand live births, but the main problem is if the cataracts are left for slightly longer time, then it would cause development of amblyopia. So even if the cataract is operated and the lens is removed, the baby will still not develop good vision because of the development of amblyopia. The risk factors that predispose a baby to have eye problems would be history of congenital eye defects in a first degree relative. Second would be various forms of genetic defects. Commonly these are trisomies, and the most common trisomy being Down syndrome or trisomy 21. If a baby has local external malformation, then again there is a risk that there may be an internal problem which may cause visual defects. And if during pregnancy mother has had infections which has caused congenital infections in a fetus, for example congenital rubella. Now prematurity in itself can injure eyes, as well as management of prematurity and has a risk that they may develop retinopathy of prematurity. Now in this talk I won't be touching on retinopathy of prematurity because it's very much dealt at secondary and tertiary level. Some babies may have rare congenital neurometabolic type of problems which can also cause problems with the vision. Now the most important thing here is to take a detailed history from parents and to check if parents have any concerns about abnormal visual behaviors of a baby. May it be abnormal fixing, having seen spots in the eye, or if there have been abnormal asymmetrical movements of the eye. So for examination, all you need is an ophthalmoscope and a baby who is not crying, because mostly always it is a crying baby that gives us difficulty in examining their eyes. So the key is to be patient. Either you just wait for the baby to open their eyes. Sometimes holding the baby and rocking a little bit up and down makes them open their eye, or you could physically open their eyes as long as it is not very uncomfortable. The ophthalmoscope stays very close to the examiner's eye, but it's about half a meter away from the baby's eye. Okay, so let's do some exercise. I want you guys to pick up a pen and paper, and I would be showing you a set of images, and I'll be asking you some questions, and at the end of it we will be discussing those answers. So this is image 1. All I want you to write is which side do you think is the problem, and I'll give you about 5 to 10 seconds for this. This is image 2. Again the same question. Which side do you think is the problem? Okay, so image 3. Which side do you think is the problem? I have put these 3 images only to trigger some active thinking. So here are the answers. The image 1 shows both eyes to be normal, and you could very clearly see red eye reflex in both eyes, and that's very symmetric. The pupillary size is also very symmetric. Image 2 is slightly tricky because on the in the right eye you could see the red eye reflex and the pupil is nicely dilated, but in the left eye either the pupil is not dilated, hence you are not seeing the red eye reflex, or truly the lens is black and it is not reflecting, hence you are not seeing it. So there are 2 differentials here. Either the pupil is not dilated, which is perhaps the more common situation, then a lenticular opacity which is dark in color. And in this situation, if you feel that it is the pupillary dilatation which is a problem, sometimes it could be related to birth injury, traumatic birth injury, which can cause Horner syndrome, which is ptosis, meiosis, and anhidrosis, where you really have to dilate the pupil to be sure about the red eye reflex. But the diagnosis of Horner syndrome in itself is also an important diagnosis. And nearly always it will resolve with time. The image 3 is rather more obvious. The left eye appears to show a white reflex, and this white reflex is due to a lenticular opacity or congenital cataract. I'll show you some more images and I'll give you 10 seconds for each. All I want you to do is to write down what is the diagnosis. That's image 1. That's image 2. That's image 3. That's image 4. Image 5. And lastly, image 6. So I hope you have got some answers. Let's look at these images again and we will discuss. Okay, so the first image is a left eye cataract, and as you could see that there is white reflex from the left eye. The second image showed hemangioma of the right eyelid, and sometimes that can be associated with glaucoma if the hemangioma extends inside the eye. The third image was coloboma of iris, and this is associated with different syndromes like Charge syndrome, where there is association with the involvement of defects in heart, anorectal malformation, and genitourinary tracts. The fourth image is a bilateral corneal opacity, and that could represent various forms of neurometabolic problems as well as isolated corneal opacities of newborn. The fourth image is conjunctivitis or ophthalmia neonatorum. As you could see that the eyelid is quite swollen and there is a lot of crusty discharge. But the sixth image that you're seeing is just a blocked tear duct, because in this there is no conjunctival inflammation, the eyelid is not swollen. All that has happened is a blocked nasolacrimal duct, because of which the tears don't flow through the duct, but they get accumulated around the eye and get dried up. And for this condition, all that is required is a regular massage of the tear duct, which will eventually open it. So, if the eye reflex, the red eye reflex, is absent or abnormal, then this will be considered as a positive screening test, and these babies need to be seen by a consultant ophthalmologist within 11 weeks of age. So really you have got 3 to 4 weeks before these babies need a referral. So that will be an urgent referral to the ophthalmology service. Let's move on to the examination of hips. Hips are the next part which form a key element for our NIPE. The incidence of developmental dysplasia of hip, which we also called as DDH, previously used to be called as CDH, is about 2 to 3 per 1,000 live birth. The reason why we wish to diagnose it early and treat it is because it has long-term issues. It can cause impaired mobility at a later age. It can cause long-term hip pains as well as develop early onset osteoarthritis. Should it remain undiagnosed, or if there is a delay in diagnosis, then it may need a complex surgery, because most of the times if it is found at the correct time, then a not surgical approach with Pavlik's type of harness has got very good results. So the risk factors for a baby to have DDH, and they should have a screening hip ultrasound scan, would be a family history of first degree relative having a DDH. If they were to be born breech anytime after 36 weeks of gestation, or if they were born before 36, so if they were born more than 28 weeks of gestation, then also they would need screening hip ultrasound scan. And if one of the twins is breech, then this other twin would also need screening for the hip ultrasound scan. So again, coming to the quiz, you could pick up your pen and paper, and the question this time is you need to work out which side is the problem. So the first image that's coming your way is great. So image 1, should DDH be suspected in a baby? And this is how you find their leg length. Which side do you think is the DDH? All you need to do is to write left or right. So image 2, if there is a difference between the height of the knee, as you could see in supine position with hips and knees flexed, which side do you think is the DDH? And this is the third image. What examiner is trying to demonstrate is that there is an asymmetry in the abduction. So which side do you think is the DDH? Okay, so let's go on to the answers. Now, when the hip displaces, it displaces posteriorly and superiorly in the anatomical posture. So the leg length becomes smaller. Hence, if you look at the image 1, the leg length on the left side is lesser than the right, hence the DDH is on the left side. And similarly, because the hip dislocates posteriorly, when a baby is in supine position with hip and knee flexed, the height of the knee appears to be reduced, as well as the abduction of the knee, abduction of the hip gets restricted due to the DDH. So in all these three images, the DDH will be suspected on the left side. So these are the two maneuvers that we do to assess a baby for DDH. These tests are called Barlow's and Ortolani's test. So in Barlow's test, what you're really trying to do is to dislocate a dislocable hip. And in this test, as you could see in the leftmost image, as well as on the right side, the upper image, the examiner is bringing the hip into adduction first and then pushing it so that the hip dislocates posteriorly. So it's an active process of trying to dislocate a hip, and should that happen, then the test is positive. Now in Ortolani test, the examiner tries to relocate the dislocated hip, and the way the maneuver is done is that the hip is abducted, and then with the fingers at the greater trochanter, the examiner tries to push the hip, the femur back into the acetabulum. So try to relocate a dislocated hip, and that is what Ortolani's maneuver is. So if clinically hips appear to be abnormal, then they would need a hip ultrasound scan, and the target given to us is that should be done within 2 weeks of examination. If a baby has a risk factor identified on the history, then that scan is not urgent and can be done within first 6 weeks of life. So this part would have been dealt by the hospital where the baby is born. So when we do a 6 to 8 week check, and if the hip examination is abnormal, then the baby needs an urgent hip scan. There is growing evidence that presence of clicks or asymmetry of skin fold do not indicate DDH, so they have been taken out of the list of being abnormal findings, and they do not form a part of NIPE anymore. Coming to the third part, which is the testicular examination. So presence of cryptorchidism or undescended testis is in 2 to 6 per 100 live births, so it's much more common. Unilateral being much more commoner than bilateral. The long-term issues of leaving an undescended testis would be risk of developing testicular cancers, reduction in fertility. These undescended testes have a higher risk of going into torsion. And should a baby have bilateral undescended testes, then they need to be examined to rule out genetic defects, as well as some serious life-threatening endocrine problems like congenital adrenal hyperplasia. And early diagnosis will reduce risk of all of them. Cryptorchidism in itself is associated if there is a family history of first-degree relative having had cryptorchidism, as well as if a baby is born with low birth weight, small for gestation age, or premature. Now, these set of images show how to examine an undescended testis. So in the image A, you could clearly see that the scrotum appears to be less developed on the left side. The examiner in image B is occluding the external inguinal ring and then trying to milk the testis down. As you could see in image number C, that the testis has been pulled down up to the base of the scrotum. But should the testis be not palpable within the scrotal sac, then the examiner needs to palpate the hyposcrotum, which is the upper part of the scrotum, and try to milk the testis down from the inguinal canal into the scrotal sac. So, absence or abnormal position of testis if found at 6 to 8 weeks. If there is bilateral undescended testis, then that really is a very urgent referral to be seen by pediatrician within 2 weeks. Now, nearly always a bilateral undescended testis would have been diagnosed at birth, but should you find it between 6 to 8 weeks, then that's an urgent referral. For a unilateral undescended testis, you could wait and review the baby between 4 to 5 months. And the reason for that is if you find the testis to be still undescended at 4 to 5 months, then a referral to surgery should happen no more than 6 months later, which means by 6 months of age, a referral to surgery should happen if there is unilateral undescended testis. Now, I have already touched on retractile and undescended testis. So the difference between retractile and undescended testis is the retractile testis is a descended testis. It's just that it is a mobile testis which moves up and down. So if you could pull the testis down up to the base of the scrotum, then it's a retractile testis. But if you can't, or if you can't even palpate, then it's an undescended testis. So the next part of NIPE would be heart examination, and I have intentionally left it for now because I'll be discussing this in the second part of my talk anyways. The definition of a missed case for NIPE would be a baby who has not had NIPE within first 72 hours, and there is a national KPI on that. If a baby has not had a 6 to 8 week check because they have been admitted to hospital, or if a family moves into a new area and has not been screened because of their movement. And in all these cases, we should aim to complete the NIPE within first 3 months of age. And the whole reason for that is following that tests like ortolany and Barlow will not be very accurate. Communication part can't be emphasized more, and solely the reason being that families who have had a newborn are anyway going through an emotional time. So explanation of the abnormal findings should be very compassionate, as well as we should try to manage their expectations with time frames of referrals and answer their queries around the diagnosis. Also, there should be a steady stream of communication with the maternity, neonatal and pediatric team. And this is important to share information about babies who have had their first NIPE and abnormalities have been found, as well as chasing the results of specific scans that have happened. Keeping a track of babies who have been missed is also important, hence a two-way communication is ideal. So when it comes to quality assurance and key point indicators, it is us providers' duty to meet and maintain those standards. Individual GP surgeries would do their internal regular checks to monitor if they are meeting those standards, and the commissioners and regional QA teams could make some recommendations and offer support with management of incidents and complaints. For secondary level service, there are formal QA visits and national data returns, but that is not the case for the primary level care. The two main important KPIs are ensuring that 95% of eligible babies have had their NIPE within first 72 hours of life. So that's is with the hospitals, and should an abnormal hip ultrasound examination be found, then a scan needs to be done within 2 weeks of that examination. This is the link to the e-learning for healthcare website from NHS England, which has a link to the e-learning module for NIPE. It's a certification course, and you can get a certificate at the end for your portfolios. The handouts provided to you have got a link of this website. And this Public Health England website gives a handbook on neonatal infant physical examination program, which essentially gives us all the details and describes all the standards. So that really brings me to the end of the first part of my talk. You all deserve a 2-minute break after all the quiz that you have gone through. And thank you for listening.
Thanks very much, Dr. Singh, for a fantastic session on the 6-week check. I was taking part in the quiz as we went along. I think we've had some excellent questions coming through on the Q&A box. So what I'd now like to do is introduce Dr. Mo Ali and Dr. Chintan Singh for our panel discussion.
That's great. Thank you, Shruti. So firstly, I was going to say, Chintan, thank you so much for the presentation. Almost as Shruti said, I think with all of us, you have a Pavlovian response the minute you put a quiz up, desperate to do well, and then you get me every single time with that normal eyes. I was there turning my head thinking, is it the eyelid? Is it something else? And you got me quickly on that one. And I suppose the other thing that actually, just as a reflection, just from a primary care perspective, it is, I loved your point about crying children. So I was just laughing a little bit as you sort of described about the eyes and what's acceptable with parents as to holding an eye open, and then also the other bit about examining hips with a crying child. With that, we've had some sort of interesting, great questions, and I appreciate you sort of running through some of the answers. I'm going to sort of kick off a little bit and take the chair's prerogative a little bit, and I'm going to ask something that is something that we're facing at the moment in primary care. So often when we're doing the checks, we've had sort of NHS England guidance in primary care now that we've shifted to an 8-week check. The only thing is internally now I've got alarm bells going off as you've told me I've got 2 weeks to refer within. And I'm thinking, hold on a sec, if I saw them at 6 weeks and now I'm seeing them at 8 weeks, post-COVID, I'm expecting many of us in primary care have got used to the convenience now of having the 8-week check, having the nurse lined up, we've got the vaccinations done in one go. So I suppose I want to throw that out there because I know a few of my colleagues will probably be listening to your talk now thinking, oh, should I be separating these out? What do I do about risk exposure? So I'll start there and I'll flip over to some of the polling questions.
Thank you, Mo. Thank you. Yeah, it's a great thought process, actually. I would say there's no correct answer to this issue. The key issue here is benefits versus the convenience. And on one side, of course, a global pandemic, and you want to restrict the footfall. You want even families to be safe and not be out. So in that way, doing it at 8 weeks just about does it in a right and a safe way, and you pull it with your vaccination. So it kind of gels very well with, on that point. But the flip side of that would be if really a baby has to have a problem which has perhaps got missed at the first 72 hours NIP, then delaying it by 2 weeks, how much would that affect is the key question. And if you were to pick up a baby, maybe once in a lifetime, you might land up picking a retinoblastoma for that sake. And that's where things may be different. So I would say we could still consider having an opportunity for parents to communicate back to say, yes, we have concerns in which situation you might wish to do it a bit early. And I'm sure even if a family calls you, you might see them at 3 weeks or 4 weeks, not even wait for 6 weeks. So that risk and benefit has to be assessed, which will help us. Parallelly, I had seen Dr. Philip Bennett Richards was asking about the incidences of these rare things that I have shown. And just wanted to comment, yes, a lot of these things are quite rare, and they may really be once in a lifetime event. But the whole idea is when we do something which is very routine and we are checking the eyes again and again and we are seeing the red eye reflex, all we don't want is to miss that one baby in 5 or 6 years, which is where truly the problem lies.
That's great. Thank you. Thank you, Chintan. So I'm going to try and sort of bundle some of the questions that have come up. So if you're okay, I'm going to ask you a couple of related ones. So if I go with your talk, we've done sort of eyes, hips, and we've done testes. So let me go to a couple of things that have come up after the question around testes. I know you've answered it in the Q&A box, but just to pick up a couple of points. So we've had Larissa now just ask around, it's a theme a number of people have asked around monitoring retractile testes, because obviously in primary care, we don't see it that often, and when should we be concerned, if we should be concerned? And the second part of that, Sarah Jane's just put up a question around, we know sometimes with mobile testes, and obviously I'm thinking about adults here more than the children, we know about them being fixed in terms of, so they don't rotate and reduce their risk of torsion. When do we consider those points for children?
Absolutely. I think that is the only risk which is there, that retractile testes have a slightly higher risk of getting torsion. Barring that, I don't think they need to be regularly monitored or followed up. Now, when should we do it? I think there is no right answer to that. Perhaps much later, because you do want the testes to grow. And if at all the testes are continuing to grow, which won't grow for initial 5 to 7 years, the puberty kicks in only then, and that's when it will grow. And mostly nothing needs to be done. Nearly always it will settle down of its own. So I don't think routine follow-up is required. If at all there were ever a concern of them having a torsion, then they get fixed mostly.
Okay, that's helpful. I'll go for one more testis question and then I'll flip over to the hips. So another question's come in around how do you manage unilateral hydrocele if you pick that up on a 6 to 8 week check?
Nearly never do you need to do anything about it. Nearly always it will settle down. The hydrocele in a baby are due to patent processus vaginalis. So there is a little bit of fluid as the processus vaginalis shrinks down and closes, and this retained fluid will get absorbed over a period of time. So nearly or never would you need to do anything about it.
Thank you.
Dr. Ali, thank you both very much. I think we're going to move on to the next talk. Is made easy now, and we'll be back for some more question and answer sessions shortly.
Okay, welcome back. So this is the second part of my talk. Heart murmur in children made easy. Now, I am a pediatrician with interest in cardiology, and I do a lot of cardiac assessment, echocardiograms, and a lot of referrals come to me with heart murmurs. And a lot of my primary care colleagues, trainees in hospital, as well as exam going candidates come to me asking how can we make some sense of these heart murmurs. So clinical examination of heart is very close to my heart. So in this talk I would touch on murmurs that you may see at 6 to 8 weeks check. So that is a part of NIPE. I would also talk about the various other causes and characteristics of heart murmurs, the specific examination points that would help you in making the diagnosis. We will go through some murmurs and try to listen to murmurs, so no quiz this time, but a little bit of music. And we will talk about some red flags as to how do you identify which are the ones that really need something to be done pretty soon. So as promised, this part of the talk will complete your 6 to 8 week check component of the heart examination. So congenital heart defects happen at an incidence of about 6 to 12 per 1,000 live births, and about a quarter of them, if not more, will be deemed as critical congenital heart defects. The risk factors for a baby to have a defect within the heart includes family history, maternal infections like classically rubella, maternal medical conditions like diabetes, epilepsy, and SLE. And if mothers during pregnancy are on specific drugs like anti-epileptic and antipsychotic, then that can also increase the risk. The antenatal scans these days is very advanced, and a lot of abnormalities will be picked up, but that is again not 100%. And if there are associated abnormalities like trisomy, then the risk of such a baby having a congenital heart defect is much higher. So when you see a baby at 6 to 8 weeks check with regards to their heart examination, I think assessing their growth, plotting their weight on the centile graph is important, and to see if there has been any failure to thrive or a drop in the centile. Key indicators on history would be history of breathlessness, poor feeding, color change, which will be cyanosis, either at rest or with feeding or excessive crying, as well as if parents feel that their baby is too breathless or tired to feed, lethargic, or has got a poor muscle tone or floppy. And these last few points will be common for various other types of illness. So a generally unwell baby is what parents are trying to indicate. And always a systematic approach to examination will give you a better yield. And I would like what classical teaching has been, would recommend first going through basic vitals like heart rate, respiratory rate, assessing work of breathing in the form of whether there are any chest recessions, whether there is head bobbing movements, suprasternal, sternal retractions, shape of the chest, if there is precordial bulge, if there is Harrison's sulcus, as well as assessing the characteristic of pulses, whether they are thready, weak, whether they are bounding, as well as assessment of circulation in the form of central and peripheral capillary refill time. A simple palpation of the heart could really give you a clue if the precordium is quite hyperdynamic, and you could feel the heartbeats easily, as well as if there are any thrills. Examination of femoral pulse and palpation of femoral pulse is although slightly difficult, but can very easily aid you in a diagnosis of coarctation of aorta, as well as looking for signs of cardiac failure in the form of hepatomegaly or having crepitations within the chest. When it comes to examining and auscultating heart murmurs, the first step would be to clearly try to identify the first and second heart sound. The second step would be to find out if there is a murmur and where is it loudest, and then try to grade the murmur according to the NYHA classification. The third step would be to try to identify whether is it a systolic murmur or a diastolic murmur. Now, in pediatric age group, nearly never would a diastolic murmur be present in isolation. So it will always be associated with a systolic murmur. The fourth step will be characteristics of that murmur, whether is it a holosystolic murmur, whether it's a decrescendo or a crescendo decrescendo murmur. And the last would be to try to listen to any other sounds, and by which this I mean whether there are any S3 or S4 present, which will indicate cardiac failure. So in the left-sided picture, I'm trying to show how closely the different valves of the heart are, but the sound is preferentially directed into different areas which are depicted onto the precordium. Now, if you draw an imaginary line at the level of nipple, the right upper will be the aortic area, the left upper will be pulmonary, and lower down the right lower will be tricuspid and the left lower area will become the mitral valve area. Now, any murmur which is present above this imaginary line will be ejection systolic. So, aortic stenosis and pulmonary stenosis both will have ejection systolic murmur. And any murmur which is lower down, like a tricuspid regurgitation, ventricular septal defect, or a mitral regurgitation, will be a pansystolic murmur. Let's listen to some heart sounds. So the first heart sound that I'm going to play will be a normal heart sound, and try to focus on the first and second heart sound and try to match it to the phonogram that I have put on the right side of the slide. So here it goes. Okay, so very clear first and second heart sound. Now let's listen to a pansystolic murmur. Now what you are hearing here is the whole of the first heart sound up to the second heart sound is a harsh systolic murmur. You cannot differentiate the first and second heart sound, and this is just a holosystolic murmur which starts at the origin of first heart sound and goes up to the end of the second heart sound, and this is present with a ventricular septal defect. Now let's come to the third sound, which is a ejection systolic murmur. Now in this sound, what you hear is a crescendo decrescendo murmur. So the sound gradually increases in the intensity and then slowly fades off. But at the end of it, you could still hear the second heart sound. And if we were to hear a very typical isolated diastolic murmur, this is how it will sound. So the first heart sound is heard very clearly. The second heart sound is not heard, but all we hear is a decrescendo murmur which slowly fades up to the origin of the first heart sound. So when should you refer a murmur? Now, there are no NIPE standards as to when, but at least there is some clarity that it needs to be seen by either a pediatrician or a pediatrician with interest in cardiology. The urgency of this referral really depends on the clinical assessment and the suspicion of how serious the cardiac condition is. So if you have features of heart failure, tachypnea, recession, grunting, if the baby is cyanosed, if they are having apneas, or if there's weak femoral pulse, then this all indicates a critical congenital heart defect, and that really needs a urgent referral. And in that situation, you might actually request an ambulance to take the baby, or the family to just take the baby to accident and emergency then and there. If you look at which murmurs are pathological versus which are benign in a slightly bigger child, then the pathological murmurs are the ones which are loud, so murmurs which are grade 3 and above, murmurs which are harsh in characteristics. So it is not just the loudness, but it is the characteristic harshness of the sound, as well as if you ever find a diastolic murmur. In contrary, a benign murmur would be something which is soft, which is sometimes associated with anemia or fever. So if really you are hearing a murmur first time in an otherwise well child who has presented with a new onset fever or an intercurrent illness, then likely this is a flow murmur that needs to be reassessed when they are back to their normal health. And a lot of these benign murmurs, which previously we used to call as Still's murmur, have a slight musical intonation to it. So, and they will change their characteristic with a change in posture. So if you make them lie down and sit up, then the characteristic of that sound will change. And now the most important bit of this is an absence of a heart murmur does not rule out a significant heart defect. So if you have features of cardiac failure and features of say cyanosis, then even if you don't hear a murmur, you should still be suspecting a critical cardiac defect and trigger an urgent referral. So that really completes the 4 key elements of the NIPE examination that we all do, and which is expected of us. Thank you once again for listening, and I would like to welcome if you have any questions, and we could try to answer them. Thanks for listening.
Thank you very much once again, Dr. Singh. I'm going to hand straight back over to yourself and Dr. Ali to continue with the questions.
Thank you, Shruti. Many questions I have tried to answer as we went along. Mo, if you have spotted any specific ones?
No, I'm sure there's probably others that are just coming up at the moment. So what I'll do is I'll pull up one that Emma's just pulled up around some practical tips on palpating the femoral pulses, and whether you've got any short tricks or anything up your sleeve that helps with that.
Yeah, I would say do the femorals well before doing the hip examination. That's number one. Sometimes I would not even open the nappies, but try to kind of insert my thumb to the groin area, because once you open the nappy, the babies start to feel a little bit cold. They have a tactile stimulus and they start to cry, and then everything becomes tricky. So the least they are unhappy, the most quiet they are, the more easy it is to palpate those femorals. But I would say go by your clinical decision. So if you can't feel the femorals, never say, oh, maybe present. You should, if it is not there, just consider it not there. That needs some further assessment.
Great. What I'll do is I'll probably repeat. There's one on there which Charlotte had put in, and I know you responded. I suppose it's just I know others will have sort of similar thoughts. So I'm just going to share Charlotte's question, and she sort of asked around. So if a baby's got congenital heart defects and parents have noticed the cyanosis after feeding, it's really the frequency of feeding as to how often it happens, and if they've got no symptoms or signs on feeding, is there a differential we have around either urgency of referral or whether it's the timing of when we do that? Obviously, there can be things that get picked up pre-NIPE check.
I think cyanosis is always a medical emergency to me. If at all there is cyanosis, then yes, it is there. Different babies slightly behave differently depending on the type of physiology they are going through. So a classical dynamic type of obstruction in tetralogy of Fallows will be more apparent when babies are crying, so which makes them, whenever they're crying, they become more blue. And similarly, that happens with feeding. So when they are feeding, they are the way the vascular tone changes causes them to be more cyanos. But I would say this pattern does not always is a classical one. You can have babies who are very comfortable and have got a baseline cyanosis because they don't have rapid changes in their saturation. So they are kind of used to their saturation of 70% for that sake, and they don't really bother much about it. And the fluctuation doesn't happen, but they also warrant a very urgent assessment. So fluctuation, I would think, should not make a change in the way we do a referral of these babies.
Yeah, that's helpful. And that picks up on Laura asked a similar question around a single episode rather than frequency, but I suppose you've raised a point around urgency to that. There's another question Elaine's asked around murmurs during illnesses, and if they're things that resolve. I'm assuming that intermittent issue, how we treat those.
Wait and watch. Wait and watch is the policy. If a child is normally growing, if he has normally grown, he has been a well child, and a good history would give you clues to that. And he has come with an intercurrent illness, and that flow murmur is just related to being in a hyperdynamic state due to the infection, due to the fever. And those murmurs are flow murmurs. In fact, the innocent heart murmurs are much more louder when people are unwell. So somebody who has a very faint murmur, which we would call as a grade 1 murmur, might not be heard at my age now. But when they are febrile, it's a little bit easier to hear. So a lot of children will come with fevers when they are febrile, but these fevers will disappear when they are well. So they don't really need any monitoring, and they don't really need an echocardiogram.
There you go. See, now you're getting me worrying about my hearing now whenever I listen. So just with that, actually, there's another question around sort of timing of heart defects, and Harriet sort of raised the point of there's only so much we'll pick up on an IP. So are there any common things that we should think about sort of post IP? So not to be overly reassured by an IP around heart conditions, and is there something common we should think about later?
So physiologically, by 6 weeks of age, the pulmonary artery pressures would have dropped down. So the commonest defect, which is ventricular septal defect, which really needs something to be done, would manifest by that age. So by and large, going by this, we are more or less safe that most of the congenital defects would get picked up by about 6 weeks of age. Many of them would actually turn up much earlier than that. So the window is actually after 24 hours and before 6 weeks. Hence, when we hear a murmur before 24 hours, we keep them in hospital till 24 hours, do their saturation, check that out, and then send them home, hoping that they are very well in your safe hands till 6 weeks of age.
That's great. Thank you.
both for a fantastic couple of sessions. We're now going to be moving on to the next part of the day, which is going to be a whistle-stop tour through some common neurological presentations. So I'd like to introduce Dr. Amit Bali, who's going to be leading these talks. But to begin, we're going to start with a poll.
My name's Amit Bali, and I'm a consultant paediatrician with an interest in epilepsy and neurology. So it's brilliant to be able to speak to you today. And the first of the 3 topics I'm covering is headaches. So quick context in that, just to show that it's a really, really common issue for young people. Almost a quarter of young people say that they get a weekly headache. So it's quite a frequent impact in a lot of people. And just to show even more so the impact, there's a lot of school days that get missed because of headaches. And I find really interesting that the quality of life as self-reported in young people who have headaches and regular headaches is actually worse than that for many long-term conditions. In terms of the causes of headaches, it does interestingly depend on where they're seen. So in the emergency department versus GP, there are some interesting differences. So in ED, it's only 1% of attendances, but it tends to be secondary headaches for self-limiting causes such as viral illnesses, as opposed to in a headache clinic when young people have had the headaches for a much longer period of time. I suppose it's not surprising that the majority of those tend to be primary headaches, as opposed to 20% in those who attend ED. In ED, you obviously get acute neurological conditions such as meningitis and so on that have associated headaches. You don't get brain tumours, at least in this large study in an ED, presenting as headache. And in headache clinic, even then, you get brain tumours presenting as an incredibly small percentage of the overall number that come through the clinic. And speaking about brain tumours, that's, I think, the elephant in the room. It's what most people worry about when they're seeing a young person with a headache. So actually, is it a brain tumour is the question people are thinking. It's really rare. So 0.03% of all childhood headaches are due to brain tumours. However, of those that do have brain tumours, a third of them actually present with a headache. But hopefully this reassures you, 80% of children who have a brain tumour and present with a headache also have another symptom. So if you're really taking a focused history, and that's what we'll cover today, and doing a thorough examination, you should be able to be reassured yourself and to reassure the family. Why is that important? Obviously brain tumours are really important to pick up, and in the UK we have historically not done it very well. So we have taken twice as long, so 50% of children being diagnosed within 12 to 13 weeks as opposed to 5 to 6 weeks in comparable countries. So more on brain tumours and on worrying causes of headaches, there are some defined red flags and they're really nicely laid out in NICE guidance, which is still a really good document to be familiar with. And I'll just list them here for you on the slide and just mention a couple. So a new abnormality on neurological examination is included in there. So conversely, having a nice, normal, thorough, documented neurological examination is definitely a good thing and should be a source of reassurance to you and to the family. But it's just important to ask about these and try and elicit these in your focused history. A much more practical way for those red flags to be talked about and to almost use as a form of safety netting is via HeadSmart. So headsmart.org.uk is a fantastic resource for professionals in terms of decision making. If you go to the website, you'll be able to see that there are those options. Also just in terms of increasing awareness, and it has already had an impact. And I actually use it practically in the clinic, as I said, for safety netting purposes. So I will do an assessment on a child, know that they don't have any red flags, or if parents felt that they might do, I've made a thorough assessment and decided that they don't need any further imaging or consideration of this being a brain tumour. So I can safety net the parents to say, if the symptoms listed here for your child's age group did develop or progressed as of compared to today's examination and assessment, then actually that's a reason to go and seek medical opinion. Otherwise, if we're putting brain tumours to one side, the main question with headaches is to decide whether or not they're primary or secondary. For example, secondary causes could be self-limiting viral illnesses, as I mentioned earlier, or an ENT cause, as opposed to primary. And if it is primary, can we classify it? Well, the way to do that is to take an incredibly focused history, and that's what I'll go through now. First important question is to ask how many headache types the young person has. It's really important to tease this out because you can certainly have coexisting headache types that are different. So for example, migraine, where a young person uses simple analgesia so much that they also get medication overuse headache. So a really common scenario for me to come across, and actually it's not something that the patient themselves necessarily consider. So it's important to use a focus history to be able to establish this. The next question is around duration and timing. So why is the young person seeking advice now? When did the headache first start? How often do they happen? Is there a pattern to when they tend to occur? And when they happen, how long do they last? Next question is around character. So how bad is the headache? I don't particularly like the rating it out of 1 to 10 question, because I think people answer that quite variably depending on their pain threshold and other factors. So I instead ask them what it stops them doing, which I think is a much more objective way to try and quantify the intensity of the headache. Obviously you ask about what the headache feels like. It needs to be in the young person's own words rather than you asking them, is it sharp, dull, throbbing? Let them explain it, because they are the one experiencing it, and they will probably describe it in a very characteristic way that you can then classify into the categories that you're more familiar with. Obviously you want to know where the headache's affecting them, whether it radiates, and any other associated symptoms that they get during the attack, for example nausea and vomiting. Next you want to ask about the underlying cause, and I would tend to ask about any factors that happen before the attack, so aura, if we're thinking about migraine, might come out at this point, and any triggers, so things that the young person or the parents think are causing the headaches or contributing to them. Obviously ask about things that aggravate the headaches, and this is where you might get things such as phonophobia and photophobia coming out, which will push you more towards a migrainous cause, and obviously whether there's a family history of any similar headaches, so that's really common in migraines in particular. Next you would ask about how they respond and react to the headache. So what do they do during the headache, or as I've mentioned previously, what are they not able to do? What simple painkillers have they tried, and if they've tried them, what effect have they had? And of course, how often have they used them, thinking about things like medication overuse headache. And between the attacks, what has happened? Is it the case, as is more common, that they have their headaches and in between they get back to their baseline function, or actually do they always have some residual symptoms, or does it impact on them even when they haven't got the headache? The latter is obviously more worrying and makes you think about more worrying underlying causes again. And obviously I think you do this really well in primary care, which is asking about what their concerns and their anxieties, their expectations are. And after that point, what I find really useful, so say if I've asked all of that history in my first consultation and we want to get a bit more clarity and information on all of those questions, a headache diary is really useful. So I don't tend to just ask them to do that. I tend to give them this particular structure that I've got on the screen at the moment, because families, when they've just given a blank canvas, don't necessarily come back with anything, or if they do, they don't come back with it in a structured way. And actually doing it in the way that's there for you to see on the screen is something that I've had a lot of feedback as a useful thing for families. It enables them to be able to list every headache that the child has between assessments. It enables them to really reflect on what might be the triggers, for example, for a headache, in a way that when it's not written down in front of them, and for them to be able to review what's happened over a period of time, that they can't necessarily identify the patterns that they can when they do use this. So that's something I would certainly encourage the use of. I would also encourage the use of some sort of validated questionnaire around impact. So these are the questions that are in a scoring system called the Paediatric score. So that's a validated impact questionnaire that actually takes a not quite a small, narrow snapshot. It actually asks about the last 3 months, and it talks about things like missed days of school and functionally things that the young person wasn't able to do. And it comes up with a simple scoring system which can enable you to grade the level of impact or disability as it's listed here. It's really useful as a one-off, certainly, but it is also really useful when you've initiated some management or tried an intervention to be able to see what the trend is. Classifying the headaches is absolutely key, classifying primary headaches. So as I said, you can use the headache diaries, really useful tool. I would also encourage you to be familiar with the ICHD, so the International Classification for Headache Disorders website. So they're on version 3 at the moment, and if you put that into a search engine, it will come up with their website. And I think we all forget some of the nuances of the different classifications of types of migraine, for example. They're all listed there for you, so you can really precisely and tightly classify somebody's headache by using that as a tool. Nice criteria, nice guidance are obviously incredibly useful. As I said, that there's a really good list of red flags within the guidance. And just to emphasize the importance of classification, there was a very, very large study where they looked back through 50,000 cases, and when there was clear classification of primary headaches, there were no tumours within that data set. So getting used to this as your approach and your structure, I think, is really, really helpful and actually enables you to be reassured, I think, that you're not just doing good practice, but you're not missing things. Quick run through just to demonstrate how that is an effective thing to do. So in case number 1, you've got an 8-year-old girl with 6 months of what she describes as throbbing headaches, and they're frontal in location. She gets 1 or 2 a month and they last up to 24 hours. They make her stop normal activity, so that's a key feature in this type of headache. She also gets associated nausea, loss of appetite, and is intolerant to light and noise. The headaches are relieved by sleep and sometimes paracetamol, and so that's, you're not surprised to hear, migraine without aura. Case number 2, 15-year-old boy, similarly 6 months of headaches, also frontal. He gets 1 or 2 a week, but he is able to continue his normal activities, so that's a key difference. His are relieved by simple analgesia too, and his I've classified as a tension type headache. Case number 3, we've got a 13-year-old girl. She already has a diagnosis of migraine, which responds normally to simple analgesia. She has 6 months of headaches, but they're almost daily. She is able to continue her normal activities with this type of headache. And these headaches aren't relieved by any of the simple painkillers or even cocodamol. So that fits nicely into the classification of medication overuse headache, and I think emphasizes that being able to establish early on that there are 2 different types of headaches is really, really important. Quick word on investigations. I would use them really judiciously because they can make things worse by causing anxiety, and anxiety is really intertwined with headaches. I wouldn't just ever use them for reassurance. I would use them when they're only really when there are red flags present. And again, just to let you know and to demonstrate how useful classification is, even when there are red flags present, you don't tend to get a high percentage at all of significant abnormalities. But when they're unclassified, as opposed to classified, it's slightly higher. So classifying them really tightly, again, and precisely does help you to make, I think, judicious decisions about investigations. My method of managing headaches and migraines in particular is to draw this pyramid out actually in my clinic. Addressing triggers is the base of the pyramid because without that none of the other things work. It also is the biggest because it helps the most young people in improving their headaches. Then simple analgesia. So these 2 things together, actually most people don't go beyond needing anything more. Triptans, if they do have migraines, can help certain people. So if they still have really frequent headaches despite doing the first 2 steps, or if they have a quite significant impact, then using triptans at the time of an attack can be helpful. And prophylaxis I put always as the smallest section of the diagram and at the top, because actually most young people don't end up requiring prophylaxis if they do the other steps well. And conversely, I do have a lot of young people who come to my clinic who are already on prophylaxis, but maybe it's been jumped to a bit too soon, and I sort of try and deconstruct all of the different elements and start back from basics. Need to talk about triggers. It's really, really important, especially with migraines. Individuals will report their own particular triggers, so it's always worth asking them first without being closed in your questioning. But if we do think about known triggers from the evidence, actually dietary triggers are quite poorly described in young people. They don't tend to be an issue, apart from caffeine. And one of the big things I find in my practice is around energy drinks. So unless you specifically ask about that, it may be that the young person doesn't think they have any tea or coffee or Coke, but actually they have a lot of energy drinks. And that would definitely be contributing to their migraines. Screen time is the other big thing that I tend to see at the moment. So I would always advise not to use any screen device in the 1 or 2 hours before bedtime. Sleep is obviously really important. Screen time affects the quality of sleep, but sleep duration is also really important. Not being dehydrated and not being hungry. And also anxiety and stress, as I mentioned before, they're intertwined. Anxiety can cause the migraines, but of course migraines, I've talked about quality of life being incredibly poor with headaches, can itself trigger anxiety. And a headache diary would certainly help elicit some of these triggers that are present. And the mainstay of management is actually, as I've said in the pyramid, firstly optimizing the triggers, and you may need to do nothing else once that's been done effectively. Otherwise, if you feel a migraine or a headache, certainly a migraine coming on, then try to rest. Avoid the things that you've identified that aggravate it. Use simple painkillers, and the evidence shows that the right dose of paracetamol and ibuprofen is probably a bit higher than we normally think about. And give it by the right route, so there's no point in them having oral analgesia when actually vomiting is a big part of their migraines. And obviously, as I've mentioned before, beware medication overuse. Sometimes just 3 or 4 instances of using a medication a week can lead to medication overuse headache manifesting. And an antiemetic can be useful in some people. So in terms of prevention, I'll mention triptans quickly. NICE say yes, they can be indicated, but only in combination with simple analgesia. There is some evidence that says nasal is better tolerated, and certainly in those who would have nausea and vomiting, I often would go down the sumatriptan route. Prophylaxis, as I say, it's got limited role. Propranolol has evidence in migraine with aura, as does topiramate, although not quite as good as it was previously felt to be. Placebo has a really good effect in some of the trials, especially with pazotafen, which I've seen used really commonly over the years, and anecdotally I would certainly say I've had a few that seem to have responded to it, but actually the trials don't really bear that out. And in terms of non-drug therapies, acupuncture is there in the NICE guidance. I've never used it or advocated it for it myself, but you may get the family asking for it. And psychologically, I think it is really important to get support, especially if you've identified stress and anxiety as a trigger, or if the headaches themselves are causing significant stress or anxiety. And remember, your goal at the end of this, the end outcome is to improve function. So try and use that sort of PEDS-MIDAS or another impact questionnaire to assess how you're doing and how things are hopefully improving, and also encourage parents and young people to share their diagnosis with their school so that any appropriate adjustments can be made. There's a really good RCGP school policy that you can signpost them to. So in summary, headaches in young people are rarely brain tumours, but you do need to look for and rule out red flags. And people who've got brain tumours as the underlying cause nearly always do have a red flag or abnormal neurological signs. Taking a really good, clear focus history will help you to classify. There are lots of good available tools and resources out there, and you rarely do need to go beyond simple analgesia in primary headaches.
Thank you very much, Dr. Barley. That was a fantastic session on headaches. I'm now going to hand over to Dr. Mize and Dr. Barley for our next Q&A panel session. We've got a few minutes, so probably time for 1 or 2 questions.
So first of all, thanks, Amit, for specifically answering the question, which was the polling question. So I think pazotafen came out number 1, and you've ruled that out as placebo, if I'm correct. There's been quite a lot of questions that you have answered in the chat, and so I'm not going to go through them all. I'm going to start off with my own question about examination of children in primary care with headaches. So my sort of safety quick neuro exam is just with a headache would be a blood pressure and have an attempt to look in their eyes. What do you recommend for assessing face-to-face examination?
Yeah, so I think whatever you can fit in, but I'm acknowledge that you're a lot more time constrained than we usually are. So gait, you can obviously see as they're coming in through the door. Their tone, so peripheral nervous system, their tone, power, and reflexes are all pretty sensitive, especially their reflexes, and seeing if there's any asymmetry, you will pick up abnormal neurology, I think, if you're just doing that. And then on the cranial nerves, I think fundoscopy is the big thing that people struggle with. We all struggle with, let's be honest. And I think if you've done everything else and it's normal in a child with headaches, they need to have it done. But I think sort of referring them or signposting them to their optometrist and saying, actually go to a high street optician, whatever, and get it done there is fair enough. If you've got abnormal neurology, then you probably do need to look yourself. But I think that's the one that's the big time saver. Blood pressure, I think, absolutely should be done. You're talking about a correctable cause and a cause you don't want to miss. So it does need to be done.
Thanks a lot. So, just to clarify about prophylaxis, been asked which one would you suggest first line. Do you think it's reasonable for GPs to be prescribing migraine prophylaxis? And if so, what's your first line?
Yeah. So potentially, but I do think the pyramid I've gone through for a reason, because I think you kind of get a skewed view, don't you, in what comes into your clinic. But I do get a good proportion of people who come in already on prophylaxis, usually propranolol, but the simple stuff hasn't been done. So I have to sort of undo that, which is always a challenging conversation with the family. But usually when we've done that and then walked our way back through the pyramid, the family find that they don't need to escalate quite as much. If somebody has gone through all of that and has followed the steps and the approach that I've outlined, I think it could be fair enough in a kind of older young person. But be aware that propranolol's got that evidence in migraine with aura specifically. Topiramate evidence is not as good as we thought it was. And although I know I said pizotifen has no effects over placebo, actually anecdotally some people find that it does work. So I'm not saying don't go for it. I'm just saying be aware that it's not, it might be kind of seen as a clean drug, but it might not be that effective. So actually just try and take all of the other steps and hopefully you won't need to get to that stage.
And just one, very couple of quick ones. Firstly, have you a suggested headache diary we can use in primary care that's primary care centric that you can link us to? And a really important one about stopping analgesics and whether they should go cold turkey, as our questioner said, or how long do they need to be off medication for them to see improvement?
Yeah. So in terms of a headache diary, somebody had asked on the Q&A if we can share this one. I'm happy to do that. So if the formatting of the PDF from these slides isn't usable, then do let us know and I can always share that. It is on our sort of local guideline, which we did a few years ago, and was supposed to be an integrated one. So I would hope that means it is available to the GPs in Tower Hamlets at least, but I'm happy to share it more widely. In terms of, the specific question in the Q&A about weaning off was about medication overuse headache. There used to be a school of thought of using naproxen, for example. That was in vogue a few years ago as a way of weaning off, using that for a couple of weeks whilst you stopped everything else. It actually just led to people needing naproxen and needing to continue that. So cold turkey is the only way. So if you are if you've got a really good history, you are highly suspicious, and in fact you've confirmed that this is medication overuse headache, you just need to wait for the school holidays and say this is a really good time to do it. Warn the family they'll have a difficult few days, but after that, usually people respond much, much better than trying something as a bridge.
Fantastic. Thank you both very much. We're going to move on now to Dr. Barley's next talk, which is on fits and funny turns. And once again, we're going to start off with a poll.
So my next topic is around fits and faints. So this is mainly going to be about epilepsy, which is an incredibly common long-term condition in children and young people. It's estimated to affect over 60,000 people under the age of 18 in the UK, but I think most people in the epilepsy community would say that is a gross understatement and an underestimation. But if we take that figure, that equates to 2,000 young people in London, and that's at least 1 or 2 in every mainstream primary school, and it's around 4 or 5 in every mainstream secondary school. It's obviously more common in the special school population. And there is Healthy London Partnership guidance, which I would urge you all to have a look at, and that has a specific section for primary care outlining what the roles and responsibilities are in paediatric epilepsy care. And mainly it's around keeping up to date with latest guidance, which is nice guidance, and specifically knowing when to refer. And you would refer into a first fit clinic. So why do we have them? Firstly, because they're outlined in NICE as a good thing to do. because there are many, many types of epilepsy, and so more accurately you might call epilepsy the epilepsies that are all very different in their natural history and how the child will do. And it's fairly specialist, so there are high rates of misdiagnosis, and that's been borne out by different inquiries in areas of the UK. So in Leicester many years ago there was an inquiry that found really high rates of misdiagnosis, where all cases needed to be re-examined, and there was something similar in Northern Ireland only a few years ago. And there's a really good study from the mid-2000s that showed in the tertiary epilepsy clinic, actually 40% of those children who had really difficult drug-resistant epilepsy didn't have epilepsy at all, and they'd just been misdiagnosed. So from a primary care point of view, should you refer? Well, if you get a clinical description of a paroxysmal event, and that is what we call the semiology, and a pattern of events that you feel resembles a seizure, then yes. Video these days is increasingly of use, and increasingly parents will come to me in the first instance with a video of a paroxysmal event where there's almost no substitute for seeing it, so I can maybe address whether or not it's a seizure at that point, but I would imagine that could be the case for you in primary care too. And obviously be aware that there are seizures, but there are also many things that can resemble seizures, so what we call epilepsy imitators. So you can categorize these in various ways, and I would signpost you to a really good website called epilepsydiagnosis.org, which is the International League Against Epilepsy's website. And it's really good for epilepsy, but it has an incredible section on epilepsy imitators. So if you see something in a child, and a lot of these are in infants or preschool children, and you feel, look, I don't think this is epilepsy, I don't think these are seizures, I can't really give it a name, well actually this is a really, really good website to look at, because you can obviously reassure a lot more convincingly to a parent to say it's not something if you can say, I also think this is what it actually is. So the history is absolutely key, as with most things. So what happened prior to the event? Do the family feel that anything triggered it? What then proceeded to happen? So in the event itself, what were the facial features? Were the limbs involved? Was there a colour change? Obviously people ask about tongue biting and urinary incontinence, but you may get the same thing described differently. So they may say that they clenched their jaw rather than talk about tongue biting. And were there any lateralizing signs? So things that indicate focal epilepsy or focal seizures. So for example, fixed eye deviation or turning of the head. Did they maintain their awareness, or was it impaired in any way? How long was it? Which is obviously a difficult question for parents to answer, especially if their child's only had one or two of these. It's not the first thing that springs to mind, is timing it. And then what happened after the event? So were they immediately back to their normal self, which would tend to go away against most seizures, or were they sleepy, confused, and does this sound like a post-ictal period, which supports the actual event being ictal? So we call all of that the semiology. Do they have a video? Always worth explicitly asking. Parents won't always offer it. I saw somebody in clinic last week where they gave a very good description, and then when I asked if they could take a video next time, they showed me 2 videos that they already had of the event in question. And clearly, is there anything in terms of risk factors in the background? So I'm specifically talking about birth history, so that they may have been a hypoxic event or prematurity. Anything in past medical history, so they may have had meningitis or another brain injury, or they may have diagnoses that are common comorbidities for epilepsy, such as ADHD or autism. Are there any developmental issues which increase the likelihood of this being epilepsy as part of a wider diagnosis? And clearly, if there's a family history of seizures or epilepsy, especially childhood epilepsy, then that's incredibly relevant too. So the second question I think about in a first fit clinic is, if this was a seizure, is this a diagnosis of epilepsy? And that's really what families want to know. And gone are the days when we should be saying everyone's allowed one fit, because yes, the diagnosis of epilepsy, as we probably all know, is 2 unprovoked seizures more than 24 hours apart. That gives you a greater than baseline risk of having further seizures. But actually you can make a diagnosis of epilepsy after just 1 event. So that's now in the definition from the ILAE. So if you estimate, and it is an estimation, that they have an above 60% risk, so what we say in part 1 there, after one seizure because they have issues in perhaps they have a structural brain lesion, for example. So something that increases their baseline risk as if they'd had two, but they've only actually had one, you can make the diagnosis of epilepsy. Or they could have an epilepsy syndrome that's been identified even after one, and that clearly means that they have that diagnosis. But actually, that's not necessarily something you need to worry about in primary care. If you've had somebody who's had a paroxysmal event and you think that that was a suspected seizure, you need to refer to First Seizure Clinic, and this is a question that we will go on to answer and assess when we see them. What we do after that time, well, we investigate. We look for causes of provoked seizures, so we do blood tests for things like a bone profile, to look at the calcium, magnesium. We do a blood glucose if that's not been done before. And we're just wanting to make sure that there's no electrolyte imbalance that might have provoked the seizure. We do an ECG if they've had a convulsive seizure. That's a nice guidance too, even though if they have no features that suggest a cardiac cause, you don't need to do anything beyond that as long as they have a normal ECG. And then of course we go on to do more specific investigations for epilepsy, so EEGs and in many cases neuroimaging. So in terms of the investigations that we do, it's worth me talking about, I think, in this forum. So with an EEG, and I say I'll talk about them in this forum because parents will often ask what happens next. An EEG may or may not show an abnormality. So the chance of having an abnormality if you have actually had a clinical seizure is quite variable. If you've got absences, an absence epilepsy, that's quite a classical pattern that you can provoke in an EEG and prove, as opposed to a bilateral tonic-clonic seizure, as we call them these days, which tends not to necessarily have an abnormality between seizures. Having said that, if they have epileptiform discharges present on an EEG, that doesn't mean they have epilepsy, so you need to take it in context of the event and your index of suspicion beforehand. If you've got a normal EEG, that doesn't mean that you don't have epilepsy. I think everybody knows that one, but that's an important thing to convey to parents. And so it really does depend on your index of suspicion. So I think even when I order them in First Seizure Clinic, I give the parents an idea of what I expect it to show and what I think is happening at that point and how the EEG will actually aid me. I don't want parents to think that I'm completely relying on an EEG for the reasons that I've shown on this slide. And a sleep EEG comes in because, again, some parents will have done their reading and know that this exists. It's something that we tend to use after doing a standard awake EEG, and there's really good evidence that if you have a normal EEG but you're clinically highly suspicious of this being epilepsy and that these are seizures, then it will increase your yield of finding abnormal findings. And it's really important to be as precise as possible by using these investigations, because it influences perhaps what management you do later, what anti-epileptic medication you might start. And an MRI tends to be what we do unless somebody has a very specific pattern on their EEG. So for example, absent seizures with the proven classical childhood absence epilepsy change on EEG does not require neuroimaging. So what advice would you give? Well, I always talk about seizure first aid. So sometimes you can signpost to a video on one of the charity websites, and they also have infographics as well. It talks about keeping the child physically safe, timing ideally, taking a video if they have the presence of mind to do so, and when of course to call an ambulance, which is in the case of most convulsive seizures after 5 minutes, because there is less inhibition to stop the seizure after that time, so it's more likely to continue to be a prolonged seizure and require medication to terminate it. And then post-ictally we talk about the recovery position. In terms of seizure safety advice, so this is the kind of day-to-day advice, we talk about showers being safer than baths, but actually I would avoid the temptation to ban them from doing things that they enjoy, because as long as they have the appropriate supervision, there's no reason why they still can't do swimming. There's no reason why they can't do cycling if they wear a helmet and avoid high-speed traffic and are with someone. So I think it's always important to put that into context too. And there's a really good leaflet at the moment from the Royal College, from our Royal College, about first seizures that you can find online that I think is a useful thing to print out or at least signpost families to. After an epilepsy diagnosis is the other area where the Healthy London Partnership talk about primary care having a really important role, and that's specifically in ensuring the ongoing supply of anti-epileptic medication, for monitoring for any complications from epilepsy, or from the medication. So that doesn't mean necessarily actively having regular appointments, but ad hoc, as and when you see a child, to be aware that they can develop these issues. Managing any pre-existing or the development of any new comorbidities, so again being aware that they can develop, so children with epilepsy are more likely to have autism and ADHD and vice versa. And just in general providing support for children and young people and their family. Clearly in secondary care we have systems for doing this too. There's also a mention of helping to facilitate transition to adult services. So in summary, with seizures, history is absolutely key, and you can identify suspected seizures or identify other paroxysmal events which you can classify and give a name to with a really good history. If you do think it is a suspected seizure, then it does warrant urgent referral to a first seizure clinic, and NICE would say that we should see them within 2 weeks. The diagnosis of epilepsy is about putting together pieces of the jigsaw. It's not just about one investigation proving it or disproving it. And the care of epilepsy for children and young people is led by secondary care, but there are important roles for primary care too.
Thanks very much, Amit. Really, really thorough. You mentioned in the talk about an increased risk of seizures after 2 fits, but you didn't quantify that as per the poll, I don't think. Could you answer the poll question for me?
Oh, sorry, it might have got covered up by the big red cross I put in it. So it then gives you a 60% risk. So it gives you more risk than not of having a further seizure, at least in the next couple of years after that. And that's why they now have that criteria where you could say that after 1 fit, if you make a judgment that you're more likely than not to have another seizure over the next few years.
Thank you. And Alice has asked the question that was burning for me about febrile convulsions, about referral, particularly if they've resolved. So you get a history of somebody's phones in, my child had a fit, or they even might have a fit in your surgery due to an intercurrent illness. What's the NICE guidance or best practice for that?
Yeah. So I think if it's a febrile seizure, you don't need to refer them in. If it's a self-limiting, self-terminating one, the only issue is if it happens when they're very young, because you can get it in certain types of epilepsy. So I would probably say under 6 months is a good cutoff. You should refer those ones in. And I think most people wouldn't be comfortable necessarily with not doing that. And if they're over 5 years, it's probably the other side of the age spectrum. We don't expect febrile seizures they may persist if they've started at the more typical age, but you don't expect a new febrile seizure necessarily at that point. So it is probably worth an assessment of that child.
And Nicola's asked something that's also on my mind about diagnosing absent seizures, which is tricky to pick up in very young children. Now, I always get parents to provide a video these days. So part of it about diagnosis, and that leads me on to a sort of follow-up question about advice and guidance, or how we get advice from you guys without actually doing a formal referral.
So I think if you get a good history and or a video that these are blank spells and you're suspecting absent seizures, I think that should be a referral anyway. You can have a discussion. I think that's probably warranted, but expect to refer that because it is a seizure type. It does need proper assessment and then probably treatment. What we get a lot are blank spells. You know, a lot of people come saying that they've got absent seizures. They've made that decision.
Absolutely.
But it's often a blank spells. You can get non-epileptic staring spells. You could have focal seizures, so you could have longer blank spells, and they're not absences. They're focal seizures. So they all need assessing. I think that's probably better done in a first fit clinic. As a kind of rule I've just made up, but I think it's probably true. If you're asking a parent to get a video of an absent seizure, they probably can't. If they get a video of it, it's probably something else, but it still could be a seizure. It could be a focal seizure because the absent seizures are just so brief that they don't usually capture them.
Thanks so much once again. I'm going to move things along for our very final talk by Dr. Bally, super snappy one on abnormalities in the head shape.
So my last topic is about abnormalities in head shape, which might be something that parents come to you with, especially for infants. And the normal development of the infant head is worth thinking about. So I think we all know it's made up of different bones, and the reason for that is it allows the brain to grow. Therefore, the size of the head is a real marker of brain growth. That's why we measure head circumference. The fontanelle, so you've got your anterior and posterior. So the posterior at the bottom of that picture there closes at around 8 to 12 weeks. The anterior fontanelle closes at around a year, but even up to 24 months. And in terms of suture fusion, the metopic suture there at the front closes in, or fuses rather, in infancy, and the others go on to fuse as the young person gets older. The key history, if somebody comes with an abnormality in head shape or they're querying that, are what do they think the issue is, when do they notice it, how has it changed over time, is there anything in the wider history that suggests that this is a true problem. So was there, for example, an issue in pregnancy such as a congenital infection or maternal substance misuse? Were there any issues at birth, so prematurity? Or was there an instrumental delivery, which would obviously have the potential to cause a traumatic reason for a change in head shape? Are there any issues with development? And this could be this abnormal head shape that the family are reporting be part of a wider congenital disorder or a genetic disorder. And is there any relevant family history, including consanguinity? So your assessment should include a general examination, as usual, but specifically are there signs of a genetic disorder, and are there any abnormal neurological signs? Looking at the head itself, the 4 S's are really important. So what's the shape of the head? What are the sutures like? What are the spaces like? By which I mean the fontanelle. And what's the size of the head? So the head circumference, which you can plot on a growth chart. There's a really good growth chart app that our Royal College have endorsed, which enables you just to enter the values in and to get them plotted and obtain the centiles. Of course, with head circumference, we always say measure it 3 times and take the largest of the 3. And it's always good to look at the parent's head size and the head shape, because it may be something that, although you've asked about family history, they don't realise that they have something extremely similar. So thinking about causes of abnormal head shapes and sizes, craniosynostosis is one of them, and that is defined as the premature fusion of 1 or more sutures. That can be isolated or it can be as part of a syndrome. The shape of the head is then subsequently affected if one of the sutures or more are fused, and that does require referral onto neurosurgery. Microcephaly is another reason for referral, and that's defined as a head circumference less than the 2nd centile. And macrocephaly, bigger than the 98th centile, also requires referral. It's worth talking about the most common reason why parents report an abnormal head shape, which is positional plagiocephaly. So this is something that now affects up to 20% of babies, even though we may not see them all presenting for a medical opinion. And the features are you get a flattened occiput on one side, and the ear and the forehead on the same side as that tend to displace anteriorly. So looking from the top, which is what the diagram shows here, I think really illustrates it well, especially the sort of schematic rather than the actual photograph. So you get a real flattened occiput, and on that side that tends to push forward the ear and that forehead. And the key thing is it's quite self-fulfilling, which means the flatter that gets, the more that child will favour lying on that side, make it more flat, and hence the asymmetry will become more and more pronounced. It's something that, as I say, is incredibly common. It's become more common since the Back to Sleep campaign. So as successful as it's been in terms of reducing sudden infant death, this is one of the sort of unintended consequences of it. But you can reassure parents that yes, whilst they're supine and tend to developmentally spend most of the time lying on their back, it is something that will improve by itself, and it will self-resolve as the child grows and as their developmental age increases. If it's severe, we can give specific advice around corrective positioning. However, sometimes that means having things in the cot, so this should never be advised and never be done whilst the child is asleep or unsupervised. Helmet use is something we get asked about a lot, and parents will ask about because they may come across it when they do their own reading. It's not been shown to be of any practical use. So in summary, for abnormal head shapes, be aware of the normal features of the infant head and how it develops. Be aware of positional plagiocephaly as the most common abnormal head shape that you'll come across, and that appropriate advice is usually all that is needed. And be aware of when to refer, so if there's microcephaly, macrocephaly, or you're suspecting craniosynostosis.
Thank you very much, Amit. Very helpful. I think I should say we should never underestimate how distressing this can be for For parents, I have had a mum with severe postnatal depression, which was massively exacerbated by her constant obsession about correcting this baby's position. A specific question, I think you answered it, but about things in the cot. So Paediatric pillows are widely advertised. And also I just would like to recommend to everybody the Great Ormond Street Hospital leaflet on Paediatric, which is really great and easily to define. But so I know we haven't got a lot of time, so if you could answer about the pillows, be great.
Yeah, I think you've kind of indicated with your question what you think. So yeah, nothing in the cot. Don't undo all the back to sleep successes that we've had. The whole point of not doing these things when they're asleep compared to when they're awake is around the incidence of sudden infant death. So by all means, things like corrective positioning, some passive positioning, that sort of thing, but that's not going to work when they're asleep. Stuff next to them to try and help correct it that might support, you just can't use if you're not there and if they're asleep. It's just not safe. I think the Great Ormond Street leaflet would make that clear as well. So it sounds like a resource to use.
Thank you, Dr. Ali. Thank you, Dr. Myers. That was a fantastic session on neurology. We've now got a few minutes for our wellness break, so I'm going to hand over to Ritesh Pai once again, who's going to do some exercises for the neck and hands. And we will then be joined again at 3:30, hosted by Dr. Dan Gibney, and our next speaker will be Dr. Jane. Thank you very much.
Okay, thank you. Welcome back. So we're going to do some exercises for our hands and head. Some things that you can do when you're sitting down all day and you kind of kneeling down, looking down at this kind of screen or on the hands. So start with just sitting back straight. And we're going to start with the head exercises. So just lifting up the head, look up towards the ceiling. Okay, and then breathing out, look down, bring the chin to your chest and down to the floor. And up again as you breathe in, look up, head back as far as you can go, and then breathe out, bring the chin to your chest and down. And back to the center, look over your right shoulder. Okay, and then to the other side, left shoulder, and back to the right shoulder, and to the left shoulder. Obviously, you can do these as many times as you want, to the right and left. Just keeping the neck mobile, getting those head. Okay, now drop the right ear to the right shoulder. Just keep the body still, just drop the right ear to the right shoulder. Feel that. And take the right hand, place it on top of the head and let the weight of the hand just pull the neck downwards slightly. And you can feel that stretch around the left side of the neck. Okay, just gently let the weight by itself exercise the neck and release and back to the center. Now to the left ear, drop the left ear to the left shoulder and take the left hand and place that again just on the head. Let the weight of the elbows just bring the head down a little bit. Feel that stretch on the neck and release. Okay, back to the center. Look at the 12 o'clock position on the clock and just rotate gently round. You're going to do a couple of rounds. Feel the neck muscles working as you go around a clockwise direction. And then come back to the 12 o'clock and go in the opposite direction now. Okay, and back to the center. Good. Okay, great. Now we go to the hand exercises. Just stretch the hands out in front of you and just squeeze the fingers tight. Really nice tight fist and relax. And squeeze and relax. Squeeze, relax, squeeze, relax, squeeze, relax, squeeze, relax. Wrap the thumb with your fingers. Bring the fist together. Keep the elbows straight and just rotate the hand, wrist round. Knuckles touching. As you go round and round, you can keep them separate if you don't feel you can touch like that. And then go in the opposite direction. It's good for your wrists. You're going to writing all day, typing all day. This is excellent exercise. You know, it'll relieve that stress and get the blood flowing properly and you feel tight. Okay, hands up, palms facing up, and flick the wrist down and up, down, up, down. Simple exercises, down, up, down, up. Okay, bring the fingers in and out, in, out, in, out, in, out, in, out. Okay, now read the palms up and touch the back of the shoulders and out. Touch the back and out. Touch the back, out. Touch the back, out. Touch the back, and now out to your side. Now hold the hands out to your side, touch the shoulders, keep the elbows straight, just bending from the elbows. Reach back to the shoulders and out and back and out and back. And hold the hands out now, keep them up, and just rotate them around 360 degrees all the way around and back up. And again, round and up and round and up. Okay, bring the elbows in, back touch your shoulders, and then bring the elbows into the center, and we're going to rotate round. Nice big rotation. Feel those neck and shoulder muscles working as you go around. Nice and slowly, really open those shoulders out. Okay, and then go in the opposite direction now. Reverse. So people who may suffer from neck frozen shoulders and things like that, these are great exercises to do, to keep them mobile and get those muscles undone. Okay, and relax. Okay, good. So now one final piece. So interlock the fingers. Okay, we're going to raise the hands up over your head. Okay, get to the back of the head, raise it up, and we're going to take a breath in. We're going to hold that breath in. So breathe in, hold that breath, and then pull to one side and look straight ahead. Look straight ahead, really kind of straightening the spine out. Feel that stretch. Hold that breath and relax and release. Now the other side. So take a breath in again and pull to the other side. And relax and down. Okay, and then one last one, which is kind of called counter pressure, and it's kind of to help the blood circulating in the neck. So we're going to interlock the fingers, and we're going to place them in the back of the head. We're going to press hands pushing forward, head pushing back. Okay, so take a breath in and hold that breath in, and press. And as you do that, you'll feel the vibrations in your neck and shoulders. And relax. And take the right hand. We're going to press against the right temple. So again, breathe in and hold that breath. And press. And relax. And the other side. And relax. And the final one is interlock the fingers again. We're going to press against the forehead. So breathe in and press. And relax. Good. Okay, so they're simple, basic exercises. We've only done a few minutes of that. But this is the upper part of the body. You can do the same things for your legs, feet, arms. Okay, so thank you. Okay, Akshay, hope you enjoyed that. And it's enough time for you now.
No, Ritesh bhai, please thank you. Coming out of your busy schedule, really thank you. And I'm pretty sure everyone's enjoyed it. I've enjoyed it. This will be recorded, so people can look at it later on also.
Sure. Come back to me if you need anything more. Thank you.
Absolutely. I'll touch base with you soon.
Great. Take care.
Lovely. So I think it's Dan who's going to be hosting. Over to you, Dan.
Thanks, Akshay. So hope you've all had a nice break. We're nearly there. Not got that long left of the afternoon. So Dr. Jane is going to present the next session, which is on common presentations. There's a series of talks in the same format, and he'll be joined by Dr. Davidson, who's going to moderate. This first talk is on growth failure and short stature and when to investigate. And we're just going to start with a poll.
Good afternoon, everyone. My name is Dr. Akshay Jain. I'm a consultant pediatrician at the Royal London Hospital, the college tutor, and also the course director for the GB Update course and the MRC-PCH course. I'll be delivering 3 talks today afternoon. The first talk is on failure to thrive and short stature. I would actually like to start with a lovely quote by Dr. Bernard Law. He In fact, he's 99 years and still with us. He's a chap who discovered the defibrillators and quite a lot of syndromes, a Nobel Prize winner. And what he says is, do as much as possible for the patients and as little possible to the patients. And really interesting fact and very pertinent to this talk. So what is failure to thrive? The technical definition is a drop by 2 centiles on the growth chart or weight for age, which is persistently below the 3rd to the 5th centile. It could also in simple terms be mentioned as a suboptimal growth, or somewhere the family are not happy with the child's growth and they get the child to the physician, or the physicians pick the problem with growth, be it weight, height, or head circumference, when the kid is examined in their clinic. So what are our key tools? Is it investigations for failure to thrive? Lots of blood tests? I don't think so. The key tools are the red book, the growth chart, plotting the height and weight multiple times, and then gauging the growth trajectory. So how do kids present with failure to thrive? They could present with concerned parents booking an appointment with the family GP. The issues could be picked up by the family GP when the family present for a totally different reason, or the issues with weight or height could be picked up by the health visitor team. So let's try and understand what normal growth is before we go into what is failure to thrive. The first year of life is really important for every child. The gain in the first 3 months, the weight gain, is about 25 to 30 grams per day. Kids are supposed to double their birth weight by 5 to 6 months of age and triple the birth weight by 1 year. The height at birth is about 50 centimeters. At 1 year should go up to 75 centimeters, and by the second year they should be 90 centimeters. After that, the growth, that's the weight and height gain, is quite steady till they hit puberty. I've put in some formulas for you which would help with gauging what the ideal weight is for the age as well as the height. These are the growth charts which we would use for plotting weight, height, and head circumference. So the concept of growth trajectory, really important. Why is it? Because weight only is affected in your classic failure to thrive. Height only is affected in short stature. Head circumference only is affected in neurological conditions. But if the weight, height, and head circumference, all of them are affected, then this could well be a congenital infection that little baby is suffering from, syndromes, genetic problems, or teratogenic problems. In the classical failure to thrive, weight only is affected, and it is way badly affected than the height. If this continues, then yes, definitely the height and head circumference would start getting affected. Most of these kids are going to be born with normal parameters at birth. So what are the causes of classical failure to thrive? Well, it could be inadequate intake of food. The food intake could be normal, but the demand is more, or the adequate intake is not good enough because there is significant losses. So the causes, inadequate intake could be because of a mechanical problem. So really important that we do a proper 6-week check to rule out cleft palate. Also, feeding difficulties, unsafe swallow can happen. It could be a safeguarding issue. Could it be a mother who's got problems with postnatal depression? If the intake is adequate but the demand is too much, this could be because of conditions like CF, congenital heart disease, chronic or recurrent infections, syndromes, or metabolic causes. And if your adequate intake is there, but there are significant losses, this could be because of, again, conditions like CF, celiac disease, inflammatory bowel disease, where you have a lot of losses. Well, tools to manage failure to thrive. Nothing replaces good history and examination. As we said again and again, the growth chart on the red book is the key. Is there a trigger that you can identify? When did this happen? Are they following the centiles? We need to have at least 2 to 3 good readings on the growth chart to make a diagnosis. These are the questions that we would expect that we should be asking the family with regards to failure to thrive. And the important thing again is understanding what is normal feeding. In the first 3 months of life, the baby needs at least 5 ounces, that's 150 ml of milk per kg to get optimal growth. Also check the development and family history. Are the parents short in height? Again, I mean, examination, the slide reads for itself, but again, please plot the weight and height on the growth chart. Look for any evidence of a heart murmur, organomegaly, pallor clubbing cyanosis. Also check for development. Is the development age appropriate? I personally think without a thorough history and examination, including accurate recording on the Red Book, investigations is like a fishing expedition. Now you would throw the net and you would get a lot, and you would not know which one is the investigation you wanted and what do you do with the abnormal result. So really important to have the detailed history, and then according to the cause you found out, investigate. I've put in a list of investigations in the order that we should go, and important points are something like a celiac investigation, really important if there is history of diarrhea in a little kid. ES are important to rule out any inflammatory causes. IGF-1 and wrist X-ray could be used for your short stature, so that's for the talk after this one. And then depending upon the signs and symptoms, you could do fecal calprotectin, check the urine. But please, we do not in pediatrics do vitamin B12 and folic acid. And we do find a lot of children who are having those investigations done in primary care. And unless there is a specific reason, we should not do those normally. So the question of when do you refer? There are 2 ways you refer. Acutely, if you're really worried about a little baby who's fallen off centiles, any child who's really unwell with failure to thrive, or if there are very severe, significant safeguarding concerns. Pick up the phone, speak with the pediatrician on the hotline, and refer to the rapid access. Otherwise, if this is something which has been happening over a course of few months, get a dietitian involved and make an appointment in the outpatient setting. Couple of slides on short stature. The most common causes of short stature are going to be familial and constitutional. Majority of the children will have that. You also can then have genetic causes, endocrine causes, and skeletal dysplasias. Here's a slide on differentiating between constitutional and familial short stature. And I think about 85 to 90% of your children will have this. And the most important point to differentiate between constitutional and familial is the mid-parental height in familial would show that the parents are short and the child will fall along those lines. Bone age is actually delayed in constitutional short stature. The final height in a child with constitutional short stature is going to be almost normal. Puberty also is delayed in constitutional short stature. Again, investigations and examinations, really important that we plot the weight and height. We need to get the mid-parental height by taking the parent's height. There are lots of formulas you can use which are available online. Look for any signs of dysmorphism, any signs of disproportionately large head with short upper arms and thighs goes with skeletal dysplasia. And the investigations would be mostly the same or similar to what we've discussed previously. Just for completion, head circumference, if it's only the head circumference which is affected, has to be a neurological cause. Speak with your neurologist. If the head circumference is equally affected as the weight and height, it could be the talc infections, teratogenic exposures, congenital syndromes. So in summary, your Red Book and growth chart are the most important tools. Identify what aspect of growth has been affected. First year of life is really important for the purposes of growth. Look at the parents and the mid-parental height, and as Bernard Law says, do as much as possible for the patient, but as little as possible to the patient. Thank you.
Thanks, Dr. Jain. That was a really useful talk. We do see this from time to time in primary care. I think health visitors do quite a lot of the work, but these parents can be quite anxious, can't they?
Thanks, Dan. Thanks for introducing us. So I think in case people missed it, the answer actually was 150 mils per
Absolutely,
kilo.
yeah.
Right.
So for the first 3 months, it's 5 ounces or 150 ml per kg. You go to the 100 ml per kg as a standard calculation once the kids are, say, 3-4 months, that sort of age. Because if you're targeting a weight, doubling the weight in 5 months, 6 months, you need that much of fluid. So the answer for the first 3 months, really important. It's 5 ounces or 150 per kg.
Excellent, good. So there were lots of points in the chat and a few in the Q&A about growth charts. So in primary care, we're doing lots more consulting, I guess, from a distance. We're not bringing children in as much as we used to do. And as a result, we're relying on parents providing us with data. So there were a few things that came in about the e-Red book, which is being rolled out across London for parents contributing weighing. And also there are apps. And somebody made a suggestion. I'm going to try. I don't know if you know this one. I'm going to try and hold it up to my screen. Someone was suggesting this app.
And that's a brilliant one. Yeah, I mean, I forgot it on the talk, but this is a app which is there, easy to download, something which we can give to the parents also. Weighing wise, I don't know, Rob, with little babies, trying to weigh them at home with social distancing and all that, it is going to, it is dangerous, trying to sort of say, okay, you stand on the weighing scale and hold a baby. I think so. We should not do those stunts. My guess is, what clothes, the simple question, okay, are you sort of getting clothes? Is the baby getting bigger? Those sort of indirect questions. Is the baby looking healthier? I don't know. Apart from that, practically how we do it.
My view is that because grams actually matter under 3 months, when we talk about 25 grams a day growth, it really matters. The scales that people have at home are not accurate enough. So we just have to bring children in safe environments. I mean, there was a question from a delegate called Tabana, who asked about how, if we are monitoring failure to thrive, how often should we be weighing babies? What's the ideal interval between one weighing and the next to actually see a difference?
I think if you're talking of a little infant under the age of 1, as we are saying, doubling the birth weight by 5 months and tripling by 1 year, it's important. 4 weekly is what I'm going to say. Do it 4 weekly initially, or in fact, if they're dropping a lot of weight, 2 weekly. When you get the confidence that the growth is happening, you can loosen up, because we do not want them to sort of at 1 year be a weight of 5 kgs or 6 kgs. This has happened, and that could really be catastrophic. So really intense weight monitoring. Once we have the confidence things are getting better, we can loosen up.
I mean, my view is that there are some things that just have to be done. So even in a pandemic, failure to thrive is so important, and it's so vital to get accurate recordings that we just have to create safe environments for these to be done, whether they're in a health visitor kind of setting or in a GP setting in a cold clinic or what have you. The other thing that people were saying was about ethnic and racial differences for growth charts. And what your experience is of using adjusted growth charts for different races, given that most of us, I noticed, are in London and we have such a diverse population.
I think so. The simple answer here is look at what centile the little baby was born. I work at Royal London, so we have a majority of Bangladeshi population, and they are going to be literally maybe 2/3 the size of a Caucasian baby, that sort of thing. So as long as they continue to follow that sort of centile, whatever chart you use, I'm not going to expect this baby to be growing at 50 or 60th centile of the standard chart. As long as they're doubling the birth weight, tripling the birth weight at the right time, I would not worry about what chart you use. Absolutely not. It's just multiple. Important point is plot the weight and height if you're worried multiple times. You can't make a diagnosis of failure to thrive with just a single sort of parameter. You have to have few readings.
Excellent. Thank you very much. Actually, I think that's our 2 or 3 minutes, Dan.
So one question which was asked by Kai was B12 and folic acid, and we never in pediatrics do it unless it's a sickle cell kid or something else or something, because the kids normally will eat everything. They'll drink milk, eat meat, eggs. Also, formula milk is enriched. So we've never seen this. So please save some money. Do not spend money on B12 and folic acid, because you get abnormal results and then you chase the tail by doing more results. So don't do it.
Yeah, and it fits very well with the quote from the beginning. Do as much as possible for your patients, but as little as possible to them. I think that's a theme throughout all the talks today. You know, we must not create more iatrogenic problems, you know, and over-investigate.
It's called vomit, Rob. It's called vomit, victim of medical intervention and technology. Absolutely. That's what it is called.
Absolutely.
Let's go to the next talk. Yeah.
Okay, great. So the next talk that we have is on red flags for developmental delay and autistic spectrum disorder.
My next talk is on red flag signs for developmental delay, autistic spectrum disorder. Well, I think the best way, if you want to end up in the wrong destination or to miss a diagnosis, is to ignore a red flag sign. Neurodevelopment, by definition, is a process wherein a hapless little infant, through the journey of achieving various milestones, becomes an independent individual. Understanding milestones is really crucial here, and it is the cornerstone in the process of identifying delays or regression. Not every child is going to, for example, walk at 12 months. Some might walk at 15 months, 18 months, and that is still normal. That normal is the limit age or the 2 standard deviations. So anything within that 2 standard deviation would still be classified as normal, but anything which is beyond the 2 standard deviation is not normal. So what are the 4 aspects of neurodevelopment? Gross motor skills, that's your sitting, walking, running, climbing stairs, riding a tricycle. Fine motor skills, holding a pen, using cutlery. Speech, language, and hearing. And really, hearing is important, because if the child cannot hear, he will not be able to speak. And the last part of your neurodevelopment is the social interaction, the emotional and behavioral interactions. How does a kid react when there are children around them? Do they want to play with them? Do they prefer to play alone? Are they happy when people are around? Are they able to exhibit emotions? And that, again, is really important. So what are the different ways in which a child could come to the GP practice? The family could make an appointment with the family GP because they have concerns about their child's development. The child does not behave or does not perform skills as his peers do. Or it could have been picked up by the family GP when the child came for a totally different reason. Or the concerns could have been raised by the health visitor. So what are the screening questions you could ask? I mean, in a 9-10 minute consultation, it's a real short time, but maybe these questions could help. I would ask questions to the family, direct questions about, do you have any concerns about how your child uses their hands and legs? How do they talk? How do they behave? Has your child stopped doing things which they were able to do previously? And a really important question to ask when you're talking of neuroregression. Does your child enjoy playing with toys? Is he imaginative? Is she able to express joy or happiness? Again, something which would point towards a diagnosis of some form of autistic spectrum disorder if present. Does your child prefer to play on their own? Does the child have any particular mannerisms, the way they behave, the way they talk, the way they look at things? Do they line up things? Again, something which goes towards a diagnosis of autism. Past medical history is important. Was the baby born early? Was there any evidence of hypoxic ischemia at birth? Did the child have any serious infections, acquired or congenital? Did the child have a head injury? Were there any problems with feeding and growth? Is there history of consanguinity? Is the child hitting the milestones at the right age? What would you expect when you're examining this child? Has this child got any evidence of floppiness or stiffness? How is the gait? Is a 1-year-old already using right hand only? Not a good sign, because we do not expect hand dominance until the age of 18 months. In the clinic, how is the kid interacting with the parents, interacting with you? Are they interested in the surroundings? Is there any concern which you can pick up with regards to their speech and hearing? Documenting those milestones is really important, be it in the Red Book, but also in your GP notes. A quick slide on tiptoe walking or toe walking, something which is really common. We do get referrals every now and then. And unless there is something else associated with tiptoe walking or toe walking, nothing to worry. We could still wait till the age of 3, but if it still persists, if there is a feeling that the muscles are really tight or there is some other concerning features, pick up the phone and speak with your physio or your pediatrician. So red flag signs, when do you worry? I've given a link below where it's a detail of every milestone, when should it be achieved and when should you be worried. But just a few pointers: if a child does not sit by 9 months, does not walk by 18 months, cannot put 2 words together by 2 years, cannot scribble by 18 months, does not by the age of 18 months show any interest in playing or interacting with others, does not give eye contact or facial expression by 9 months, these are worrying signs. If you were to do some baseline investigations before you wanted to refer the child, you could do a nutritional screen, see what the hemoglobin is, see what the vitamin D, the bone profile is. Specific screening tests include CK, especially if you're worried about any form of muscular problem. Creatine kinase is a really good test, and thyroid functions. Once you've identified that the child does have problems with some form of delay, be it motor delay, speech delay, or a combination of everything, the next step is, where do you refer? If it is concern about speech and language or autism, the best place to refer them is your community pediatrician and the speech and language therapist. If the concerns are more about fine and gross motor delays or regression, and I'll come to regression in a minute, then pick up the phone, speak with your pediatrician on the hotline, and refer the kid to them or the pediatric neurologist. Neuroregression, a couple of slides on neuroregression. Losing a milestone. For example, a child who was able to stand and walk is unable to do so, is a worrying sign. Nowadays, everyone has a mobile phone, smartphone, lots of videos of the child, and the parents will show it to you. And if you do identify a loss of milestone, in one way it is an emergency, please speak to your pediatrician on the hotline and refer them for further tests and assessments. So what are the causes of neuroregression? I think so these are a group of conditions, very specific genetic metabolic conditions or chronic viral infections or toxin exposure, which leads to neuroregression. Examples: if your white matter is affected, it's called leukodystrophy. If it's a gray matter which is affected, it could be Rett syndrome. Sometimes along with the brain, other organs are affected, and these are your storage disorders, be it lysosomal, peroxisomal, or mitochondrial disorders. To summarize, not every child will achieve the milestone at the same time. Important to know what the true standard deviations for that particular milestone is, and if the child does not achieve milestones within the 2 standard deviation, important to refer them on. Having a basic idea of milestones, fine motor, gross motor, speech and language, and behavioral,
and social interaction milestones is the cornerstone for picking up red flag signs. Early pickup is really important so that therapies and help is available as soon as possible. Neuroregression in one way is an emergency. Please refer early. Thanks a lot. I've put in some references which tabulate the different milestones when they are achieved. And I do think this would be useful.
Great, thanks, Akshay. So there's just one question in the chat.
I know, I'm just wondering, I mean,
is everybody a bit overwhelmed?
All doubts, everyone's gone to sleep. What's happened here?
Yeah.
Well, listen, just in case people missed it, I think the answer was 18 months, wasn't it, for handedness?
It was there in the
It was there in the talk, so we've got that. One of the things that people sometimes ask me in my surgery, or they refer to other children that they have in families where there's more than one child, they might say, yeah, but he's a boy, so he's going to walk at a much later age than my daughter did. Is there any evidence for a difference in acquiring milestones between the sexes?
Absolutely not. I don't think so. You know, every kid is individual. If you look at it, boy, girl, till the age of puberty, they're almost the same, you know, and then the hormones will separate them into a boy and a girl. If you look at, you know, variations also, there are kids who will start walking at 9 months, and there are kids who will start walking at 18 months. And boy, girl does not. Yes, boys might talk a little late. One point taken, they might talk a little late. But apart from that, nothing. And maybe the first kid, I've got two of them. The first kid is slightly take their time. The second kid looks at the sibling and learns pretty quickly.
Okay, and the other thing was that there has a question come in again from Tabana. Thank you, Tabana. That's the second question. So credit to you. She says he or she. I apologize. I don't know if you're male or female, Tabana. How to manage if a baby is noted to have poor neck control after 3 months of age?
And again, I mean, the chart which is there will tell you for neck control, which is the 2 standard deviation. So anything which is beyond the 2 standard deviation, and forgive me, but I do not know, I mean, it will be about 4 months or something, 4 or 5 months, is not right. So look at the charts, anything which falls outside 2 standard deviation for any milestone. And first 2 years of life really is important, because that's where most obvious things happen, and you have to pick it up. So anything beyond 2 standard deviation, refer. You have to at least discuss. No, I'm not saying refer. Pick up the phone, speak on the hotline, do the use ERS or any of those resources. You know, if you want to email your consultant colleagues and get the question out.
Excellent. And one final one, Sarah Jane's just written a question which I had actually had a similar question, which is about the role of direct referrals to things like speech and language therapy. Should we be referring directly to allied services, or should we be referring to community paediatric teams who then can refer on to multidisciplinary services to have that approach? What's the preferred, how do you prefer patients to be worked up prior to a referral?
I think it's a very difficult one, because community pediatricians, the waiting list is too long. It's too long a waiting list. Every area, you know, the waiting list will be different. Access to speech and language, dietitians, physios is different. So it depends upon area to area. If you can get an appointment with a physio, for example, if it's a gross motor problem, get it with the physio quickly. If it's speech and language, but you're worried about autism, at least get the speech and language therapist to see, because they might be able to see them quickly. Community pediatricians, unfortunately, are really working their socks off, but appointments wise, it's difficult. So I would say if you can get them into the allied health, so the dietitians, physios, that sort of thing, speech and language, we should take that and also make the referral if necessary, to the community pediatrician.
Excellent. Dan, how are we doing for time? Can I take one more, or must we move on?
I think we take one more. Yeah.
Okay. So there's one about neuroregression, which was a theme of your talk, and that's an important phrase, and it has a very specific meaning. And the question is, do you see neuroregression in autism?
Autism is where you stop. You don't regress. So for example, a kid at the age of sort of 2 has not done anything. Regression is where you've gone backwards. So someone who was able to run and jump is now not even sitting and losing balance. And then also having other things. In neuroregression, it's not simply loss of skills, but you also have fits, you also have feeding problems and everything else. In autism, classically at 18 months, 2 years, you start seeing those patterns of a routine, some mannerisms, speech which is not coming out, and they're not able to express themselves, express happiness. So we should differentiate autism from neuroregression, because you'll have a lot more in neuroregression which is not there in autism. Not that I don't see epilepsy in autism, but that's a totally different thing.
Great, thank you very much.
Great, I think we've run out of time there, I'm afraid. So we've got a few more questions, but we're going to have to move on to the next talk, which is also going to start with a poll. And this talk is on recurrent infections and when to refer.
So my next talk is going to be on recurrent infections and immunodeficiency. So let's start with another interesting quote, this time from Louis Pasteur: "Chance favors the prepared mind." Whenever you're investigating a kid with worries about recurrent infection, the best available diagnostic tool is a thoughtful clinician, that's yourself, with a good working knowledge of what is normal in terms of frequency and severity of childhood infection. Once you know that, everything else falls in place. So we will talk today about some basics of the immune system. So what are normal infections, what are not, common presentations, what are the different possible causes of recurrent infections, a brief talk on primary and secondary immunodeficiencies, what questions to ask, examination and investigations, and when to refer. So a typical presentation could be an 18-month-old. Parents, bring this kid to yourself because this kid's been having recurrent infections, and the parents are worried that there is some problem with the child's immunity. So what are the possible causes? Why is this kid getting so many infections? Well, more often than not, this could well be an absolutely normal child, a preschool kid whose immune system is maturing and it's getting exposed to various viruses. Or it could be a kid who has got multiple allergies, atopies, with a normal immune system. Up to 10% of kids could have chronic disease, not immunodeficiency, but chronic underlying conditions. And less than 10% would have some form of maybe immune deficiency, primary or secondary. So let's talk about our normal child. Well, this is a preschool kid who has a normal immune system which is maturing. He's getting exposed to multiple viruses. They can come from the sibling, through daycare, nursery. What are the type of infections they get? The most common infections are going to be simple upper respiratory tract or simple DNV. And they can get anywhere between 4 to 8 of these infections, which are self-resolving. Some papers quote up to 10 to 12. As long as they are simple, self-resolving, we do not worry. Smoking is an important factor, so really important to emphasize to stop smoking to the family, to the parents especially. And these kids will not have any issues with failure to thrive. So on your red book, they'll be thriving. Let's talk of the second child, the kid with atopy. Again, this kid would have a normal immune system. But because of atopy, be it hay fever, wheezing, eczema, they have very inflamed mucosa, increased mucosal permeability, which results in them catching infections. And the most common infections are going to be rhinitis, sinusitis, ear infections. The kids will respond to antibiotics, but treat the atopy and actually the infections will fall. Let's now talk of the 10% kids who have some form of underlying health problem, not a immune problem or a atopy problem, but a health problem. This is conditions like cystic fibrosis, reflux. The kid could be aspirating, kid could have some form of heart condition, congenital heart condition, or some form of anatomical problem. And here invariably there will be some form of failure to thrive. And that leaves us with maybe under 10% of kids who could have some form of immune problem, be it primary or secondary. And invariably they will have failure to thrive and serious infections. Some basics of the immune system, well, you know, the bone marrow produces the T lymphocytes, B lymphocytes. B lymphocytes are associated with your humoral immunity. That's the production of antibodies. T lymphocytes are associated with cellular immunity. The other important components of the immune system are your neutrophils, macrophages, and the complements. So how common is immunodeficiency or the primary immunodeficiency? This is a figure from the UK primary immunodeficiency register, and there are 5,000 registered patients. Prevalence is 1 in 13,000 in UK. So talking of primary immunodeficiencies, B cell deficiencies is a problem with antibody production. So typically you'll get infections in the cyanopulmonary area. Most common infections are encapsulated bacteria like pneumococcus and H. influenza. Examples are X-linked gamma globulinemia or IgA deficiency. And again, important to know that most of the primary immunodeficiencies affect boys more than girls. T cell deficiency, not that common, but really severe, leads to problems or recurrent infections with viruses, fungi, gram-negative bugs. One of the examples is DiGeorge syndrome. We then have problems with the macrophage-related illnesses. For example, chronic granulomatous disease, where you have multiple abscesses in the skin, lungs, lymph nodes, and the organisms are Staphylococcus and Klebsiella. Problems with complement-related deficiencies lead to infections most commonly in this area. And then you have the syndromes, be it DiGeorge syndrome, Wiskott-Aldrich condition where you have low platelets and eczema, or ataxia telangiectasia. A quick word on secondary immunodeficiencies can happen in children who are on steroids for multiple reasons. For example, nephrotic syndrome, undergoing chemotherapy, on some form of immunomodulating therapy, and more often than not, this is the buzzword. All these infliximabs and all these other mabs can cause problems because they modulate the immune system. Can happen where there is history of HIV, severe malnutrition, also common in children who have had splenectomies, be it the sickle cell children or post-trauma. Again, history taking really important. What are the questions we're going to ask? Where is the infection? How many infections has the child had in the whole year? How many courses of antibiotics have been given? More importantly, how many IV antibiotics have been given? How many hospitalizations have happened? Plotting on the growth chart to see if there is failure to thrive. Are there any problems with feeding? History of smoking in the family? Atopy? Is the child on any medicines? Really important questions to ask. Examination findings, classically in children who have primary immunodeficiencies, they might actually not have tonsils. You can't feel lymph nodes. Really odd for a 1, 2, 3-year-old to not have even a single lymph node which you can feel. Presence of hepatosplenomegaly, severe eczema, failure to thrive, and also checking your patient records to see what infections and how many hospitalizations this kid has had would be really important. If you are suspecting some form of immunodeficiency in the primary setting, you could actually not need to do a lot. You could just do a full blood count. Really important is lymphocyte count. If you have low lymphocyte count, please repeat it. That's one thing if you take away from this talk. Low lymphocyte count has to be checked again. Persistently raised neutrophils, again, not a good sign. Or persistently low neutrophils, low platelets in Wiskott-Aldrich syndrome, getting a blood film to ensure that all the cells look normal. Other things you could do is baseline immunoglobulin levels and check for signs of inflammation. I think this is the main slide of the talk. It clearly gives you the warning signs, what is not normal in your child you're suspecting to have immunodeficiencies. I'm not going to read through this, but really it's giving you a very clear picture of how many infections, antibiotics, hospitalization, failure to thrive, where are the infections, family history, a very comprehensive work done by Model et al. So to summarize, preschool kids will get a lot of self-limiting viral infections, anywhere between 4 to 8 or even more. It's not the number, but the types of infections, the treatment, are they hospitalized, are they failing to thrive? Really, this is what we should be looking for. Primary immunodeficiency is rare, but if you do have signs and symptoms of those, please refer. Also, please do not forget kids who have atopy and chronic diseases which could be associated with infection. Thank you.
Brilliant. Thanks for another very concise talk.
Thanks, Akshay. Dan, I saw one question come in on the Q&A, and that was about the point at which we should be investigating recurring infections. And I think what I've taken away, it's not the frequency, it's the type of infections. That's what I heard from Dr. Jain. But there was a second part to that question, which would be great to get your opinion on, which is transient blood findings or cyclical blood findings. Sometimes we might do a blood test in a child with an infection and find, I guess, the opposite of what you might think, a slightly low neutrophil count or a low lymphocyte count. So what's your view on transient findings and repeating blood tests?
So we classically used to get this when you used to do the famous 3-week prolonged jaundice clinic, that sort of thing. Used to find low neutrophils, that sort of thing. Or you routinely do bloods when there's a viral infection and you get these sort of things. The take-home message is lymphocyte count out of everything else is really important, because your lymphocytes will produce your immunoglobulins, will help with T-cell immunity. So lymphocyte count definitely repeated in at least 4 to 6 weeks time. Neutrophils, there is the phenomenon of cyclical or autoimmune neutropenia. And again, if the child is well, with neutrophils, you could wait, say 6 weeks, 8 weeks, but definitely repeat it. And if there's a consistent picture that they are low, you could speak with your hematologist. Yes, neutrophils can also be low in particular ethnic. There's ethnic variation also. So in particular ethnic background, you will get low neutrophils, like the African sort of population, where they can have slightly low neutrophil count.
As with all of these things, it's the context of the test, isn't it? Yeah. When the blood was drawn, was the child ill or not ill? That you're right. There's a variation in terms of ethnicity, particularly with neutrophil counts. So that's worth bearing in mind. One thing and we've just had a flurry of questions come in, typically just as we're about to wrap up. I think what we'll try and do is answer them in kind of when we're finished.
Yeah, I'll answer them, yeah.
Yeah, and we'll try and answer. There's one more that I had, which is I'm going to take kind of the prerogative of being the moderator to ask this question, which is we've had a few letters now hit our patients about the end of shielding for children and encourage children to get back to school. Once now the pandemic seems to be at a different phase. But there are children who still need to shield, right? So are there any kind of, for our GPs out there who are receiving letters saying, please review these children, are there any children who you would suggest absolutely should continue to shield whilst COVID is still circulating the country?
I know Dr. Riddell has got this in her COVID talk.
Oh, perfect. Perfect. So let's pause that and ask Anna to...
Thank you. Not that I knew the answer.
Yeah, great. So thanks very much, Dr. Jain. They were 3 really good punchy talks.
Excellent. Thank you.
Davidson.
Thank you.
Dr. Jane, thank you very much. Now we have Dr. Anna Riddell, who's a paediatric consultant at the Royal London, who's got a special interest in infectious diseases and safeguarding, presenting, and also Dr. Philip Bennett-Richards moderating, who is one of our local GPs in Tower Hamlets and our programme director. So the first talk that we have by Dr. Riddell is on aches and pains and vitamin D.
Hello, I'm Anna Riddell. I'm a paediatric consultant at the Royal London Hospital, and I'm delighted to be talking to you about a trio of common paediatric presentations this afternoon. So I'm going to start with aches and pains and vitamin D. First off, we'll have a case. So there's a 6-year-old girl who's brought by mum to your surgery complaining of pain in her legs for the last 6 months. Mum says she cannot do the 10-minute walk to school without complaining she's tired and in pain. However, once she gets to school, there are no issues. She plays with her friends in the playground and can do PE the same as the other children in her class. She does a gymnastics class after school and is one of the best as she's very bendy. The pain is often worse at the end of the day, and mum has to massage her legs to get her to sleep. Mum states that she herself has Ehlers-Danlos syndrome and is worried. So for this case, you want to consider, is there significant pathology here? And looking at the features, the most likely diagnoses are growing pains, vitamin D deficiency, or functional pain. But in fact, this child has benign joint hypermobility syndrome. So, what are the most common benign conditions causing leg pain? Well, growing pains is much discussed by families and also by GPs. It's a common condition, but interestingly has no direct link with high growth velocity. It's found in children mainly of school age, and the causes tend to be overuse and musculoskeletal variants such as scoliosis, but they can also be psychological and vitamin D deficiency. Growing pains tend to be bilateral and found in the lower extremities and tend to happen in the early evening or can actually wake the child in the night with pain. They're often episodic and occur with increased activity but don't limit activity. Interestingly, they're often associated with headache and functional abdominal pain. But growing pains do tend to respond to simple manoeuvres such as analgesia or massage. So moving on to restless leg syndrome, this is more commonly associated with adulthood but can occur in children. So it's worse at rest, improved by movement, and experienced again mostly at night or in the evening. Interestingly, iron and folate deficiencies have been associated with this, so it's probably worth checking if you're considering this diagnosis. And then finally, moving on to benign joint hypermobility syndrome. This is in fact very common, around 15% of the population, and seems to be more apparent in children. So it's caused by laxity of the ligaments and gives pain due to muscle overuse. So the approach to management is strengthening with exercise and pacing. The pacing is very important to explain to the family. So the child mustn't push themselves beyond the point at which they're experiencing pain, but must continue to exercise regularly. Often this syndrome is erroneously referred to as Ehlers-Danlos syndrome. Ehlers-Danlos is a collection of extremely rare genetic disorders which have a separate constellation of symptoms. They're not the same as benign joint hypermobility, but often the hypermobility disorders are referred to, given this term, particularly by parents. So going on to the clinical assessment, you've already taken the history and come up with a short list of diagnoses. You will have wanted to consider the psychosocial factors, which may be underlying the symptoms, but also may be actually caused by the pain. So, is the function different at school compared to the weekend? Have you identified any significant stresses for the child or within the family, which may be making the pain worse? Then going on to examination, it's really helpful to watch the child or young person walk along the corridor to your room, because this will give you an idea about the impact of the pain on their normal activity. In terms of formal assessment tools, the PGALS or Paediatric GALS tool is very helpful to assess gait, spine, range of motion, and it can actually be adapted to be done through video consulting, so could be quite useful. The Baton score needs a slightly more hands-on approach, but is very quick to do while you're doing PGALS and is useful if you're looking for benign joint hypermobility. Finally, thinking about investigations. For the great majority of simple benign problems, no investigations are needed. And if you did have to choose one, I would choose vitamin D, because treatment with vitamin D could actually have a significant impact on pain. If you're thinking about more significant pathology, you might want to go on to do tests such as full blood count, blood film, CRP or ESR, which are all helpful to identify an inflammatory process. A urine dip may be positive for blood if the child has juvenile inflammatory arthritis. An ASOT may indicate a previous streptococcal infection, which could give rise to a reactive arthropathy. You might find a raised CK in viral myositis, and the LDH may be very high with malignancy. Going on to imaging, the most useful test now is an MRI, which is very difficult to obtain for most primary care clinicians. An MRI is particularly important if you have a presentation of new onset back pain in children to rule out significant pathology, and this would be a good reason to refer on. I'm going to skip through the next 2 slides. So is vitamin D important? Nutritional vitamin D deficiency can lead to quite significant health problems in children. There are the well-known ones such as rickets, but also cardiomyopathy and seizures due to hypocalcemia can present simply due to low vitamin D. As I'm sure you're all aware, it's obtained from sun exposure and through some oily foods, but in the main, vitamin D treatment needs high doses of supplements. And the guidance which has been set out for both pregnant women and for infants is detailed below. I think it's now generally acknowledged that the great majority of children and young people, but adults as well, are likely to suffer from vitamin deficiency across the UK, and we know that it can cause symptoms, so I do think it's worth a trial of treatment, particularly if you've identified that the levels are low. So I have another case now. It's a 14-year-old boy who's been brought to the practice by his dad. He's been complaining of pain and swelling in his left knee, which has got worse over the last few weeks since the start of school. He's now finding it difficult to put weight through the leg. He's had fevers on and off and also a body rash last week, which has now faded. He had a minor injury playing football a week before the symptoms started. The family also say that they've been on holiday in Bangladesh over the summer and he'd been fine. He has been feeling tired recently and has had some weight loss which he can't explain. He's obviously limping as you call him into the clinic room. So there are a number of red flags in this case which will lead you to be concerned that there is significant pathology going here. And a list of the diagnoses could include septic arthritis, osteomyelitis, osteosarcoma, leukemia or TB. But in fact, this young man has juvenile inflammatory arthritis. So this slide lists some of the red flags you'll want to look out for if you're concerned about significant pathology, and many of them you'll see were in the previous case we've just discussed. At the bottom I've put safeguarding concerns. It's really important to remember that sometimes functional pain can present with a background of safeguarding issues which should be explored. So what do you need to worry about and what do you not need to worry about with these presentations? Well, the common and self-limiting presentations we've already discussed have no red flags, are often self-limiting, and may respond to a trial of treatment. However, some of the more significant pathology can lead to really significant morbidity, so these diagnoses do need to be identified and referred on. Don't forget orthopedic problems such as slipped upper femoral epiphysis, Perthes disease and Osgood-Schlatter, which would need specialist opinions. And finally, think about chronic pain syndrome, or ME, which can be associated with significant psychological morbidity. So when do you need to refer? Well, if there are no red flags, but the symptoms have persisted and you've tried some treatment modalities such as vitamin D or physio, then consider referring on for further assessment. If the pain management strategy is not working, that would be another reason to refer on. If there was limitation of activities of daily living, or if you were worried about a serious underlying diagnosis or specialist treatment was required. And then finally, just to re-emphasise, if you have a concern about a safeguarding or associated mental health issue, that would be another reason to refer on. Finally, I've just put some resources here for further reading. Thank you for listening.
Thanks, Anna. I think that's a very common problem we do see quite a lot in primary care. There's been a few questions that we've managed to answer, but a couple more.
Yeah, thanks very much for that, Anna. That was a very useful talk, and thanks to everyone who's staying around for the last session. There's not been much fall off, so really good to see you all still here. There are a few questions that are unanswered, Anna, about vitamin D. Yasmin has one around, if you suspect vitamin D is low, would you recommend treating without a blood test?
I think you could. I would probably treat vitamin D deficiency only really if you think it's causing symptoms. There are many children who do have vitamin D deficiency, and one of the questions said earlier that the incidence is probably about 50% in the adult population. I think it's probably the same for children. So, but many of them are not symptomatic. So it's always worth a trial, a treatment, and then if that doesn't work within sort of 4 to 6 weeks, you might consider going on to the next level with investigations.
Thanks. Another question's come in around co-administration of oral vitamin K with vitamin D. What's your view about that?
Well, I think, again, it's thinking about why you're doing that. So if you think that there is a common problem with fat-soluble vitamins, which is what they both are, so that's either due to malabsorption or an issue around fat in the diet, then you might want to. But they are quite different vitamins. They do different jobs. So I think you need to be really clear about why you would be adding in vitamin K. I wouldn't do it automatically.
But certainly not a routine intervention.
No.
Okay. Shailesh is asking around the dosage of vitamin D and has pointed out that in certain ethnic groups with darker skin tones, do you find commonly that you have to up titrate 400 units, maybe to 1,000 units daily?
It depends what you're trying to do. So if that's for maintenance of vitamin D levels, then yeah, possibly 400, 1,000 is probably not going to make a massive difference. It's very safe dosing, so there'd be no issue about increasing it. However, if you suspect there are very low vitamin D levels associated with clinical symptoms and signs, you're going to be going for much, much higher doses than that. In a teenager, you're looking at 10 to 15,000 units a day, for example. But the guidance which I referred to in my talk is really helpful. It gives a lot of clarity around dosing.
Great. And the final question on the list at the moment is, could you clarify that? Would you recommend imaging for all children with new onset of back pain, or how would you manage if someone walked in, say, to the surgery with back pain? How would you wouldn't have us sending everyone up for imaging? What sort of level of wait and see would you suggest before you did? Obviously, it's going to depend on the presentation, but if you could give us some guidance on that.
Yeah, I think back pain in children is a real red flag. So you're not going to be able to access MRI, which is the go-to straight to test, basically. For MRI is what you're going to be wanting. So my recommendation would be to seek urgent paediatric advice through a hotline or a rapid access service. Get the young person or child seen clinically, and it's highly likely that they will end up having a semi-urgent MRI to explore it. I think that's probably the most likely route in most of the areas that GPs will be working in.
That's wonderful. Just one more supplementary question on the vitamin D. We always say with adults that if you've ever been low in vitamin D, you need to take a daily supplement. Does the same follow in children, or is that something that you think that we should avoid?
Well, I think there are a lot of people who believe that every child in the UK should be taking vitamin D every day. And I don't think I disagree with that, because again, it's a really safe drug. I suppose it comes down in the end to public health cost and the benefit that you get from that. So for any individual child, if you're concerned about ongoing vitamin D deficiency, you can't really go wrong by treating them.
With 400?
Yeah, with maintenance dosing, yeah, just to maintain your levels.
Okay, and I'm right in saying I think that I answered the question on the list. I'm right in saying that I think Healthy Start vitamins are available for the under 5s from health visitors in children's centres. But otherwise, I think with the demise of the Pharmacy First scheme, I think it's now a purchase for children for vitamin D. But I think it'll differ in different CCG areas. Great. I think we're clear to go on to the next talk.
So for my second talk, I'm going to be talking about lumps and bumps. So I'm going to start with a case. A 2-year-old boy is brought into the surgery by his father. He's noticed several small lumps around the child's neck, and in particular one lump under the jaw, which is quite large. The lumps have been there on and off for months and seem to start when his son began at nursery. He seems to get coughs and colds every month, and the lumps increase in size when he's unwell. The lumps don't bother him and have never hurt when touched. The family travelled to Eastern Europe a few months ago and were in contact with a family member who was unwell with a chronic cough. They're worried as a relative's child was recently diagnosed with lymphoma and had similar lumps in the neck. They do think their son is generally well, but want to know if he might have cancer, and also wonder if the recurrent infections mean his immune system is low. So what's the diagnosis? Well, a differential could be lymphoma, cat scratch, or tuberculosis. But in fact, the diagnosis is actually reactive lymphadenopathy. I put this slide in to cover over some of the other possible causes of lumps and bumps in children by category, and some of the ones you may see quite frequently would be, for example, the traumatic causes which happen around the time of birth, and the family may present to you at the 6-week check with an unresolved caput or Keffel hematoma. Fat necrosis is another commonly misdiagnosis. So around the time of birth, there can be a traumatic injury which causes damage to the fatty tissues, and on healing you get a small, very hard, often not very mobile lump around the back of the head, and it usually takes a number of months to resolve. We've talked a bit about infective and inflammatory causes in the previous slide, and also clearly the neoplastic causes are the ones you're going to be interested in ruling out and that the family are going to be most concerned about. There may also be developmental causes, most of which will have been picked up around the time of birth. but these may present to you later on, again at 6-week check, and they would need referral on to specialists in paediatric surgery. I've included some pictures on this slide just to illustrate the possible differentials from the slide before, and in particular I would look at the picture of the child with the lymphadenitis, because you can see there's some overlying erythema and probably increased swelling, so you might be considering whether this is a superinfected lymph node. Thinking about reactive lymphadenopathy, it's extremely common. Around 44% of children younger than 5 will have palpable lymph nodes, and they're normally seen around the neck, but you can see them in other places. These nodes can persist for months or even years. They may go up and down in size with infections, but they're often very easily visible because in the younger child, the neck can be quite slim and there's not a lot of fat covering, so they're easy for the parents to see. The parent may describe a preceding upper respiratory tract infection before the mass was noted, and some simple clinical assessment and tests can help you rule out significant disease, particularly lymphoma. So going to the clinical assessment now, this follows the usual pattern, looking at history and examination. So you'd want to find out, were there recent upper respiratory tract infections which may have triggered the lymphadenopathy? Have there been particular animal exposures, thinking about cat scratch disease? And then if you work in North East London, you'll probably be quite interested around possible exposure to TB, and this could be knowledge of an index case or travel abroad. Then going on to the examination, there's some really useful information you can get from the examination, so it's helpful to pay attention to this. So shotty lymphadenopathy is absolutely typical of reactive lymph nodes, and these are tiny nodes that feel like buckshot under the skin, and I'm sure all of you have examined children's necks where you've felt this. However, if you go to examine the neck and you find something that's hard, irregular on the surface, or it feels a bit firm or even rubbery, and particularly if it feels like it's fixed to the underlying tissues, then that's when you're going to be concerned about either an atypical infection or a malignancy. Probably the most critical part of the examination is to think about assessing the size of the lump. So lymph nodes, particularly around the neck, under the size of 1 centimetre in diameter, are normal in children younger than 12 years. Just remembering that the jugulo-digastric node can be quite large. However, if you find persisting enlarged lymph nodes which are greater than 2 centimetres, that's when you need to be concerned. Just remember, however, that this can be quite a tricky clinical assessment to make, so it would not be uncommon to find a node which appeared to be very large, but it in fact was made up of multiple little lymph nodes that are clumped together in a cluster. And if you're not sure, then probably the best thing is to think about how you could further assess that. I've put the box here in the slide really just to help you collect all the information from your assessment into a diagnostic framework, and therefore come to some kind of decision about what is likely to be the cause of these nodes or masses. So what are the red flags to look out for, and what are they going to tell you about the possible diagnosis? Well, if you have a child with fevers, rapid enlargement of the node with recent onset, tenderness and overlying erythema, then it's most likely that there's going to be an inflammatory or infective cause for the mass. However, if the mass is rapidly growing in size and you've identified some constitutional type B symptoms, which would be associated with lymphoma, these are symptoms such as malaise, weight loss and night sweats, then consider whether this may be a malignancy. and think about the time frame for these symptoms. If, however, you have a child who appears slightly more unwell, has had persisting high fever over the last 5 days or more, a bilateral conjunctivitis, an erythematous rash, and oral mucosal changes, then you may have a diagnosis of Kawasaki disease. This is clearly quite an important diagnosis to make because there are significant consequences for the outcome with Kawasaki disease. The bottom line is if the mass persists for 6 weeks or gets bigger if you've decided to treat with antibiotics, then you need to think about a neoplastic lesion and then need to think about how you're going to further assess this child. So many parents who come with masses are concerned about cancer, and it's quite useful to understand something about the incidence of cancer in order to frame your consultation with them. So there are around 1,900 new cases of cancer in children and young people in the UK every year, but children's cancer accounts for less than 1% of the total number of cases, so it is rare. The incidence has gone up over the last decade, and leukemia is the most commonly diagnosed cancer in children. And currently the risk is around 1 in 500 by the age of 14, which seems like a slightly higher number than you would expect. The most common cancers, as you can see from this chart, which I've got from Cancer Research UK, are leukemia, brain tumours and lymphomas. So once you've done your assessment and made a decision, you need to think about how you're going to manage this child ongoing. So I would consider, particularly with the larger lymph nodes, doing some simple blood tests. The ones which we would recommend include full blood count, ESR, CRP and a blood film. And these will really help you try and tease out whether there is a likelihood of cancer, a serious infection, or whether this is likely just to be a benign node. Ultrasound is a really helpful and simple test to do for the child, and it's also you can order it from primary care. So I would consider doing ultrasound, particularly if you're not clear about the size of the node and the nature of the node. I've put a list of the specialist tests here just for your reference. These would sometimes be done if you refer this child up to secondary care for a further opinion. So in terms of approaches to management, I think in the great majority of cases, watchful waiting is appropriate, as long as you advise the parents about the red flags, which we've talked about on the previous slide, and also just tell them what to expect about the natural history of these nodes, that they do tend to shrink over time, but they can go up and down with infections. You might consider treating with antibiotics if you think there is a superinfection, and if you do, target these two bacteria, Staph aureus and group A strep, with the following antibiotics. So when should you refer? Well, if you think you need a specialist opinion or a surgical intervention, particularly with developmental masses or infections, then you'd need to refer on. And then if you do think there is a malignancy, and think about the criteria we've already discussed for that, which are listed below, then that will require referral. If the lump is over 2 centimetres in diameter, do discuss with your local paediatric team and refer for urgent review. And I think it's more appropriate to discuss this over the phone or through your local rapid access processes rather than submitting a 2-week wait referral. So I hope that covers most of the questions you have about lumps and bumps, and I've just put some references here at the end for you to use for further reading. Thank you for listening.
Great, thank you, Dr. Adele. Quite a common problem that we deal with in primary care quite a lot.
Great. Okay. We're just a little bit behind the clock, so we'll just take 2 questions. very quickly, Anna, a question in the chat has come in. When should children with mild clawing of toes and those who walk on their toes be referred? I think actually dealt with this a little bit, but have you got a definitive answer?
So if a child is a toe walker, they should be able to get their feet flat on the ground standing passively. So they'll often toe walk when they're actively walking, but when you examine them, they should be able to get their feet flat on the ground. If they cannot do that, then they probably have Achilles tendon shortening, and that might be an indication of diplegia. So I think that's a simple test to help you decide. Clawing is a bit more tricky. I think it's quite rare in children to see clawing of the toes, but again, it can be related to muscular atrophy and much rarer neuromuscular problems. So I think if the child has not just clawing, but has clinical signs or symptoms which might indicate an underlying neuromuscular condition, then I would refer on. However, if they are functioning completely normally otherwise, then it may just be an anatomical variant and just require watching and monitoring.
Okay, thanks. And do you have a sort of ballpark figure for watchful waiting for lumps?
Difficult one. Could be months, could be years, because younger children just seem to have lymphadenopathy all the time. Anybody who's got young children, they go home and feel their child's necks, they probably can feel a lymph node at any point in time. So it's just one of those things that you tend to be very, very common. So it's really much more, it's not duration, it is about those red flags. It's looking for the red flags.
Okay, so normal bloods, looking at absence of red flags, carry on watchful waiting until you feel that you've watchfully waited long enough without any particular ballpark.
Yeah, and I suppose you'd have to take into account the level of anxiety of the parents. So if you do have a family who have close relatives with lymphoma and they're very worried, then you're more likely to do tests which might provide a bit of reassurance.
Yes, yes. Okay, thank you. So shall we go on to the next talk?
So this is my final talk on safeguarding early warning signs. All of you will have done a fair amount of safeguarding training in the past and will have to do it regularly as part of your statutory and mandatory training. And so you'll be aware it's impossible to cover the topic in 10 minutes. So the approach I'm going to take is to give a very brief discussion around a case and then some extra issues. And I've also documented in your PDF more detail to look for on the specific areas of abuse, which you could refer to during the talk if you would like. So 1 in 5 adults have experienced at least one form of child abuse before the age of 16. And this is ONS data from last year. And you'll be very well aware of the 4 categories of abuse which are outlined on this slide. I think it's important to note that neglect is by far the largest category. And therefore there's a big focus on prevention of neglect in social care. It's important also to appreciate that multiple types of abuse can exist at the same time. So I'm going to take some time to go through a quite complicated safeguarding case with you to try and illustrate safeguarding in practice. And I'd like you to look for the early warning signs, but also potential protective factors that come up through this case. So we start the story with a 19-year-old woman who had a baby that died unexpectedly at 7 weeks of age. The coroner agreed a cause of death is sudden infant death syndrome. Mum then spent a period of time as a sex worker and became pregnant, delivering a girl weighing 3.2 kilograms at term. During the pregnancy, she was treated for an STD and possibly had some drug exposure. She was supported by social workers and her GP prior to the birth and was under a specialist midwifery team postnatally. So looking back at this section, there are some obvious vulnerability factors. This woman was only just an adult when she had her first pregnancy, and she then became a sex worker and was possibly abusing drugs. However, there are a number of protective factors, and the care that was wrapped around her meant that she had a normal pregnancy and delivery and was supported afterwards. So going on to the next stage of this story, following the birth, the baby had repeated attendances at a local A&E department with minor complaints. She had several admissions to hospital and a monthly follow-up in a paediatric outpatient clinic. She also saw her health visitor regularly. She was breastfed for 5 months and had normal development. At 7 months of age, she presented with an unexplained fracture. This was investigated as a child protection issue and then stepped down to child in need. Mum attended some parenting classes supported by her social worker. So there are a number of positive things in this section. The mother appeared to be engaging quite well with health and social care, and her baby was making very good progress. We may never know if the fracture at the age of 7 months was a non-accidental injury, but again, this was picked up and investigated, and Mum was supported after this event. So going on to the final section, Mum was later rehoused and began living with a new partner who was supportive and helped care for her child. Mum found a job and he looked after the girl when she was at work. The child began attending nursery and was initially described as happy and sociable, but then became inexplicably withdrawn and fearful. One day on returning home, mother found bruises over the girl's thighs and became concerned as her daughter had recently developed a sore bottom. She presented to the GP, concerned that her child may have been interfered with. So I imagine this must be one of the most difficult situations for a GP to have to deal with, a possible allegation of sexual abuse. So in this case, what would you do? The framework at the top of the slide here is described in the government document What to Do If You're Worried a Child is Being Abused, and it sets out the steps very, very clearly. Be alert, question behaviours, ask for help and refer. And the guidance below is taken from the current NICE guidance on child maltreatment, and it's a very similar kind of framework. So the first step is to consider abuse. If you've identified some concerning features, then discuss this with a colleague, gather more information from other agencies, and ensure that you do review the child or young person, and you may have to do this several times. Once you've gone past this step, if you suspect abuse because the information has raised a level of concern for you, then your responsibility is to refer the child or the young person to children's social care. And you'll all be aware of the local arrangements to do this in your area. If, however, you've gone through step 1 and you've found a suitable explanation for the features that you've picked up, then you may be in a position to be able to exclude abuse. It's still very valuable to have gone through these steps because you can document what you found, and this may be important in the future if further episodes occur. It can be very difficult trying to help a child or parent share a worry about child abuse. So these are some of the tips on how to do this most effectively. So try and remain calm, be aware of your non-verbal messaging, and try to avoid making comments or judgments about what they're saying. Allow them to talk freely about what's happened and try not to ask leading questions. If you can't understand the child or parent, then think about using an interpreter or advocate to help you. And finally, the most important thing is you need to be really honest with family about what your concerns are and what the processes will be next. The only circumstances when you do not do this is if you're worried that this will put the child at risk of harm. And probably the classic situation for that is if you're concerned about factitious or induced illness. Most practitioners who work with children have been worried about their safety and mental health during the period of lockdown. And there are some specific issues around safeguarding which have been raised during this time. We know there are less opportunities for early recognition and response, and child abuse does appear to be more of a hidden problem. We know that there's increased socioeconomic adversity and increased rates of domestic abuse. Children are much less visible as they're not in school, and there are no home visits being done and minimal face-to-face appointments. So children's voices are not being heard, and this is literal. If you think about your own practice, the number of times that you're able to speak or see a child in your virtual consultations. Quite a number of services has simply been stopped, and this is certainly the case for specialist community paediatric services, such as looked after children and autism assessments. And there's a reduction in foster care placements due to concerns about the risk to older adult carers. We know that referrals for CP medicals have reduced, or the need is probably much higher. So when you're faced with a child protection or safeguarding issue, please do consider the additional impact of lockdown. There are many other areas in child safeguarding which are helpful to understand, but I don't have the time to cover them during this talk, and I've tried to signpost you to further resources and opportunities to training on the final slide. Thank you very much for listening to all three of my talks.
Thanks very much, Anna. That was great. Always a very sensitive issue for us all to deal with in primary and secondary care, and any tips gratefully received. There aren't any outstanding questions on the Q&A. Actually, I can see you've come live. Do you want us to crack on?
If you want to go for a couple of questions, don't mind. You are almost on bang on time, so 5 minutes would not make a difference.
So we don't have any questions that are outstanding. So I think maybe taking the COVID questions later. I know there were a few COVID questions before that came up earlier this morning. So I suspect there will be more COVID questions than that we could deal with after the next presentation.
Fine. So Anna's going to do this one live. This is the only one which is live, and she's going to screen share. So over to you, Anna.
So I'm doing a quick COVID-19 update, just to be topical. It's in two sections. So the first is really a bit of a background about COVID-19 in children. A lot of the information that I'm presenting here is sourced from Don't Forget the Bubbles, and they have done some excellent work analysing about 450 papers on COVID in children. So if you want to explore this in a bit more detail, do go onto their website and have a look. Essentially, it seems that children are significantly less affected by COVID-19 than adults, which is a good thing. I think we weren't totally clear about this at the beginning of the pandemic, but it is now becoming very clear that that's the case. They also tend to be quite well with asymptomatic or mild disease. And this WHO chart just demonstrates the really dramatic difference between adults and children in terms of number of cases. So you can see there at the bottom, up to the age of 19, minimal compared to the adult cohort. So thinking about transmission, interestingly, again, the data really demonstrates that COVID-19 is mainly spread between adults and from adult family members to children. So there's a lot of concern about children going back to school and transmission between children and then from children back home to households. And the current evidence is actually the risk of that is much, much lower than adult transmission, which I suppose should be quite reassuring for us. And one of the reasons for this might be the fact that they seem to have very low viral loads. I don't know if you can see the chart here on the right, but it shows that the viral load in children is significantly lower, particularly than the older adults, and it just increases with age. The incubation period for children is quite a bit shorter as well, I think, than for adults. Oops, I'm just trying to fiddle around with my, there we go. So coming on to clinical features, well, the great majority of children don't develop any symptoms at all or have subclinical symptoms. And then others have the same symptoms that adults do, but also in addition, symptoms such as diarrhea and vomiting, which perhaps are not recognised so much in adults. There's been an interesting case series of children presenting with rashes looking like chilblains, often on the feet and toes. But in summary, there's very little in the way of clinical signs in children which differentiate this viral infection from any other childhood respiratory virus that you will have come across many, many times in your practice. So difficult to tell, I think particularly in this coming winter, whether this is going to be flu, RSV, enterovirus or COVID for a child. There was a question about shielding earlier, that's on my next slide, but this is looking at special groups of children and the considerations you may need to have for them. So looking at children with comorbidities, it seems that the rates of complication from COVID are not disproportionate, again, to those from other respiratory viruses that you will have seen in many children. So it's not going to affect them severely this winter any more than flu or the other viruses around. In terms of newborns, in general, mothers and their babies do tend to do very well, but there is now a recognised small but notable increase in the rates of preterm birth with COVID, and hence the advice around pregnancy, which is via the Royal College, and I put at the end of the talk as a reference. This is just a little snapshot for interest of our experience at Barts Health NHS Trust, and it is the largest acute trust in the country. So despite that, across all of our 3 sites, we've only actually had 50 positive swabs during the height of the coronavirus period. We did a little audit looking at our experience. So some of the interesting things are that there's a wide range of presentations, as you can see there at the bottom left. The great majority of children, as I said, had no comorbidities, but those who did, it seemed to be mostly respiratory and also developmental delay, such as cerebral palsy or genetic conditions as a predisposing factor. I think the ethnicity data are the most interesting. So if you look at the ethnicity, then what we see in North East London is a large Asian population, 28%, white population 50%, and a black population around 12%. And this is not what we're seeing in the children who are presenting with coronavirus. So more than 50% of our cases were in the Asian population. And there was also a slight overrepresentation for the black population and a significant underrepresentation for the white population. I'm afraid I don't have any answers for you in terms of why that's the case, but it's just interesting to note that in the context of all the conversations we've had about the BAME experience of COVID-19. So what have been the unforeseen consequences? Well, late presentations have been a really big concern, and in fact there's a paper that's just been published in archives about this, which was a spot survey of paediatricians across the country around late presentations, and it does seem that this is an issue. There has been a significant number of late presentations and even possibly deaths as a result of people not accessing healthcare. And we have seen a persistent fall in A&E attendance, which is still going on even when lockdown has been eased. Discharge planning has become a bit more tricky. We have noticed increase in safeguarding concerns, which I alluded to in my earlier talk, and definitely an increase on mental health presentations, probably part and part because of the socio-economic distress, but also the isolation that lockdown has caused. So this is the current shielding guidance for children and young people. It was published by the RCPCH in June. Just at the top as a headline, children and young people who are cared for just in primary care are very unlikely to need to continue to shield. So I think that's an important takeaway message. The college has put children into very clear groupings and listed types of conditions. So it's worth going to have a look at the guidance if you've got a specific child in mind. But there are some notable conditions not on the list, such as diabetes and those on steroid replacement therapy. And what does it actually mean for the child? Well, they must stay at home and can't go to school. They must continue to attempt to socially distance at home, which can be difficult for some of our families. And consultations need to be remote if at all possible. So that's what it means for you and what you tell your young people and their parents. So I'm going to go on to the second part of this talk and talk about a case which may be a sort of familiar story for some GPs and certainly in the press. So this is an 11-year-old girl who has attended A&E with a 3-day history of fever and rigors. Her parents had measured her temperature as 39 on several occasions each day over that period. And in the last 24 hours, she's been complaining of abdominal pain and has developed diarrhea. She was nauseous, but was not vomiting. There is a history of COVID in the family at the start of lockdown, but everyone has now recovered and no one is otherwise unwell. When the child was assessed in A&E, she was noted to be shocked, tachycardic and febrile to 40 degrees. She had cervical lymphadenopathy and tenderness around her neck. Her abdomen was distended, tender, and she required fluid resuscitation, but did not have an oxygen requirement or significant breathing difficulties. Investigations, when they came back, showed that she was significantly anemic with a very high CRP, a low albumin, and abnormal liver function. She had a surgical review and they were concerned about possibility of appendicitis. The abdominal ultrasound showed free fluid and distended bowel loops. So what's the differential diagnosis here? Well, you might be considering sepsis or appendicitis or possibly some kind of vasculitis, such as Kawasaki disease, or even if the child was being managed in secondary care, we might be thinking about some kind of more unusual and more alarming conditions such as macrophage activation syndrome or HLH. But in fact, this child has a diagnosis of PIMS-TS, which I'm sure you have pretty much all heard of. So what is it? It stands for Paediatric Multisystem Inflammatory Syndrome, temporarily associated with SARS-CoV. That's a real mouthful. It's a shame it hasn't got a more straightforward name, but there it is. And the first case definition was actually produced by the Royal College of Paediatrics and Child Health in the UK, although cases had been identified in Italy and in the US before this. So here is the definition. Just important to note that SARS testing may be positive but could be negative. And a number of these children actually have positive antibody tests because this appears to be a post-infectious inflammatory process. And therefore, for many children, the active SARS infection has actually burnt out by the time they present with this disorder. I've just put a link there to the full definition if those want to go into a bit more detail, but the symptoms really mirror the case that I've just described. And you want to exclude any other significant cause, which could be explaining the symptoms. So looking at the epidemiology, less than 200 cases reported across the UK, and it seems it happens around 2 to 4 weeks after the infection, and that's illustrated by the graph below, mapping the cases. So the orange line is when the peak of COVID-19 hospitalizations occurred, and the bars describe the increase in cases which happened after this. It does seem to affect older children more than Kawasaki disease does, so that the average age has been about 9. And the likely cause is an exposure to a totally new antigen, which gives rise to this uncontrolled immune response. And it's the immune response of the patient which is delivering all of these symptoms, not the active disease itself. And it's interesting to look back at the peak of Kawasaki disease, which occurred during the 2009 H1N1 epidemic, because it looked very, very similar to this. So this is a list of the clinical and laboratory features. So the blue box describes how these children present clinically. The green box is really what you see in terms of signs on your examination, and some of the basic point of care tests. And then the third box is a description of what the investigations are likely to look like when you get them back from the lab. And some of these tests are tests we don't normally do in children. So D-dimers, troponin, BNP, these are all measures of cardiac activity, which actually as GPs, you're probably much more familiar with than we are as paediatricians. And we've been learning to understand them with this new disease. So the general picture is of a persistent high-grade fever, limited or no respiratory compromise, fluid refractory shock, extremely high inflammatory markers, and frequent cardiac involvement and dysfunction. And I think it's the cardiac dysfunction which has really alarmed paediatricians and has led to the significant morbidity with these children. The condition's been split up into 3 different phenotypes, which seem to be quite easily recognizable and distinguishable. So you've got the febrile and inflammatory phenotype, the shock phenotype, and the Kawasaki-like phenotype. And this is from a study which was done jointly between the Evelina and Great Ormond Street Hospital. And just a couple of other interesting points. You can see that disproportionately, children from Black and Asian minority and ethnic groups seem to be affected by this condition, and different for each of these phenotypes as well. So the shock phenotype seems to be the highest group for BAME patients. And then looking at coronary artery aneurysms, CAA, that seems again to be more represented in the Kawasaki-like group or the shock group. They all have a fairly high rate of evidence of SARS-CoV infection, and this could be clinical or related to the contacts they've had, or could be a positive test, whether it be an antibody test or a PCR. So this syndrome seems to be a hyperinflammatory syndrome, which has similarities to Kawasaki disease, toxic shock syndrome, and other syndromes such as HLH and even SLE. And there is a wide spectrum of severity. I've just put this slide in as a quick reminder about Kawasaki disease. So basically 4 out of 5 of the features below, but remember that young children can have incomplete Kawasaki disease and may not have all of these features. So what should you do if you're faced with a patient you're worried may have this problem? Well, the first thing to say is that they're likely to be unwell or deteriorating. So make an assessment using your normal ABCDE approach, and then send A&E and also alert the on-call paediatric team that they're coming and discuss the child with them, as the child may need resuscitation and may need specialised treatment when they arrive. All children should be treated as suspected COVID-19 positive, and so all the PPE precautions should be taken. So the pitfalls in the diagnosis would be lack of recognition and failure to escalate care if the child is misdiagnosed as having sepsis or potentially appendicitis, failure to prevent a coronary artery aneurysm with the appropriate treatment, but also potentially we may become worried that every child with fever, abdominal pain and elevated CRP has this condition, which is clearly not going to be the case. The current approach to treatment is IVIG and steroids, that's intravenous immunoglobulin, and that's the standard approach to treatment for Kawasaki disease at the moment. Some of these children may go on to get immunomodulatory drugs, and people have become a bit more familiar with these as a result of the recovery trial, which has mainly been focused on adults with COVID, but they are being used in children as well. You just need to know that there is actually no clear evidence base yet, and there's currently a study called the BAT study, which is looking at this. But also, lastly, remember most children to date have recovered. There's been 1 death in the UK, and the long-term outcomes are not yet clear. So here are the resources. If anybody wants to do a bit of extra reading, I don't know if there's been a poll. I haven't seen it come up, but that's the end of my talk.
Great. Thanks very much, Hannah. There are a few questions coming in that you won't have been able to see in the whilst you're presenting. So I'll deal with them as they've come up. So May has got a very good question, really, and I think it probably resonates with everyone who works in primary care. With this sort of autumn and winter looming, how are we going to manage children who just pitch up with a cough and a cold and fever? Is there an indication to swab everyone? Do we isolate? And what would you advocate for us doing in that situation?
I think it's been so difficult to keep up to date with this because guidance has been changing really frequently, and certainly early on in the pandemic we were having to check the PHE website several times a day in order to really understand where we were. I hope that when the next wave happens, we'll be a bit clearer and the guidance from PHE will be better. But I would still advise following PHE guidance, because I think otherwise it can get very confusing for clinicians and parents. Certainly, any child that comes to hospital now is swabbed automatically. So that happens on admission to hospital, and they are isolated until we have that swab result, which normally is taking about 24 hours now. So any child that comes up, that will be happening. I would hope that the CCG might be considering advice for GPs once more face-to-face appointments are happening in primary care, and that's something certainly that will need to be picked up, I think, across the country.
Yes, thanks for that. Of course, as you're right, as you say, we're still discouraging face-to-face contact, which again is going with the national guidance at present. But I guess May's point is that with the winter coming, those natural viruses are going to be circulating as well. Not that coronavirus is not a natural virus, but obviously the 19 is the key thing.
Yeah, I think the problem is that you're just never going to be able to distinguish. It's going to be almost impossible. Yeah.
No. Well, that's and that has been the issue throughout, really, hasn't it? That and that's why everyone has been so keen to make sure that the sort of social distancing and have been put in place. I think it will be difficult in a second wave to implement that, actually, but we are where we are, aren't we? So I don't know if that answers your question, May. I think we just have to wait for the guidance and follow it when it comes and take it from there. The lowest age that a child can have a COVID swab?
Oh, we're doing them on newborns.
All right, okay.
Yeah.
In the community, do you know? I think if you go to a drive-in, I think it is 2, but I'm not sure about that. I'd have to look it up.
I think the limitation might be that the nasal swabs are actually quite tricky to do in very, very small children. But the way that we've got around it in hospital is that we're still using nasopharyngeal aspirates in the really, really tiny babies. But I suppose that's going to be more applicable to the in-hospital setting.
Yes. Okay. Murray's answer is mentioning that 5 is the cutoff at the COVID hub that he works in. I got a feeling that the drive-ins may be 2, but we'll have to look that one up. And is there a comment on outpatients and referrals coming in Tower Hamlets? When are you back to normal or approaching a back to normal, or can you give us an update on the clinic situation?
So we've been accepting outpatient referrals all the way through the lockdown period. The only difference is that at the start, we were doing all the consultations pretty much by phone, whereas now we're gradually introducing face-to-face consultations back in. We're currently looking at trying to set up a system whereby we alternate face-to-face with phone consultations in order to manage the volume of children and parents in the waiting room. Interestingly, I think the COVID pandemic is likely to trigger quite a major change in practice in outpatients, and certainly as a general paediatric team, we're looking at that at the moment in terms of how we can be a bit more agile and deal with the GP referrals in quite a different way, which supports GPs but also is much more responsive for families. So,
yes. And of course the phone service and advice is still up and running throughout.
Yeah, absolutely.
Okay, another question is around something you touched on. So this is from Shailesh. A child with a fever and abdo pain could be viral gastroenteritis against the sort of PIMS TS clinically. Apart from the history of COVID exposure and rash, would it just be the severity that would make you consider the more serious condition?
Yeah, definitely. And as I said in the talk, there is quite a spectrum of severity of PIMS TS. So there's undoubtedly been children that we've seen who've not been that unwell and haven't required resuscitation and specific treatment, but it's the kids that have presented really significantly unwell that have worried people. And what I would say to GPs is that they should just manage them the same as any unwell child that they come across in their practice, and get urgent help and discuss with a paediatric team. I suppose the only difference is that if you've got some understanding of what this condition is, you may be able to discuss your clinical findings with the paediatrician and alert them to the fact this child may have the diagnosis when they're coming to hospital.
Okay, thanks. Alpa is mentioning that it's any age for the drive-in in England, but colleagues in Wales, who I know that we marginalised first thing this morning, I don't think you've still apologised for that, actually. It's different for Wales and Scotland.
History is pretty poor, and the geography as well, isn't it?
So one final question from Satish. Do you have any thoughts about reinfection of COVID-19 in children?
Oh, I think that's a really tricky one. The problem is no one knows. I think it's likely people can become reinfected. I think this virus is going to behave more like the common cold rhinovirus than flu. And I think that it's going to take quite a long time to build up the levels of herd immunity, which will mean that it's not significant in the community. So, but I think it's watch that space on that one.
Yeah, okay. So thank you very, very much for that, Anna, and the other talks. Really interesting, and especially the topical, the COVID talk. And I'm sure we all took something home from that. Thank you very much indeed.
Thanks a lot, Anna. Really lovely, and thank you for the COVID talk, Anna. Last minute, but thank you. Phil, the next session, I think so. We have invited 5 panelists to interact with you, because it's not fair for me to be talking about what happened and how did things go. It's result time for us in one sense. Once that's done, I'll do the finishing comments about videos and certificates and all those things. So we're going to get all our panelists, if they turn their, all our delegates who are now panelists, if they turn their videos on, and we can have a quick 5-minute session with you.
I'm riding my bus.
I'm loving the extra sound. That's a beautiful laughter going on.
This is the only way we can interact with our delegates. So, what do you feel?
Okay. Well, thanks to everyone for presenting today, and thanks especially to everyone who did a talk and moderated. But the main thanks, as ever, goes to those of you who've taken part and experienced the event. I think all of us were slightly apprehensive about how it might work. Certainly, we spent a few sleepless nights thinking about whether it could work online, but I think today has been a testimony really to the fact that it can work, and well done to everyone for sticking it out. I was looking at the numbers, and very few people have dropped off, and of course some people will have to have gone on to other things, but amazing retention throughout the day. I'm just thinking, if there are any questions or specifics in terms of feedback, please do put them up in the Q's and A's. But broadly speaking, we've had some very positive feedback from trainees in Tower Hamlets today, which I've passed on. And certainly I think the chat and the questions and answers have worked very well. I was a little bit worried that it wasn't going to be as interactive as it might be if we were face to face, but I think it's worked really well. So well done to all.
So Anusha wanted to say something, and then we can get each and every delegate to just talk for a minute. Yeah, Anusha, over to you.
Hi there. Hi, I'm Nisha Tatani. I'm a training program director at West Herts, based at Watford Hospital. That's my daughter in the background who you can hear making lots of noise. Quite fitting for a day on paediatrics, I think. Yeah, I just wanted to thank you very much for such an informative day. I thought the breadth of topics that you covered was actually quite amazing. I don't think I've ever been to a study day where such a range of topics has been covered. And I really liked the 10-minute length for all of your sessions as well. And what I find really interesting is that as a GP, we're used to dealing with one problem in 10 minutes. So I really like the way that you dealt with like one problem in 10 minutes. It kind of reflects what we do on a day-to-day basis. Really good for engagement and attention as well. And also thank you for including safeguarding. In the last year, the rules for both trainees and GPs for appraisal has changed with safeguarding in terms of what we have to do on an annual basis. So it's really good to get a safeguarding update. And the mindfulness or the wellness was great as well. I thought the neck exercises, now we're on our telephones all day, was very, very useful. I'll be doing that again, I think. So thank you very much for that. So thank you for inviting me along.
Thanks, Anusha. Whoever wants to go next, Vishal.
Yeah. Well, I'll just voice what Anushka said as well. I think very well organized, well done, Akshay and team. Very, very well organized. And I think most of the topics, you know, probably all of them, right from constipation to 6-week check to asthma to allergy to failure to thrive to vitamin D, safeguarding, COVID. I think all the topics were so close to home, so real to general practice, so real to primary care that we see every day. So brilliantly done. And I must say, this is all new to all of us. And I was thinking technology is something which will fail us sometime, but hurrah, well done. It's all done.
I'll tell you something. I'm total
IT
illiterate, and the person who is here is with no social.
Well, kudos to
this is Jeremy.
Guy.
This is because of him.
Yeah, kudos to this guy. Then brilliant. I think there was not even one single hitch. Brilliantly organized, Akshay. Well done. I think your whole team should pat your backs today. Very well organized. You're going to get a brilliant feedback from everybody.
Thanks,
and good luck.
Thank you. We've got Pooja.
I think Anusha and Vishal, they have said everything that I wanted to say. Probably congratulations and really, really well done. So very relevant topics. I've attended lots of pediatric day courses until now, and this was one of the best ones. So, and with the technology, actually, it makes us wonder, isn't it, whether this is the way to go forward now, because all the travel time and everything. Because I work in Southampton, Hampshire, so I don't know. Honestly speaking, if I would have commuted to London just for this course, but this is actually, you made it accessible to me. So that's actually worked really, really well. So thank you very much. and really, really helpful course. Thank you.
This is a bit of a paradox. COVID had a lot of bad things, but it was in one sense a boon for us, because we initially were going to have 80 people. We managed to have 250 of you, which was
I
not going
know.
to be possible. So, and IT
Look at the silver lining. There's always a silver lining, Akshay, isn't it?
we got Shivam.
Yeah, hi. Thank you very much for hosting. I think I really echo everything that everyone else has said. I think, having something like this during COVID, I think a lot of, as a GP trainee, a lot of the training has sort of, come reduced quite a lot. So it's been quite nice to have some sort of training during this time. And like some of the guys have said, it's been a really wide breadth of topics, which covered so much of pediatrics and general practice, which I think was amazing. And I think, credit to you guys for, initially this was meant to be a face-to-face type of course. And I think it's pretty amazing that you've managed to adapt it so well on a virtual format. And thank you for sending the slides in advance. That's actually makes it a lot easier to be able to follow through the presentations. So well done, guys. Thank you very much for hosting this.
Thank you. And we'll give the last word to Nikki, who was our first registration. So Nikki, I know your video is not working. Off to you.
Just to echo everything that's already been said, thank you guys so much for today. It's been really, really great. I'm a little bit knackered, not going to lie, but it's been really, really helpful. So yeah, thanks very much.
Excellent. Look, we could not have a photo with everyone, but we have representation from the delegates, from all my GP colleagues and my lovely presenters. So we could just, I don't know what we do. A big smile and we take a photo. Okay, 1, 2, cheese. Excellent. So I'll just wrap up quickly. Couple of things. One, the videos will be made today and tomorrow. So Jeremy will work on it, and we'll use a platform, and I'll share it with you so that you can have access to the whole talk at your leisure. The thing which we want is feedback, please. This is like our exam, and we want the results. Whatever the results, we will take it. Give us feedback so that we can make positive changes. We will also send you the certificate of attendance. This course has been approved by the Royal College of Paediatrics for CPD purposes. The next course is on the 10th of February. So we've had the courage to declare the date just because I think we should. And I think this webinar format is going to work. So please spread the word with your colleagues and everything if you've enjoyed the course. Any questions, any queries, please send it to me. There were some queries about PDFs, and we'll try and get more PDFs, send across to all of you. Anything else in my list? Well, nothing.
Phil, anything from
Dr. Naik, you're saying something.
Could we please have a round of applause?
No.
I'd like to thank you to Akshay, actually, on behalf of the speakers, the moderators, and the attendees, that actually this has been your brainchild. You've done amazingly well. I think it's going to be superb feedback and a good way forward. And of course, a special thank you to Jeremy, but most of all to Akshay. Well done.
Can we have a round of applause for Akshay, please?
No. Well, I think, I'm a cricketer, and the captain is as good as the team. I think so. I had a brilliant team. I just did not have to do anything here. Brilliant delegates, brilliant GP colleagues, presenters outstanding. So, it was an easy thing for me. Phil, last word from you before we close the talk.
Sorry, I was just trying to paste the feedback form up. It was a brainchild that you put forward that has really worked, and I just echo everyone's thanks to you and in particular, but to everyone who's taken part. Actually, it's really rewarding for us in primary care to work so closely with such committed colleagues in secondary care and break down some of those barriers which sometimes are inadvertently set up. And I think today we've had a really generous spirited day of learning together, and it's worked. So thank you.
Rob, anything from your side?
Well, what can I say? We started the day with the stool chart and ended with COVID. I mean, that just tells you, doesn't it? We've just covered an umbrella of stuff, all massively relevant to primary care. I think, you know, this is the way we're doing a lot of consulting now anyway. So we're having to get used to virtual courses, learning, continuing professional development. So, you know, we've tested it, we've proven that it works. The initial feedback that I'm seeing on the chat bar looks really good. So credit to everyone, and thanks very much for allowing me to be involved. It's been a great day.
Brilliant.
Excellent. I don't know how you end a webinar. What do you do?
That's the question.
Say goodbye and wave, actually.
Chin has something. Chin.
Sorry I wasn't really be able to be part of it because I've been attending today, but everyone was brilliant. Do we have a limit on attendees? I don't see why we should have, but do we?
So it depends upon what package you have. We've taken the 500 package. So Zoom has the 100, 500, and you can scale it up. So it depends upon, well, I mean, we were happy with initially 80 and 100, but I think so the response was phenomenal. So yeah, I mean, there's...
For what it's worth, I did Infomed last month, and they had 12 attendees, and that was a really popular course. 12. So you really have, or we really have, hit a market that was struggling and done really, really well. And if we can hit 200 now, and the feedback comes out, there's no reason we shouldn't hit 500. I don't know whether there's, you know, it's just publicizing it in the right way and delivering the right content. So it depends on the feedback, I guess. But really well done, everyone. I wanted to stay and listen to more. Sandy, you sounded like a really, really, really lovely maternal auntie when you were presenting.
But the point is, I think so the content is going to be the king. I think so we have to, the purpose of the course is to ensure that we help our primary care colleagues so that they manage cases. We do not want referrals in the hospital. That's the sort of basic point here. Secondary care with the new sort of system is not going to cope. So more our GP colleagues are confident in dealing with things. I think so that's what is going to be the clear indicator. If we manage to even reduce referrals by 10 per person, we have 250 delegates. That's 2,500 referrals gone down. And I think so that would be a mark of success rather than anything else. That's what I would look at. And that's what our aim here would be. Because this sort of engagement with primary care, I mean, this is amazing. I mean, we have a WhatsApp group with 8 of our GP colleagues. I mean, never had that sort of a group, and the sort of cohesion, the coordination was second to none. And this is not like we knew any one of us. We actually knew everyone once we joined the group. So I'm feeling sad actually because till yesterday I was not sleeping, and today I'm feeling what am I going to do tomorrow? Well,
Sarah Brown heard the talk over my shoulder, and she was watching and said that the organization of this, and you guys have done, I mean, I've just been sitting on the shoulder watching and not really engaging too much in the organization, was so much better than the King's respiratory talk, which has been going for several years and is massive.
I'm not going to take any credit here.
What you've done, what you've put together compared to what's out there has been superior. It's really quite impressive.
I mean, I would say the ideas of this doing a pre-recorded came from Amit. Tessa gave the idea of making the short talks of 10 minutes. So I'm going to give all the credit to those people. And then it was Jeremy. I have absolutely got nothing to do. This is all these people who've given the ideas. I've just tried to put it in, get feedback, and it's worked. It's worked. Hopefully the feedback will tell, I mean, how it was, but
yeah, well, let's see. Yeah,
absolutely.
Okay.
Anything else? Shruti, Dan, anything before we wrap up? The pillars.
No, just a big thank you to Akshay and also all the presenters as well. It's been a great team and everybody's came together. I think, yeah, produced a really good, informative day.
Shruti?
Agreed. Massive thank you to you, Dr. Jain, and to every single one of the speakers. I think we've hopefully achieved our main goal of really helping to empower our primary care colleagues with the topics that we've covered today. So, great job.
we've just had a question about certificates. Yes, please.
Okay, actually, I think before you get any negative feedback, you need to wrap up and just tell them how the delegates had to get certificates.
I'll be sending it all to you. So give me a day and it will be with you. Before we finish, last word from Jeremy. I think so. He's done the main job and we've not heard from him.
Well, thanks very much, Akshay, for giving me the last word. There's not too much to add. It's been great working with you all. Fantastic job. What great collaborative effort. Again, my job very easy because all of you guys just really pitched in and did your bits great. So thanks again. And I think we'll leave it there. We'll see you all again soon, hopefully.
See you all soon. Well, I'm not going to say drive safe, but stay safe in this virus environment. And thank you, everyone.